I'd like to welcome you to the BTOG Thymic Malignancies Essential Update. This is a real pleasure to be chairing this session and taking part in this study day looking at thymic malignancies. And I hope that you will find it both interesting and stimulating. Just a few general housekeeping points. On sponsorship, the sponsors of BTOG events don't have any role in the planning or content. If you need anything throughout the day, please use those links to the executive team, Dawn and Gina, and I'm really, really grateful to both of Dawn and Gina for helping support the study day and also the Thymic Specialist Interest Group, which I'll talk to you a little bit about. And we'd really like you to submit questions about the talks or any discussion items that you'd like to raise. So type your questions via the control panel on your link, and we will pick these up and hopefully use them in the panel discussions at the end of each session. As ever, we'll send you an email so that you can give your feedback on the day, and once you've done that, we will send you a certificate of attendance, which is approved for CPD points. So this meeting has really arisen out of the BTOG Thymic Malignancy Specialist Interest Group. We know that tumours of the thymus are rare, but they are a significant part of thoracic oncology. And I think, certainly from experience, I know that people are the understanding of thymic malignancies can be sometimes poorly understood. And so the BTOG, I'm really grateful to BTOG because we set up a group, a multidisciplinary group of interested parties. It was very much stalled after or during COVID. The first meeting was at the last in-person annual meeting in Dublin in January 2020. And then everything, of course, went a little bit pear-shaped because of COVID. But I'm grateful to Dawn and Sanjay from the BTOG management for really trying to rekindle the interest in thymic malignancies. And we've got a pretty wide and multidisciplinary membership of this group. I'll show you in a slide later. But the aims of the group are to promote the understanding and to improve the knowledge of thymic tumours and to work cooperatively to improve the pathways for this, this very important group of malignancies. This is the agenda for today. And I think that you will see that we have covered or tried to cover every aspect of the thymic pathway. But one really, really important function of this meeting and this day is to try and look and see how we can improve across the UK the management of thymic malignancies and move forward in this. And I hope that by the closing remarks at 4 o'clock this afternoon, we'll have some really good avenues that we can explore into doing that. So this morning, the first session is about an introduction and overview to thymic malignancies. I'm David Gilligan. I'm a consultant oncologist in Cambridge, and I've been interested in thymic malignancies for a number of years. And in this session, I'll also be joined by Abigail Galt, who's a medical oncology trainee in Newcastle, and Stephen Robertson, who's a clinical oncology trainee in London. And I'm really pleased that we can involve trainees because the Notch group of trainees, a national group of oncology trainees, have done some really good work in looking at how we treat thymic tumours in the UK at the moment, and they're going to share that with you. So that will be our first talk. And then secondly, I'm really, really pleased that we have Karen Ruddock, who is chair of the Thymic UK Patient Advocacy Group. And Karen is someone who was diagnosed with stage 4 thymoma a few years ago and looked around and couldn't see anyone or any information to help or support her. And she set up the Thymic UK group, which I'm sure she'll give you some more information about, and how this group has helped stimulate discussion about thymic tumours in the UK, but also is very much part of the BTOG specialist interest group. So these are my disclosures, and I'm going to open by saying that May happens to be Thymic Malignancy Awareness Month. So I think it's really, really appropriate that we have this meeting at this time to basically increase awareness, and that in the UK through BTOG we are doing our bit to do that. As I said, we set up the specialist interest group originally in 2020, but sort of rekindled it at the beginning of this year. And it is really a multidisciplinary group of many, many individuals, including trainees, including the patient advocacy group. And again, I'll talk a little bit about the more extended MDT that might be relevant to thymic tumours. That's maybe a little bit more than you would normally have in your thoracic oncology group. And as I said, I'm very pleased that we are supported by Dawn and Gina and the BTOG Secretariat to do this. So one of the things a number of the aspects I'm going to cover this morning is the epidemiology of thymic malignancies. Is it getting more common, or why are we seeing, or why do we think we're seeing more cases? One of the big issues, I think, in talking to people about thymic tumours is that people do get a bit sort of puzzled by the staging and the pathology and how it all fits together. And we're going to have a number of talks today, but one of them is going to be on the pathology, and I'm hoping that will clear up a lot of questions that people have about the pathology and how that integrates with stage. And as I said, with thymic tumours, we sometimes have to rely on other disciplines and then more extended MDT, because we know that thymic tumours are associated with other medical conditions, and these can be they're very important that we discuss and acknowledge how these can be managed in along with the thymic tumours themselves. And then finally, I'll just sign off with what exists at the moment and how we might want to increase support and networks for the management in the UK. So, first of all, are we seeing more cases? And this is a piece of work that I did with Public Health England, as was pre-COVID, and NCRAS. And it really arose because in our MDT, we thought that we were seeing many more cases than we should. Because if you look at the ESMO guidelines, and I'll come back to those later, the incidence is about 1.3 to 3.2 tumours per million of the population per year. And so that would equate to a range of certainly under 200 new cases in England per year. And this just didn't seem right, that we in our MDT were seeing, and we were an MDT that was of a certain size in East Anglia, far more than we thought far more than that would predict for the general population. And also, and Karen, I'm sure will talk about this, patients with thymic tumours were saying to us, look, nobody knows about this. My GP hasn't heard of it. No one's heard of it. Please, can you help? And more patients were sort of looking for information. So a lot of it, if you look back at how that came to be, if we look at coding, which is a way of recording tumours, and because thymic tumours are unusual and their behaviour is perhaps not typical with some compared to some tumours. Pre-2000, thymomas by cancer registries were considered benign and not recorded unless it was felt that they should be recorded. And then in the first decade or so of the 21st century, there was a gradual switch in coding from benign to malignant. And then since 2016, almost all cases have been graded as malignant. And this slide shows work that, as I say, we did with Public Health England, looking at the number of cases. So if you see back in 2001, there are maybe only about 75 cases recorded in England. This is for England, I have to say. But through the first 15 years of the 21st century, we can see that these have increased, and in 2016, around 275 cases were recorded, which already puts that incidence rate up for England to 4.9 cases per million. And so 2016, so that's now 6 years ago. And you can see from the graph there's a very much an upward trajectory, and I'm sure that we can get more data from Public Health England and the registries to say that this is becoming, or at least it's being recorded as being more common. So why is that? Well, I think one reason is that we are doing more imaging. A lot of the presentation of thymic tumours are incidental findings, and you can see highlighted on that CT scan image on the left, there is an anterior mediastinal mass typical of a thymic tumour, which is probably not causing any symptoms as it sits there in that image, but someone might have had that image because they're having an examination for something else, be it another potential malignancy, be it trauma, be it suspected pulmonary embolism. And you can see on the right a graph from diagnostic imaging data set from 2017 in England, showing that there is really, as we all know, a massive increase in the number of CT scans that have been done, and so that we will be picking up more of these tumours. And this is also supported by some surgical data from the Society of Cardiothoracic Surgeons, and I'm very grateful to Doug West from Bristol for providing me with this. And this is, again, pre-COVID data, but you can see, and this is important, this is not comparing directly with what I've said before, because this is data for UK and Ireland, not just England. But if you look at their data set, which is a very good and accurate data set, if you look at the red arrows on that graph, the bars that are indicated by highlighted by the red arrows are patients who've had thymectomy for thymomas. And you can see that in 2014, 2015, there are already over 200 cases of resected thymoma. And so that doesn't obviously include cases of more advanced disease that are not resected. And then just updating this for 17-18, from the same data set, you can see that already that's risen to 334 cases of thymectomy for tumour. And I'm sure we will look into this in the session looking at the surgical management of disease, that back in 2017-18, the majority of cases were done by open surgery, but there is now certainly a move to more assisted surgery, either VAT surgery or robotic surgery, sometimes called RATS. And I'm sure that will be part of the discussion today in the surgical sessions. One other, I think, thing that makes people nervous about thymic tumours is the staging. And there are, I suppose, two staging systems that people need to be aware of. One is the one that's been around for quite some time, which is the Amasaoka staging system, which goes from 1 to 4. And is relatively easy to understand because it's talks about the encapsulation of the tumor and whether it's spread from the capsule to other places. But it is a surgical staging system and relies on knowing what's happening with the resection of the tumor. And so it doesn't correlate exactly with survival. So the TNM system, which is listed in the table on the right, has been used because that more accurately correlates with survival, but it is a little bit more complicated. And you will see that on the bottom third of the graph, the stage grouping, stage 1 in TNM actually equates to stage 1, 2, and part of stage 3 of the Masa-Oka-Koga staging. So it can be complicated. However, we do know that the Masa-Oka-Koga stage is still quite widely used, particularly because thymomas have, as we'll see, the overall survival is done over many years, so the data predates the TNM. I think, as with most things, we'll get used to TNM and Masa-Oka in parallel. Pathology we're going to hear about later, and again can be the source of some mystery. But if thymomas are staged by a histiotype A, AB, B1, 2, B3, and also thymic carcinoma is type C. And this is a series from JTO from a few years ago, and you can see that the breakdown is the numbers in this particular series. Most are type B tumors, but there are a fair sprinkling of A and AB. And looking at the age spread, it's around about 50 to 60, but you can get people diagnosed with thymomas as young as in their 20s and old as in their 80s. And also, we'll find out more about associated conditions, but you can see that in this particular series, the percentage of patients with myasthenia gravis, which is probably the most common paraneoplastic syndrome, ranges from around 20 to 50%, depending on the histological subtype. The graph on the right, I think, is help illustrating the spectrum of stage distribution and aggressiveness, if you like, of the tumors, so that you can see that the A and AB, there are more stage 1 tumors in that grouping compared to the B grouping, and particularly as you go up to stage B3, which are the more on the malignant spectrum, that you see more advanced stages. But I think one really positive and important part of discussing thymic tumors is the survival rates. Now, most of us work within the field of thoracic oncology, which is really centered around the treatment of lung cancer. And if we were to have these survival figures, I think we'd be feeling really very pleased that things had improved. So thymic tumors, the majority of them are early stage, the majority of them are managed surgically, and the majority of them are cured. And we talk very widely about 10-year survival rates. And you can see from both the table on the left and the graphs on the right that survivorship is really, really excellent. And I think that is very important, that we convey that to patients who've been diagnosed with thymic tumors. And even the stage 4 tumors, you can see 10-year survival rates, which, although we're making massive improvements within the field of lung cancer, these figures, I think you can see, are particularly impressive and good and positive, and hopefully we can work on them and improve them even more. And so that really just, I think it's always important to try and look at clinical examples, and that because most of us work in the field of lung cancer, thymoma is not lung cancer. It is a different disease, and important to realize and discuss that. So this is an example of a patient of mine who was diagnosed in 2007 with a stage 4A. So that's an advanced tumor with pleural disease. And they had chemotherapy up front, but back at diagnosis, you can see on this scan, which is from 2012, so that's 5 years after diagnosis, there is a considerable bulk of disease in the mediastinum, which you might expect might be causing a lot of problems and a lot of symptoms. But actually, this person was fully active, was fully functioning, was walking around. You would never know that they had this volume or bulk of disease within their chest. And although the disease progressed and they had further treatment for progression, they had some radiotherapy for superior vena cava obstruction in 2013, and then they had further chemotherapy in 2014. This CT scan 4 years after the one on the left, and 9 years after diagnosis, shows significant disease. It has progressed, but they remained extremely well. Sadly, they did pass away over 10 years from diagnosis, but I think it's really important to understand that this is a very, very particular disease, and that people can be fully functional, walking around with significant bulk of disease, and that needs to be recognized. And because of that, and because of the other conditions, I think it's important that when discussing thymic tumors, and most of them will be discussed in a thoracic oncology MDT, that there is an extended team. And you can see here, I've put in grey the disciplines that you might expect to be involved in an extended team or MDT. But particular to thymic tumors, we have to add in the expertise and knowledge of other MDTs, particularly neurologists looking at mainly myasthenia gravis, but other neurological symptoms, and we're going to hear more about those later on today. Hematology, pure red cell aplasia can be a problem, and that can be managed and is managed by hematologists, and it's important that we liaise with them, and also immunologists. Good syndrome and immunodeficiency is associated with thymoma, and sometimes it's not the thymic tumor that is the problem, it's management of the other neurological conditions. And I have many patients whose thymic tumor is, the actual tumor itself is stable and under control, but you need help from others to manage these associated conditions. And so in doing that, that does sort of really introduce how in the UK we might improve this model. If we look across the English Channel to France, the French are probably quite far ahead in doing this. They have what's called the Thymic group, which is a national group of 14 centres, which I've marked on the map here, spread pretty evenly across the country, and all cases are discussed within the MDT, which I think are held a couple of times a month. They have two, if you like, super specialist centres, one in Paris and one in Lyon, and they have agreed protocols, they do research, they pool their knowledge, and through the national, and it's a nationally approved network, they have this network where they can discuss difficult cases, but they're all managed either if they're very difficult in those particular centres, or they give advice to other centres, and that may be a way that we can look at for the UK. There are other groups, and certainly we've had some contact from Italian groups. And again, we should perhaps, one of the outcomes of today's meeting will be how we move forward and having a model for the management of thymic malignancy in the UK. And I think it's important to know that we also have existing information and help. And so I would stress that there are resources available now that we can use. And these are some of the resources that I have found extremely useful. ESMO, through its clinical practice guidelines series, and Nicolas Girard and others have produced Thymic guidelines for the diagnosis, management, and follow-up of thymic malignancies. And these are available on the internet. Just Google ESMO thymic malignancy guidelines or ESMO thymic guidelines, and you'll get the PDF of the Annals of Oncology paper, which is an incredibly useful, sensible resource to use. ITMIC, which is the International Thymic Malignancy Interest Group, is an international group who hold a very interesting, important annual meeting. This year it's online, unfortunately, but nevertheless a very useful resource looking at the management of thymic malignancies across the world. And if you look on their website, they have some very interesting information and resources which for both professionals and patients. And finally, Thymic UK, which we're going to hear about from Karen later in the session, is the patient advocacy group, which is based in the UK. And I think that's really important for our patients in the UK, that they feel that there is a group that is relevant to them, that they can tap into and get advice and information from. So I hope that really gives you an overview of what thymic malignancies are all about and how we might be better able to manage them in the UK going forward. I'm going to hand over now to Abby, who is going to talk about a survey that she and the Notch group of trainees did. This will, I think, be a very good baseline from which to move on. So thank you very much.
David. So yeah, myself and Stephen Robinson will be talking through kind of two projects that we undertook within the National Oncology Trainees Research Collaborative for Healthcare. So the first of which is this was my project looking at the clinical features, management and outcomes for patients treated for thymic epithelial neoplasia, which I'll refer to as 10 in the rest of my talk. So I'll update on the results from that sort of UK multi-centre series, and then I'll hand over to Stephen, who will talk about a survey that we've undertaken following this on radiotherapy specifically. So just to give you a little bit of background about this, I had seen a patient with advanced thymoma, and I was really disappointed, unfortunately, when I did a literature review in the quality of the data that was available, because it was predominantly single centre retrospective series. And there were actually very few from Northern Europe, so quite a lot of studies from other areas internationally. And although we have the guidelines, they predominantly exist on the basis of expert opinion and these small case series that are out there. So I was really keen to look and try and improve outcomes for patients by understanding what's happening within the UK a little bit more. So I set up a local audit, got governance approval and things like that, and then pitched to Notch, kind of spreading this out across our network, which at the time was just Northern. We only had 7 centres across the north of the UK involved at that point. So we'd identified just over 300 patients with 10. Of those, we had 226 with thymoma, 83 with thymic carcinoma, and 7 with a radiological diagnosis. And this was over a 10-year period from 2008 to 2018. Of these, the gender split was pretty equal for both thymoma and thymic carcinoma, and the average age of diagnosis was early 60s, which fits with the data David was outlining as well. The wedge pie here sort of shows the number of patients coming from each of the treating centres. So these are the centres that were involved on the right. And the vast majority, as you can see, came from the Christie in Manchester. We did look at sort of presenting features that patients had, and as David alluded to, the vast majority were picked up incidentally, so 29% of thymoma and 19% of thymic carcinoma. And I think that reflects the huge amount of imaging that we do nowadays. But they weren't the only presenting features. There was actually quite a wide variation, but the most common 3 symptoms that we identified were pain, dyspnea and cough, with dyspnea being the most common, which 26% of patients experienced. So I just wanted to kind of give you a bit of a feel for flavour of what we saw from this 10-year case series looking at the diagnostic workup. Sorry if this is coming up a little bit blurred, it is for me, but it may just be the quality of the internet connection. But basically we have thymoma here on the left with the number of patients and percentage, and thymic carcinoma on the right. So you can see that the vast majority of patients did undergo CT imaging. For PET CT, there was a slightly higher proportion of thymic carcinoma patients that underwent that, but within our data series, actually very few patients underwent MRI imaging, which was quite surprising to us because it is recommended in the guidelines for borderline resectable tumours to kind of identify tissue planes more clearly. So that's something that was a bit surprising. And looking at the groups by stage, the vast majority of the thymoma patients were with sort of early stage disease, and most of the thymic carcinoma patients were quite well spread out, but the biggest group was the stage 4 disease. So we looked at the different management strategies. So for curative surgery, this was actually, upfront surgery was the treatment of choice for most patients. So 89% of thymoma and 61% of thymic carcinoma received upfront surgery. And that was mostly total thymectomy. But we were quite surprised that we also saw quite a high margin positivity rate. So 41% for thymoma and 59% for thymic carcinoma. And as you'd expect, the rate of R0 resections fell with increasing stage. So that's kind of in keeping with what you'd expect. But some of the other sort of international tertiary centres that had reported their data sets, their resection margin positivity rates are less than 20%. So this is quite surprising to us. But we didn't actually in the project set out to look at this in detail initially. So we can't understand the reasons behind this because we didn't collect data on that specifically. But it is very interesting that within an unselected NHS population, these figures are higher. So we also looked at radiotherapy dosing for curative radiotherapy regimens, which was in the main given as adjuvant radiotherapy. They were just a single patient treated for both thymic carcinoma and thymoma with just radiotherapy alone. But we wanted to see kind of the range of doses and fractionation given for these diseases. It's actually flips, the thymic carcinomas on the left in this slide and thymoma on the right. But you can see there was quite a sort of heterogeneous approach, quite varied in terms of the dose and fractionation that was delivered. For thymoma, you might say that perhaps more patients received a dose within the 45 to 50 gray region. But for thymic carcinoma, it was much more spread out, perhaps the vast majority receiving about 50 gray, but again, some centres giving up to 60 or down to sort of 40 gray. So this is something that was very interesting to us and prompted kind of Stephen's project, which we'll go on to talk about shortly. So we also looked at systemic anti-cancer therapy that was given, and we split this out into first line, second line and beyond. I'm just showing the first and second line data for now, but for those patients that were treated with this first, the vast majority received platinum etoposide doublet, which is what you'd expect. That's what the ESMO guidelines recommend. So that was all very much in keeping. And I'm conscious of time, so I'm going to wrestle through these, but these are our overall survival Kaplan-Meier plots for thymoma on the left and thymic carcinoma on the right, with just overall survival for all comers across the top and then by stage across the bottom here. And we did see that our median overall survival for thymoma was 123 months, with just 89 months for thymic carcinoma, but that is actually slightly better than what's reported in the literature. For thymic carcinoma, it was around 67 months that we'd seen from previous studies, so perhaps slightly improved outcomes, which is positive. So just to go on and talk a little bit briefly about paraneoplastic syndromes, this was something that we had an interest to look at in the study as well. So we had 90 patients out of the 313 that developed 101 paraneoplastic episodes between them. So as you can tell, some patients had more than one episode, and about 17% resolved after tumour treatment. there were 12 patients that developed recurrent paraneoplastic disease. And a personal interest of mine was looking at patients and trying to see if we were testing really for good syndrome. So only 34% had immunoglobulin levels checked, and the ESMO guidelines recommend testing all patients with thymic masses for this. So this is potentially something that we could very easily improve with just a simple test. So it's something that you could even take away from today and look at your own practice and see if you can kind of push that a little bit higher. I have to say, in the early stage thymoma patients, the rate of checking this was slightly better at 40%, but I'm sure there will be some cases where it hasn't been checked and potentially could be missed. It has such a big impact for patients if it is picked up and can be treated with IVIG and things, that they can stop having recurrent infections. So even though the chance of picking it up is low, it's still definitely worth looking out for. And we were quite surprised that out of the 14 patients with hypergammaglobulinemia or recurrent infections, only 10 of those were actually managed by immunology and had some input into their care. We also looked specifically, obviously myasthenia gravis was an area of interest as it's most common. So that was 21% of our thymoma cohort and 8% of the patients with thymic carcinoma. So we actually, the incidence overall was 18%, which is slightly lower than has been reported in some other studies. And we had just a 22% resolution rate in that group. So quite useful real world data, I think, to kind of chat about with patients if you do have anyone with those coexisting conditions, are really helpful to kind of guide those discussions. So I'm just going to kind of wrap up my section and then I'll let Stephen take over. But basically, I think our study is one of a handful of Northern European studies, and because we've actually collected data from 7 centres, it's one of the largest studies more recently. As you can see, we had a slightly lower incidence of myasthenia gravis, which could just be by chance, or it could be related to our population locally. We did see the low staging rates in terms of MRI, which potentially could have factored into the surgical resection margin rates. Potentially, if we're not doing enough imaging, that could be why those were slightly higher. It's a shame that they are higher than internationally reported results. I'm sure that those international reports are from selected groups of patients. I'm sure that factors in, and I know we do very complex surgery within the UK as well. So this is definitely not to discourage the surgeons out there, but it is interesting, and I think it's an area that is definitely ripe for a bit more review and research. And definitely we felt there was kind of a lack of radiotherapy consensus in terms of dosing, but also in terms of utilization. So actually less patients that were eligible for adjuvant radiotherapy actually received it. So there were 53 patients that were eligible that didn't receive adjuvant radiotherapy. And obviously I know stage 2 can be quite a controversial area. So we did look in the detail at that group, but actually only 33 of those were stage 2. So there was still a group of patients that potentially were eligible for adjuvant radiotherapy that didn't receive it as well. So that's something would certainly be interesting to consider, whether a UK guideline or a consensus statement might help in terms of looking at that in a bit more detail. So I definitely think this is an area that's ripe for research. And I'd just like to thank all of the contributing centres who shared data into this project. And I'll let Stephen take over and tell us about the radiotherapy survey following this. Thank you.
Thank you very much, Abby. My name's Stephen. I am a clinical oncology trainee based down in London, and also part of Notch. My interest in thymoma and thymic epithelial neoplasia is kind of built out of the discussions regarding radiotherapy as highlighted by Abby, and then also through attending an operational development network meeting in the south of England, which had 2 case discussions on thymoma and highlighted that there was no clear understanding or agreement between the centres. So following that, we developed a radiotherapy survey with some input from Dr. Gilligan, which has been sent out across the country and is still currently open for responses. So So far, we have had 32 responses from complete responses from 60 from the 60 radiotherapy centres within the UK, with a further 11 partial responses for a total of, 43 responses in the country. I will be highlighting and discussing the data from the 32 complete responses in this presentation. So we were initially trying to work out who were the people treating this condition, and it turns out that in general, most commonly there is a single oncologist at each radiotherapy centre who is focusing on thymic epithelial tumours, with a huge range between none all the way up to 12, depending on the size of the centre. As can be seen in the first bar graph, there is a huge range of the number of cases that each centre treats per year, ranging from 0 to 1 all the way up to more than 20, which kind of highlights that there may not be a huge amount of expertise in managing this still relatively rare cancer, but that there are some centres which obviously do have some experience. Reassuringly, most centres are aware of the ESMO guidelines and attempt to follow these guidelines within their practice. But most centres do not currently have a lead clinician with a specialist interest in thymoma, with only 22% of centres having an identified clinician, with even less having a CNS with a specific time set aside for thymoma of less than 10% of centres. There is slightly more centres which have a neurologist with a special interest in thymoma, importantly, given the known association with myasthenia gravis, but this is still less than a third of centres which have this availability. So, as discussed by Abby, there are a number of different investigations which can be used for the workup and staging of thymic malignancies, and slightly differently, it seems like there is an increased number of centres which are willing to consider an MRI scan of the chest as part of the diagnostic workup. So that is 16 out of the 32 centres, so about half of centres would be considering an MRI scan of the chest, and almost all centres are performing either a PET CT or a CT scan of the chest and abdomen with contrast. As highlighted by David, there is a significant variation in the different staging systems used, with currently the majority of centres still using either the Masaoka or the slightly updated Masaoka Koga staging, with a significantly smaller proportion using the TNM, and only 1 in 5 centres using either a different staging system or both the Masaoka Koga and the TNM staging. Currently, significant majority of the patients are being discussed in a local MDT alone, with only one centre which has or 2 centres which have a thymoma specific MDT or a thymic interest group, and a smaller number of patients who get discussed at a regional MDT. In regards to the radiotherapy planning, the majority of centres say that they don't vary their target volume based on any of the clinical descriptions, with a smaller proportion saying that they will use slightly different volumes depending on whether it has been a complete or an incomplete resection, and a smaller group again saying that they occasionally do different volumes depending on the stage and the histological subtype of the tumour. most centres treat the area of concern with no elective target volume included, with a small number of centres which treat adjacent pleura, defined nodal regions, and occasionally the whole mediastinum. As per the Royal College of Radiology guidance, radiotherapy volumes should be discussed with and peer reviewed, and in almost all centres this occurs, and primarily this is discussed with an alternate clinical oncologist. In smaller numbers, a thoracic surgeon or a thoracic radiologist are included in the peer review process, and a recent study published from one of the European groups has identified that there can be significant difference in the target volumes felt to be at risk by a clinical oncologist compared to a thoracic surgeon. Most patients have their radiotherapy planning scan performed using 4D CT simulation, with a few centres highlighting that they don't use this because they did not feel that the anterior mediastinum would significantly change through the respiratory cycle as their justification for using 3D CT simulation. Most patients are now being planned using volumetric arc therapy, with only a very small number of patients being planned using typical traditional 3D conformal radiotherapy, highlighting the step change in radiotherapy management for thoracic malignancies. And the majority of centres are performing daily cone beam CTs throughout, with the rest of the centres starting daily, typically for either 3 sessions or 5 sessions, and then moving to weekly to confirm target volume placement within the radiotherapy field. So we were also asking about the when people would consider using radiotherapy in different stages of the thymic cancer pathway, and there is a huge amount of heterogeneity within centres. Over 1 in 5 centres have suggested that they would consider post-op radiotherapy for a completely resected stage 1 thymic epithelial tumour, which is different to the ESMO guidelines, with reasoning being related to a more aggressive histology, whether it's starting to get slightly close margins, whether there was extracapillary extension, which is suggesting the difference between the TNM staging and the Massaker-Koga staging. And only 3/4 would offer post-operative radiotherapy for all stage 3 or 4A thymic epithelial tumours, against the recommendation, the ESMO recommendation, that all patients should be offered post-operative radiotherapy. And again, only just over half of centres would offer post-op radiotherapy for thymic carcinomas and or thymic neuroendocrine tumours, even rarer subtype, which is again in slight difference to the recommendations from the ESLA guidelines. And only 4 in 5 centres would use post-op radiotherapy for complete resections, with factors being considered including the fitness of the patient, the lung function, and the cardiac doses related to the tumour volume, and whether it was a low risk histology or a higher risk histology. So one of the most contentious decisions is whether to offer post-operative radiotherapy for complete resected stage 2 thymoma patients. And as you can see in the table, there is general agreement that the more advanced stage and the more advanced histology should have post-operative radiotherapy, but there is still some variability within the more intermediate histologies, especially at higher stages. As highlighted by Abby, there is a huge variety in the doses of radiotherapy used, with typical doses being, apologies, some of the numbers have been cut off, but typical numbers being 50 gray and 25 is the most commonly, up to and 60 gray and 30, suggesting that there is very much no standardized discussion, with slightly higher doses being used for incomplete resections and slightly higher doses being used for definitive fractionations. There's still quite significant differences in the use of both neoadjuvant and definitive chemoradiotherapy, with quite a large variety of doses, and only 50% would use induction chemotherapy, as opposed to the recommendation of all patients having induction chemotherapy as part of definitive treatment within the ESMO guidelines. Their stage 4 disease is typically managed by a clinical oncologist, with a smaller proportion being managed by medical oncologists or both, and most centres are using some palliative radiotherapy, normally the typical lung doses for typical lung indications, and most centres have the clinical oncologists following up all of their patients with thymic epithelial tumours, but there is quite a significant variety, with some centres having multiple clinicians looking after their patients, and most patients are seen every 6 months with a CT imaging either 6 monthly or annually, and there is a significant variety in how long patients are followed up. As David mentioned, there a number of patients have prognosis over 10 years, highlighting the need for extended follow-ups, although the majority of centres are following their patients up for only 5 years, suggesting that maybe we should be following up these patients up a little bit longer. So thank you for listening, and I will now pass you over to Karen, who is the lead of Thymic UK, and we'll take questions after all of the presentations are complete.
Thank you, Stephen. Yes, I'm Karen Ruddock, and I'm a thymoma patient and also the founder and chair of Thymic UK. I'd just like to thank BTOG and members of the Thymic Special Interest Group for giving me the opportunity to speak on behalf of thymic malignancy patients, and for bringing this day of learning forward to coincide with Thymic Malignancy Awareness Month. Now you'll see my video presentation on behalf of Thymic UK. Thank you. Being diagnosed with cancer can be a distressing and difficult time. Being diagnosed with a rare cancer poses additional challenges which can add to a patient's anxiety and stress. A diagnosis of a rare cancer such as this can leave patients feeling isolated, desperately trying to find any information or doctors that have experience of treating the disease. Patients need to research and advocate for themselves, as often some healthcare professionals know little about the disease or may not have heard of it at all. This is an added burden at a time when you need it least. I experienced all these feelings and issues when I was diagnosed with stage 4 thymoma. I knew the only way for things to change was to bring patients together. We needed to make the change ourselves, and there is power in numbers, however small. In the summer of 2018, I put a post out on the International Thymoma Support Group on Facebook, inviting UK patients to a meeting on Cancer Survivors Day at Guy's Cancer Centre in London. My clinical nurse specialist, Marika Colvin, who is now a Thymic UK trustee, helped to source a space and attended the meeting for support. Also, my oncologist at that time, Dr. Lau, came to the meeting to help answer patient questions. Both volunteered their time. There were 6 patients at that first meeting, We now have approximately 350 patients on our Facebook group and our mailing list combined. From our small beginnings, Thymic UK is now a registered charity. Thymic UK aims to address the feelings of isolation by providing a safe space for patients to discuss their feelings and experiences of living with these rare diseases. We have an active closed Facebook group for patients, partners and family members. We also hold virtual patient meetings where our members can learn from each other and share. We also aim to help increase awareness and understanding. Because of the rarity of thymic cancers, the level of knowledge about them across the medical community is limited beyond a few specialist doctors and nurses who have chosen to take an interest in thymic malignancies and have had experience of treating more patients. We aim to help increase the awareness and understanding of thymic cancers across the medical community and across the general public. Thymic UK have collaborated with the International Thymic Malignancy Interest Group to launch our first ever Thymic Malignancy Awareness Month. May 2022 is our first year, and we hope this month will grow and create increased awareness, which in turn will lead to more research, greater understanding and better outcomes for patients. We aim to work with doctors and governing bodies. It is difficult to access new treatments on the NHS and even privately due to the level of clinical evidence required to support the use of a drug for a particular disease. With a rare cancer, there may be an insufficient number of patients to run the kind of clinical trials required to generate the necessary clinical evidence. By working with doctors and governing bodies where appropriate, we hope to address access issues for these rare cancers so that patients can receive more effective and safer medicines. Lastly, we aim to promote and initiate research. There is little active research into understanding and treating thymic cancers. Our ambition is to initiate research, and with the growing number of patients in our group, this is something we believe is now possible, as many are willing to share their medical histories to aid research. As I've previously said, being diagnosed with a rare cancer poses additional emotional impact. Your life is taken over with appointments, tests and treatments. You have little time to process what is happening. Decisions must be made quickly about your care. One of the issues that patients in my group have raised is why do so many doctors have different approaches? Having a clear and visible UK standard pathway would ensure that patients can be confident in knowing that they are receiving the best treatment for their particular type and stage of cancer, and doctors can be reassured in the decisions they are making for their patients' treatment. As a thymic cancer patient, you want to be sure that you are receiving the best treatment options from your healthcare professionals. Just by searching the internet and communicating with patients abroad, we can see that there are chemotherapy drugs available in other countries that are not available to us in the UK to treat thymic cancers. Or they may be available for use with other types of cancer, but not thymic malignancies, as there is no proven data in the UK to show that they work effectively. How do we get data if we are not allowed to use these drugs? This naturally leads me to research and data. The funding for rare cancers is underrepresented. Small charities such as us often spend years fundraising to initiate research. Why is this? Data records are also an issue. With better and more detailed data submission, there would be a clearer overview of how certain treatments work on particular types and stages of thymic malignancies. This would be of great help when decisions are being made on treatments, especially where a patient has recurred and certain chemo regimens don't work a second time or cannot be reused. Why do so many doctors not recognise thymic malignancies as cancer? I have been told by patients in my group that some have been sent away by doctors that downplay their symptoms, or worse still, are sent away being told that thymic malignancies are benign, often returning later to be told that they have a stage 4 cancer with limited treatment options. There appears to be an outdated learning on thymic malignancies, or in some cases, no learning at all. That is why today's webinar is so important for us as patients. Thymic UK is very proud to be working with the BTOG Special Interest Group, headed by Dr. Gilligan. We are truly grateful to the healthcare professionals in the group that are volunteering their time and caring to improve the learning and understanding of thymic malignancies for patients. The Special Interest Group will soon be working on creating a gold standard pathway for other doctors to follow when treating patients, and in time are setting up a review board that will give advice on individual patients' treatment following submission of their cases by their doctors. This will be an amazing development for all concerned. Thank you all for taking the time to watch my presentation. There is more that can be done, but we need your help as healthcare professionals to make it happen. Just by taking part in this day of learning, you are making a difference. The information that you take away today will, without a doubt, make a difference to someone's life. Thank you. Thank you. I hope that presentation has given you all an insight into the patient's perspective and made you think about what you can do to increase awareness in your place of work. And thank you all again for taking the time to listen. And thank you to the healthcare professionals that are volunteering their time today for this day of learning. Thank you.
Thank you very much, Karen, and thank you, Abby and Stephen, for those amazing presentations. I think I will say, because there was such a lot of data, particularly in the Notch presentation, that all these slides will be post-meeting online for you to look at and study in greater detail. And I think it just really sets the scene for the rest of the day's presentations about where we are and how we can go forward. And it just tells me that there is a massive amount to do. So we need to keep to time, and so we've got about just over 10 minutes for questions, and we've had some coming in to and please keep them coming. One question is survival. Does it differ if thymoma is associated with a paraneoplastic syndrome such as myasthenia gravis, i.e. A more aggressive tumour? Abby, I don't know, have you got any information or data from your study about that?
So we didn't undertake our survival analysis according to paraneoplastic syndromes or not. So we didn't specifically look at that. It is an area of interest, but unfortunately with the data set just being like 300 patients or so and only 20% of those having myasthenia, it was quite small numbers by the time we got to that in terms of the complete data that we had in terms of survival as well. So it's a shame we couldn't look at that in our data set, but I'd be very interested to see if that's a factor in the rhythmic study that you mentioned that's coming out of France. It's obviously hugely important to know if that has an impact, definitely.
Yes, and we'll be hearing from the Oxford group, who are neurology based, about myasthenia, so that we maybe get more information about that in a later session. Certainly, my experience is that one of the biggest issues about managing people with paraneoplastic syndromes maybe is not so much the myasthenia, although it can be quite significant, is the management of pure red cell aplasia, or, and as you mentioned, Good syndrome, so that patients are really quite incapacitated by infections or anemia, needing support in that aspect of their care. And it was really interesting to hear about your survey about doing something as simple as doing routine immunoglobulins on patients to pick up any possible immune deficiency that could be, as you say, effectively treated and managed proactively, rather than something that is an afterthought. And many patients that I've seen have, it has been picked up retrospectively, and if we can anticipate it, then and so much the better. A question, Karen, you highlighted obviously the rarity of the cancer, and that is quite a big problem in trying to further research, drug development, access to treatment, etc. On your website, you've got a mention of the Cancer 52 group, which is looking at rare cancers. Do you have any more information on that?
Cancer 52, they're a registered charity, and they are basically a voice for smaller charities that represent rare cancers. So overall, they push the agenda for smaller charities such as Thymic UK to try and change government guidelines. One of their most recent campaigns was Can You See Us?, where they were trying to push the agenda to get rare cancers more recognised and for more funding to go to rare cancers also.
Okay, I mean, I think that's important, that there is a collaborative approach. Thank you. Just looking at some of the other questions, some of them I think will maybe the group here are well, we can certainly discuss, but maybe better place to answer will be in the subsequent sessions. In particular, how accurate is CT MRI in picking up thymoma and differentiating from other lesions? And I think the next session will be really, really important in answering that question. So if I defer that perhaps to the next session. One question to everyone, and certainly something that was at least a sort of a hint of something going on. Firstly to Karen, and then to Stephen and Abby, to see if you've got anything coming through from your survey. The impact of COVID on thymoma, certainly we were picking up that there may be, and it could be related to the immune deficiency, that in certainly the first waves of the COVID pandemic, there were patients who presented with severe COVID, and because they had chest imaging, their thymoma was picked up. And it is difficult, is it a chicken and egg situation, because they had COVID and therefore they had a CT of their chest, or that they were more at risk of getting severe COVID because they had some sort of immune deficiency. Karen, have you, any of your group, talked about their experiences regarding that, or indeed anything through COVID?
That is interesting, because we have had more of a steady flow of patients joining the group.
but not really any that I know that have said that their thymoma or thymic carcinoma was picked up due to screening for COVID. It could just be a heightening of the profile as the group grows, that we're gaining more patients. So that is an interesting observation, definitely, that it could, like you say, it's a chicken and the egg. It could be due to COVID screenings, but that's not something that's been very apparent to me from the patients that have been joining our group.
Any views on that?
Whilst we didn't ask for it specifically in the survey, I know that a number of centres have been mentioning that they've definitely had an increase in the number of patients they've had, even in the last couple of years, kind of coinciding with COVID. And so whether there have been an increased number of pickups because of increased number of CT scans being performed, or people getting checked out because they've got new chest symptoms, and whether that could be related to COVID. I think it's a very interesting question.
And we've had one question which, sorry, Abby.
Interesting thing as well will be to see, I know obviously we were looking to implement lung cancer screening as well with like supermarkets and things. I heard about the pilot a while ago, and I think because of COVID that has potentially been delayed slightly, but it'll be really interesting to see when that actually starts, whether that as well has any impact on thymoma pickup rates to possibly a slightly older population, but I'm sure there will be more patients that come forward with incidental findings.
Yes, I think that's a really, really important point, that with the rollout of lung cancer screening, the method by which it's being done, which of course is low-dose CT, that will also pick up thymic lesions too. So we will be seeing more and more, I guess, and that will be a sort of a byproduct, if you like, of the lung cancer screening program. There has been a question, Stephen, is your study still open? And the people would be interested in adding to it. So that's great that we can, that you can sort of add to your data set. In that case, I think at the end of your presentation, you gave an email address, but for people who want to add to the study, what's the best way of getting in touch with you?
So either you can contact me directly on sdrobinson@doctors.org.uk, or you can go to the survey directly, which is www.smartsurvey.co.uk/s/notch_thymoma. But either route will allow you to get access to the survey. If you email me directly, I'll send you the link.
Okay, I think the line went a bit odd when you were actually doing the smart survey end of the web address. But I think if people email you at your email address on the presentation, and as just to repeat, the presentations will be available for and I should know this, but I can't remember. I think it's at least 30, if possible. I'll mention it at the end. Actually, when I come to sum up, I will get the exact figure. But the presentations will be on the BTOG website for certainly at least 30. And I'm not sure if it's 90 days after this particular meeting. I will get the BTOG Secretariat just to confirm to me exactly how long it's going to be. I should know that, but I've forgotten, so I'm sorry. I think I'm going to draw this session to a close, and thank you to all the speakers and contributors to this session. Thank you also to those who've asked questions. Please stay online, because some of the questions that you've asked will be covered and answered in other sessions. So please get yourself a coffee or a bit of fresh air and look forward to seeing you again for the next session, which is in 15 minutes. Thank you.
Hi, my name's Deirdre Linsky. I'm a senior oncology registrar here at Cambridge University Hospital's NHS Trust and Royal Papworth Hospital. And I'm delighted to welcome you to our next session titled Managing the Thymic Pathway. And we have 4 presentations in this session. Our first speaker is Dr. Shalini Datta. She's a consultant radiologist at NHS Greater Glasgow and Clyde and clinical lead at the Scottish National Radiology Reporting Service Bank. And her presentation is regarding how radiology can problem solve thymic lesions. Our second speaker is Dr. Rebecca Durden, who is a thoracic radiologist at Wythenshawe Hospital in Manchester, and she has a wealth of experience of working within tertiary referral centres and supports numerous regional MDT meetings. And Dr. Durden is talking to us today about radiology of anterior mediastinal masses. Our third speaker is Dr. Angeles Montero Fernandez, and she's a consultant histopathologist with over 20 years' experience in thoracic surgical pathology. And she's talking to us about having a simple guide to thymic pathology. And then finally, we'll finish with Dr. Mohammed Reza Ashrahi. He's a Myasthenia Clinical Research Fellow at the University of Oxford, talking to us on the management of associated conditions. And there'll be a focus primarily on neurological conditions, and we hope to cover other associated conditions in future events. And then we gather back together for a panel chat and discussion and any questions where all our speakers will try and answer your questions. And we'll also have Professor Maria Isabel Leet joining us on the panel discussion for any questions. And remember, you can log in, type in your questions, which we can put to the speakers at the end in our panel discussion. So I'll hand over now to Dr. Shalini Datta on how radiology can problem solve thymic lesions. Shalini.
For inviting me. I have nothing to declare. I've been tasked to discuss the role of the radiologist in the management of thymic lesions. The thymus is an interesting organ. It has been described both as the seat of the soul and the seat of the Satan, and it is generally regarded with suspicion. And with the increase in the volume of cross-sectional imaging, it is no surprise that thymic lesions being increasingly picked up and mentioned in radiology reports. To discuss the role of the radiologist in the management of thymic lesions. So I will start with a very brief description of the spectrum of thymic abnormalities and the imaging modalities available to us to problem solve. And then I will share with you examples of cases which have gone through our MDT in the last few years to illustrate some key points. In the volume of cross-sectional imaging, it is no surprise. So thymic lesions range from being on the benign end of the spectrum, i.e. hyperplasia, cystic lesions, AB malformations, to indeterminate masses and frankly malignant lesions. I will concentrate on the more benign end of the spectrum, and then one of the other radiologists, Rebecca, will sort of talk about the more malignant end of the spectrum. So in the main, when we come across a lesion, the physicians and the surgeons are looking for an opinion from us. Can we leave this alone? Does this need a follow-up? Or is the lesion clearly malignant? To indeterminate masses and frankly malignant lesions. I can't get rid of this echo. On the more benign end of the spectrum. Okay, are we good now? Yeah. Yeah. Okay. Coming back to what I was saying, in the main, the physicians and the surgeons are looking for an opinion from us. When we see something, can we leave it alone? Does it need follow-up? Is it clearly malignant and needs to be treated as such? So my talk will focus mainly on the more benign end of the spectrum. So CT is the most common modality available to us. Most lesions will be first, in fact, mentioned as something which is visible on CT. It's fairly good for anatomical locations. It can give us a good idea about the density of the lesion, the presence of calcification within the lesion, and is reasonable for contrast enhancement. MRI can add further information about the presence of fat, which can be very valuable. We can use chemical shift imaging to demonstrate this. Diffusion weighted imaging has been recently described also in the characterization of these lesions. And of course, then there is PET, in cases where we think it's a malignant lesion, it can give us an idea about the extent of glucose uptake in the lesion and also if there is disease elsewhere. So moving on to some examples which have gone through our MDT in the recent years. So here's an example of a 50-year-old female. It was incidentally found to have what appears to be benign thymic hyperplasia. So, there were no known underlying conditions. As you can see, this typically appears as a triangular mass in the anterior mediastinum with sort of concave margins. It can have a speckled appearance, as you will see in the next case. This is a slightly larger version, but of course it is important to know if the patient has got any underlying conditions. In this case, the patient had hyperthyroidism, which is a very well-known association. And if once you know that there is an underlying condition, one can be fairly comfortable in calling this as thymic hyperplasia. And of course, you can do other things if further reassurance is required, and I'll come to that in a minute. Here is another example of a young 21-year-old female with multiple endocrine neoplasia. This was not active on the tetroid isotope scan, and again has remained stable over a reasonable number of years and has just been treated as benign thymic tissue. This is a slightly more dramatic example of how big the thymus can appear. This patient has got Graves' disease. Sometimes these patients can go quite further up in their management train, and there can be a high concern that there's an underlying malignancy, but the presence of Graves' disease is a very good reason for just a wakeful watch. This is a slightly more interesting example. So this lady was seen to have this sort of lobulated appearing thymic tissue in the anterior mediastinum. All the plan was to take it out. However, her BMI was too high. She has an underlying condition of rheumatoid arthritis and is on methotrexate. She was asked to lose some weight, and then on repeat imaging, it just seems to have involuted, and she remains under follow-up. So I think I wouldn't have been able to say to begin with that, yes, this is likely to be benign, but the fact that it has involuted suggests that this probably just represents some sort of lymphoid hyperplasia. This is an example of a lady who has undergone or is undergoing treatment for breast cancer. And again, it is not uncommon to see enlargement of the thymus. Sometimes it can be rebound hyperplasia, or sometimes it can occur along with the treatment. And again, recognition of this is important and not to be confused with malignancy. What I have been doing in my practice is to give further reassurance using chemical shift imaging. This has been, it has been described and used in centers before, but the challenge has always been to localize a small thymus and get rid of breathing artifact and to obtain reliable, reproducible scans. So what you're looking for is a drop in signal intensity on the out of phase images. And if you can demonstrate that, you can be fairly confident that you're looking at just a benign thymic tissue. So I'm increasingly using this where I'm convinced or fairly convinced that it is just benign thymic hyperplasia, and this is very reassuring for the patient. And then if any follow-up is required, these are young women, it can be done by a limited scan which does not involve any ionizing radiation. So moving on to sort of the next phase of the benign spectrum are cystic lesions in the anterior mediastinum. Again, very, very common. This is a 80-year-old lady with an incidental lesion in the anterior mediastinum. The green circles show, the radiologist measuring the Hounsfield unit, which is, the density within the lesion. And then in general, it's sort of accepted that if you get values of less than 20, that generally indicates fluid within the lesion. Although, cystic lesions can have hemorrhage, or, they can be dense because of proteinaceous material. But if you have Hounsfield unit values less than 20, that's fairly reassuring. These are two examples. So on the left is a 35-year-old female. Again, you've got a lesion which, if you look at the vessels adjacent to it, it's very low attenuation, and it looked like a cyst. Whereas if you compare it with the lesion on the right, it is much denser, shows enhancement, has blurred margins, and this is a lymphoma. As I mentioned earlier, MRI is very good for illustrating contrast enhancement or the lack of it. And in this case, this lesion does not demonstrate any enhancement, no rim enhancement, no solid components. And one can be fairly certain that you are just dealing with a non-enhancing lesion likely to be benign. As I mentioned earlier, diffusion weighted imaging has been mentioned recently. The lack of restriction is a suggestion of benignity. However, I've only just started using this, and I'm sort of gradually building my experience to see how definitive I can be with this. So these are some examples of what look like cystic masses, but which have been excised. I think it depends on the level of patient anxiety. It is not always possible to say that something is fluid attenuation and completely cystic. But cysts generally tend to have smooth margins, and sort of still. They seem to maintain. Sometimes they can be rounded, but sometimes they just have this sort of pointy anterior margin. This one turned out to be a bronchial cyst, but I don't think on imaging I could have said whether this is a thymic cyst or a bronchial cyst. But I suppose my impression was this is probably benign, but it did end up coming out. Some cysts can have calcified margins. Again, in general, calcification is thought to be a sign of benignity. In this case, the pathology came out as either a benign thymic cyst or an organizing hematoma. There was no history of trauma in this patient, so I'm assuming this was just a benign thymic cyst with some rim calcification. This is another example of a calcified lesion. The calcification is a bit thicker. This turned out to be mature cystic teratoma, and the report said no evidence of malignancy. This is at the benign end of the spectrum, but again, it did end up coming out. This last example is from our last MDT, and again, I was asked, can we leave this alone? And I guess it's a discussion with the patient. I think if it's an elderly patient and the surgery is thought to be complex, one can one can have a discussion that is it worth taking this out, or can this just be followed up? One of the other things I've come across increasingly is the presence of AV malformations, and one needs to be wary about these because the patients often, present initially having had a non-contrast examination where the malformation just looks like lumps of tissue in the anterior superior mediastinum and are called as such. And then, one mustn't just proceed to biopsy these things or excise them. On more than a couple of occasions, I've been able to demonstrate that this is in fact an arteriovenous malformation. As you can see, on the non-contrast imaging, if it's probably hard for you to appreciate, but there's a speck of calcification, which is something, which are basically phleboliths within an arteriovenous malformation. Then, in the middle, which is the arterial phase, you can see bright enhancement of the vessels, and then a slightly more diffuse venous enhancement on a delayed phase. And so one can be fairly certain that this thing, which otherwise just looks like clumps of tissue, is actually arteriovenous malformation and probably best left alone. Moving on to the slightly more indeterminate or complex end of the spectrum. So this is a slightly more, complex cyst in that you can see that there is rim enhancement on the arterial and the venous phases. This patient elected not to have it excised, and it remains stable on follow-up. This is an example of what appeared to be, a very smooth lesion. However, it had attenuation values of 46. And although it didn't show any contrast enhancement because of the high attenuation values, it was excised, and this turned out to be a thymolipoma. This is an example of, so this is not exactly in the region of the thymus, but we often come across masses which sort of, they combine, they're either present like this or in association with some thymic tissue more anteriorly, and I'll show you an example of that in a minute. This was sort of slightly warm on PET. It was showing mild enhancement and was dense on CT, so it was, we couldn't call it just benign thymic tissue, and this turned out to be reactive lymphoid tissue. So I think these cases are difficult, and radiology can only take you so far. So this is an example of how one can sort of reliably demonstrate enhancement in tissue in the anterior mediastinum. So you can see on the middle slide and the slide next to it that with progressive enhancement of the vessels, there's also enhancement of the lesion. This lesion is more solid appearing. It's got lobulated margins. It's sort of got convex borders. And this is a typical example of what you would expect a thymoma to look like. This was an interesting one. It was a lesion which was picked up, I think, the first time in 2014. And then I think it was mentioned and nothing was done about it. And for some reason, the patient had a follow-up, and it had enlarged. And this is just benign, and it turned out to be a thymoma, but this sort of grew very slowly over several years. But on MR, you can demonstrate enhancement within the lesion. And of course, it had grown, so there was no question that this was going to come out. And just to finish off, this is again something which had grown over a number of years, and you can see how this lesion, not only it has grown, but is demonstrating enhancement and is avid on PET. And this also, the patient was asymptomatic, and it turned out to be a thymoma. So in summary, anterior mediastinal lesions are being increasingly reported. As a radiologist, we have access to various imaging modalities that can be used to problem solve. I use MRI a lot, where I can, where I feel I can reliably demonstrate that something is benign and can be left alone. Over the last, initially these lesions used to come across in our lung cancer MDT, but there's just the number of cases that are discussed in the lung MDT has just been ever increasing. So we decided to have a separate MDT to discuss these lesions. So, we have a thymic interest group almost, which discusses cases from the west of Scotland. On an average, we have about 10 cases every month, but the surgeons have found it extremely helpful, and the physicians as well. So, that's my take-home point, good to have MDT discussion about these meetings.
Thanks very much, Shalini. So apologies for my voice. I am in day 5 of COVID at the moment, but not feeling too bad. But if you do have any issues with hearing me, please do put it in the chat. And also apologies if I need to stop for some water partway through this presentation. So I'm following on from Shalini talking about the more aggressive spectrum of anterior mediastinal masses. I have nothing to disclose. So first of all, a little bit of background for the non-radiologists, those people who may not be so au fait with looking at CT. How do I evaluate an anterior mediastinal mass? Well, first I need to locate. And for that, I'm thinking about the anatomy of the lesion, because obviously that's going to identify where the anterior mediastinum is. I need to describe what I'm seeing. And for that, I'm going to think about things like radiological terminology that we use on a regular basis. I'm certainly going to then need to differentiate between the different things, and Shalini's covered some of this already for the more benign end of the lesions. We're going to use things like surgical sieve, but also it's really important to have clinical information from the team referring, such as age, whether there are secondary symptoms such as myasthenia gravis, and also biochemical results. And then finally, if I do see something that looks aggressive, I'm going to need to stage it. And we have a formal classification system for thymic lesions and several others I'll come on to later. So just for those of you unaware, we are thinking about the anterior mediastinum. It's a very small area, and it shouldn't really contain anything in the adult other than fat, lymph nodes, a few vessels. It should be empty, really. So as soon as we see something in that region, we have to think of this as potentially pathological. A lot of lesions we see there have actually come down from the superior mediastinum, which you can see is the green area on this lateral diagram. And particularly the thymus, because in childhood this does extend into the anterior mediastinum, but it then regresses in adulthood. Adulthood can actually be quite late on, so it's normal to see some thymic remnant in people in their 20s, but once you've got to 30, it should have disappeared. So what do we arise masses from? Obviously, we've just mentioned the thymic remnant. It can be lymph nodes or fat. It can come down from the thyroid, although that's less common, and I'll come on to that later on. It could come from the pericardium posteriorly, or it may relate to the vessels. And then with the lateral margins being the pleura, obviously any disease such as mesothelioma can come in from the lateral aspect. And don't forget the sternum anteriorly, that protrudes down into the anterior mediastinum. For example, if you've got an osteomyelitis, a mass may relate to that. Radiologists like to have things to remember, and I like to do them in 5s because we've got a hand, you can put them on your fingers and your thumb. So we tend to talk about the 5 T's, which is a thymus, a thyroid, a thoracic aorta, a terrible lymphoma, or a teratoma, and that's a useful adjunct to try and remember the causes of an anterior mediastinal mass. And approximately half of all masses in the mediastinum are within the anterior mediastinum. So moving forwards, we've covered some of the benign features as discussed by Shalini already, and we're going to move forward through these intermediate into the more malignant lesions. And at the bottom is a couple of papers which are summative papers, very helpful for people if they want to do some reading afterwards, both from a radiological standpoint, but also from a clinical standpoint as to how to evaluate these lesions. I've not copied them here, but there are some very useful tables, particularly bringing in those clinical informations, age and sex of the patient, which can help you differentiate quite well. So, what kind of things are we looking for to differentiate between benign and malignant features? Well, we're going to focus on malignancy in this part of the lectures. So we're really looking for lesions which look irregular margined and have invasion into other structures around them. This is particularly important when you're looking at the staging of lesions. We're also looking to see on CT in particular, are there any evidence of metastases or abnormal fluid in the adjacent structures such as the pericardium or the pleura? This would not be a normal finding. Tissue attenuation, as already alluded to, is really important. A more heterogeneous or complex lesion is more likely to be malignant rather than a completely homogeneous lesion, and particularly whether there's a case of fluid or cystic change in there. Enhancement with contrast, if something is highly vascular, that is also really important to note. Again, that would suggest a more malignant lesion, although we have to have the caveat of a vascular lesion to start with. And then chronological change, a rapid progression, a growth or invasion into adjacent structures would suggest malignancy. We do see very slowly growing thymomas on a regular basis, but the vast majority of lesions do grow over time rather than staying stable. So here we've got a case where anatomical location is key. On the left of the screen, you've got a lesion with edge enhancement, which I've already mentioned could relate to malignancy. And centre of it is in low in attenuation, which would suggest that it's potentially cystic. When you look on the lateral view, which is on the left of the screen, this is off-centre, and you can see it extends up into the neck. There's another lateral view here, which actually shows relation to the anterior mediastinum. And if you remember that diagram I showed to start with, this is not anterior, this is in the posterior or central area. So this doesn't fit. And then when we look at the axial imaging, you can see it extends up into the neck on the right, and it has the same attenuation on the external aspect as the thyroid does. And this is a case recently that was diagnosed potentially as malignant, but this is actually a very large thyroid cyst extending into the superior mediastinum. So you have to be very careful to look at the whole image set to make sure. And this is awaiting surgical resection. Our next image is hopefully, yes, it's playing, of a similar case of a thyroid goiter. But this actually also has I'll just play that again, a anterior mediastinal nodule, which is truly in the anterior mediastinum, which is actually a thymoma rather than ectopic thyroid. And this was proven with post-resection. Here we have another case where we've got to think about the margins and contact with other structures. So what do we have? We have a large mass in the right side of the anterior mediastinum. It's taking up a huge proportion of the right thorax. You can see there is vascular enhancement within it. You've got vessels within it. But if you look carefully, it's squashing the vessels. It's passing in between the vessels, but it isn't actually invading the vessels. And this turned out to be a very large lymphomatous deposit of a high-grade B-cell lymphoma. So there are aggressive features there, but there is not local invasion. And that fits, that fits more with lymphoma, because that tends to interdigitate between structures rather than directly invade with them. And this regressed with appropriate lymphoma treatment. Now we're going to go on to tissue attenuation. Shalini has already talked about this. Here we have a case of a patient with a lesion in the anterior mediastinum, and it has got 3 different foci within it. On the right, there is something which is attenuating post-contrast up to 36 Hounsfield units, centrally 25, and then on the left, only 9. So that would be in keeping with fluid, whereas the soft tissue components and the centre on the right is enhancing. This is unusual, and if you go more inferiorly, you can actually see there is a small pericardial effusion, and there is evidence of potential invasion into the pericardium and possibly even the right atrial appendage. So this would be much more concerning for an aggressive lesion. This was biopsied, the more solid component was biopsied, and that was proven to be a mediastinal germ cell tumour. We've got to speak a little bit about biopsy, and I'll come on to that later on, but the place of biopsy needs to be chosen carefully so that we think about what's going to give the best tissue diagnosis for the pathologists, but also what's least likely to seed through the mediastinum and or the pleura, depending on the approach. A little bit about contrast enhancement. We've already talked about one case. Here is a case of a large anterior mediastinal mass. You can see on the left, there is a non-contrast study. And on the right, there is a contrast enhanced study. And even though there is some heterogeneity on the left, it's more obvious on the right. And you can see vascular enhancement within it. And this turned out to be type AB thymoma. And the arrow on the left shows where there is subtle but definite invasion into the anterior chest wall, which would stage it as stage T3. And AB thymomas of this size are difficult to resect, but they were going to try to resect this following our recent MDT. This is another case where contrast enhancement is visible in quite a heterogeneous way. It looks similar to Shalini's case of a hemangioma. There is calcification within it. There is heterogeneous vascular enhancement. And you can see the image at the top is non-contrast. It's also taken at the time of biopsy. You can see the needle in the lesion. On the left of the screen, you can also see the the lung windows. Anteriorly in the right upper lobe, there is a nodule right next to the vessels. And then posteriorly in the left upper lobe, there's another nodule, as well as a left pleural effusion. These are features of metastasis. And this was a sarcoma. It was biopsy proven to be a sarcoma. Sadly, this progressed very rapidly, and the patient died only 6 weeks post the first image at the bottom with diagnosis. So some lesions, although they have got this heterogeneity, it does suggest quite aggressive pathology. And the late stage of diagnosis will obviously not have helped with this patient's course of medication, which unfortunately was very short-lived for chemo. So when we're approaching, we've already talked about using CT staging for imaging of malignant features. We particularly use CT for the T stage, although we do have MRI as an adjunct if needed. MRI is particularly helpful if we were looking to evaluate for more benign features, for cystic lesions, as mentioned already, but it can help to say this is indeterminate and needs further workup. When we're talking about CT biopsy, location is obviously very important. If it's a small lesion immediately adjacent to vessels, deep within the mediastinum, with a difficult access behind the sternum, CT biopsy may not be feasible, but we do try to sample as much as we can to help guide consent process. And also, if there are no surgical options, it then will guide potentially the chemo options, particularly if there's a question of lymphoma. Core is essential rather than an FNA of a node for lymphoma. Also, we've got to think about things like components. So if it's a completely cystic lesion, we can literally pop the lesion and cause seeding. If there are cystic and solid components, we tend to suggest complete surgical resection if possible, rather than a dissemination of soft tissue or fluid components into any of the compartments. And fitness of biopsy is really important if somebody's very unwell. If they've got SVCO, they can't lie down flat for the biopsy. That might affect whether we can offer it. PET-CT is useful if potentially malignant and radically treatable to confirm there's no disease elsewhere. And also if we prove that the lesion is a carcinoid or has got any features of neuroendocrine markers, we can use Dototec imaging to confirm there's no metastases. And that's using for specialist nucleoplasm studies. We also use those for if the lesion could be thyroid or parathyroid in origin, and that might negate the need for biopsy and or resection. And as we've already suggested with Shalini's talk, we do need to use MDT discussion. Imaging alone is not going to confirm diagnosis. So I'm going to move on to staging now for the last part of my talk. We've got lots of different stagings, and the IASLC classification, TNM8, uses a clear staging for thymus, lung cancer, mesothelioma. We've got lymphoma with Lugano, or lyric if it's post-treatment. And then obviously metastasis depends on the primary site as to whether there's staging. We don't currently have staging for teratoma germ cell tumours and sarcomas within the chest specifically, but this may come forward with new iterations of TNM. I would point you towards using the ISLC apps. If you don't have it already, it's available on Android and on Apple for you to have on your phone to help with staging, both overall staging for surgery as well as radiological staging. So moving forward, we'll talk a little bit about thymic tumours here, because that's the focus of what we're talking about. We've got T1 tumours, T1A with no mediastinal pleural involvement. This is a case of a T1B. You can see in the left-hand image there is invasion into the mediastinal pleura protruding into the lung, but not directly invading the lung. We've got a CT-guided biopsy of this showing we've got a nice intralesional position, and we've got that the PET shows some uptake with the SUV value of 4.6 compared to a blood pool of 2.6. This was worrying potentially for meso as well, because we've got some pleural plaques, but they were not PET avid, and the biopsy confirmed a type B1 thymoma. Moving on to T2, and this was another type B1 thymoma. There is pericardial invasion. You can see the soft tissue component on the right-hand side of the image is very closely related to the right atrium, but then there's also a cystic component more medially, which also is clearly visible on the MRI. This is a complex lesion and was not one of the ones we wanted to biopsy, as I've mentioned before, because we were worried about the cystic component, but it was resected to confirm the diagnosis. Unfortunately, it did have a positive resection margin, so this is patient's going to be going on for post-surgical consolidative treatment. And this is just a sagittal view to show the majority of the pericardial contact is cystic, but there is that solid component more laterally. Here we have a case of T3 disease, and that could be invading any structure as listed. This is into the innominate vein and also into pericardium. You can see that there is a focus of calcification, which sometimes does suggest malignity if you're thinking about germ cell tumour, but in this case, this turned out to be a B2 thymoma, and you can see there's also pericardial effusion present. The eagle-eyed of you may notice on the coronary format on the left that the diaphragm is elevated, which is actually due to phrenic nerve invasion, but that still remains within the T3 staging. And that's just showing where the invasion is. This is T4. You can see on the left-hand view, I've re-windowed to show the invasion into the aortic arch. More inferiorly, it is clear of the aorta, but we can see quite clear evidence of multifocal pleural deposits in keeping with pleural metastases and a pleural effusion. So this is a T4 disease with multiple pleural mets. It's a thymic epithelial tumour, probably type A, but not absolutely definite on biopsy. And the biopsy was made of the pleural lesions. Here we have got nodal staging. Obviously N0 is no nodes. Type 1. N1 would be perithymic or anterior nodes, and we've got some sub-centimetre nodes in that region. N2 would be deep thoracic or cervical. And you can see there is something which is still with anterior mediastinum, but no deep nodes. There's also stranding of the fat around this lesion, which does make you worry about this being a malignant process. And this was an unusual case of a thymic squamous cell carcinoma. That's the deep node that's borderline. Metastases, you can see here another case with multiple level pleural metastases, and this was biopsied also with the under ultrasound to prove the diagnosis. This was actually a thymic carcinoid. This second case was a thymic carcinoid, and this is a Dotatec PET scan, which proves metastases into the bones. So sometimes we have to go a little bit differently for staging. These were not visible on CT. So in summary, we've got to think carefully between the clinical correlation of findings that our clinicians provide for us, the patient demographics and the radiological features to help guide how we stage these lesions. We need to thoroughly evaluate adjacent structure involvement to accurately stage. Biopsy of benign lesions should be avoided if we think there's confidence of benignity, and we also need to think carefully how we approach malignant lesions because of complication and potential seeding. And finally, MDT review is essential for histological radiological correlation, given the broad range of lesions that we have in this group. Thank you very much.
So thank you very much, Rebecca. My presentation is the title is A Simple Guide to Thymic Pathology. My name is Angeles Montero, and I work as a cardiothoracic histopathologist at Manchester University Foundation Trust. Next, please. So I have no disclosures. Just to keep it simple, I have divided my presentation into 5 main points. So the first one, I am going to talk about the thymus, because it's important to understand how the thymus developed, from where, to understand the pathology. I am going to talk very briefly about the pathology and overall. And I am going to focus in thymomas, because this is, well, the main and the most complex pathology that we receive. I'm going to talk very briefly about molecular pathology and the impact of thymoma histotype on prognosis. So the thymus is a very complex organ and comprises epithelial and lymphoid components. It proceeds from the third parapharyngeal pouch. The same place from where the inferior parathyroid come from, and is the main organ in which the lymphocyte T mature. And that's why the T lymphocytes are called like that, because they come from the thymus. So as I said, they develop from the third parapharyngeal pouch, and is an endodermal organ. And the histology shows mainly that we have 2 areas. This is residual thymus in a tumor, so it's one of my specimens. And you can see that the periphery is more blue, is because we have a lot of T lymphocytes. And in the center, there is a kind of a clear area. This is the medulla, which comprises epithelial cells that at the end, eventually, they evolve into the basal corpuscles. There are also in the medulla some B cells, also T cells, but this is the typical architecture of the thymus, the normal thymus. So the normal thymus develops up to 35 grams in the puberty, and after that it regresses and it stays atrophic. So, sorry, I am having problems with the, it's not working. Please, next. So I have divided the classification into 3 big paragraphs. And this is mainly the specimens that we receive. So I consider benign, is because they are benign, hyperplasias and cysts of the thymus, of the thymic epithelial tumors that are divided mainly in thymomas and germ cell tumors. We have other type of tumors that are soft tissue that they have been already nicely described. I am not going to talk. And the next one is the lymphocytic tumors. Lymphocytic tumors that are lymphomas, they are more frequent than thymomas, and they are normally in childs and adolescents. Next, please. So this is only to show you how we look at the thymus. So in the left-hand side, you have the same specimen that I showed you before with the hematoxylin. And if you do a keratin, you can see that the epithelial cells are distributed at the periphery. So this is normal. They have these prolongations and they create this kind of peripheral network. This is a normal thymus or a residual thymus. In the right hand side, you have epithelial tumor, so you have a thymoma, and in this case, this was a type A thymoma. So you see that the distribution of the keratin, it helps us just to make the diagnosis. Next, please. So thymic epithelial tumors are rare and represent the most frequent tumors in the anterior mediastinum. They are originating from the epithelial cells, and they are less than 1% of the human tumors. They are classified into thymomas and thymic carcinomas. Thymomas that are low to moderate malignant potential, they are subclassified in A, AB, B1, B2, and B3, and it depends in the morphology of the neoplastic epithelial cells. Thymic carcinomas are overtly malignant and aggressive tumors. They are subclassified depending on the morphology of the epithelial cells. The most frequent squamous cell carcinomas, but they are more varieties, and they have been included recently in the last classification several other type of tumors that I will talk very briefly about them. Next, please. So the international, the first classification of the thymomas, it was in 2004, received a lot of criticism because of the lack of reproducibility and some inconsistency in previous studies. So the International Thymic Malignancy Interest Group, from now on called the group because it's too long and complicated, and they decided just to review the classification. And they considered that the classification was right, but they concentrate in these three points: the thymomas with features intermediate between prototypic subtypes, tumors with atypia or high mitotic activity and necrosis, and tumors showing more than one histological pattern. The other thing, next please, the other thing that they did very good is they review all the subtypes of tumors, and instead of just describing long, and sometimes complicated to follow, what they did is they create these tables that they summarize very briefly the characteristic or the criteria that the pathologists use to diagnose, and they accompany with a very clear type of pictures. So if we start with the type A thymomas, the major criteria are mainly two. Spindle or oval cell tumor cells, the epithelial cells should be this type, and the paucity or absence of immature TDT thymocytes through the tumor. There are other criteria like the presence of rosettes, the presence of glandular formation, vascular pattern, which is typical in other tumors, and other other criteria that are minor but help us. But the two main histological criteria are these two, which are very helpful. So next one, please. So the problem now that they saw, it was how do we diagnose AV thymomas? So AV thymomas, they also saw these epithelioid rounded or elongated cells, epithelial cells, but also they have an increase of TDT T lymphocytes. So when you have more than 10% of the tumor with an increase of TDT positive lymphocytes, this has to be called AV thymoma. In the table, you can see that, so we have to look for this biphasic pattern, high epithelial cell content, spindle or oval epithelial cells, and more than 10% of what they call a moderate to severe amount of T lymphocyte. The way they describe it is very simple. The article is very easy to read. And what they say is when we cannot count the amount of lymphocyte, this is more than moderate, so this is called AB type thymoma. Next, please. So if we go to the type B thymomas, they are tumors that they have a huge amount of T lymphocytes, but they are on top of an epithelial component. So if we look at the pictures, the first one, A, is a B1 thymoma. We have a very important lymphocytic component. So this is a keratin. And what you see is this brownish tumor is highlighting the keratin. The amount of epithelial cells is lower than the one we have in the C, which is the B3. So it is very helpful when you do a keratin and you see that when the cells can be visualized independently, it's more a B1. And in 3, we see that the amount of epithelial cells are very dense. This is very helpful. There are other criteria, of course. And this is very helpful when you see the table. So major criteria, if you have a tumor-like pattern throughout, what it means is you have the medulla and the cortex. In B1, you have consistently present, but it's rarely present in B2. So we kind of follow this criteria to make the diagnosis, and it's very easy to see, it's very simple to understand and to follow the pictures. So if we go to the next slides, please. The thymic carcinomas are, as I said before, overtly malignant tumors. Thymomas are considered low to moderate, but thymic carcinoma are aggressive tumors. The major criteria for the diagnosis is the presence of cellular atypia in tumor epithelial cells, and the exclusions of thymoma with atypia or anaplasia, and the exclusion also of metastasis. So what is called atypia? Atypia is rarely seen in type A thymomas, and it is described at the presence of focal areas of necrosis and more than 4 mitosis per 10 power fields. Anaplasia is seen mainly in B2, BT, in B3, rarely, and it is normally focal. So when you have atypia, more than atypia, dysplasia and aplasia, which is diffuse, this is a thymic carcinoma. We have to exclude, of course, metastasis, and there are other minor criteria that are very helpful to make the diagnosis, overall to make the differential diagnosis between B3 and thymic carcinoma. We can use immunohistochemistry and the positivity of CD5, CD117, and GLUT1 and MUC1. They are positive normally in thymic carcinoma and negative in B3. There is an absence of T lymphocytes, so TDT cells are normally very, very low or absent. And there are other characteristics that we can follow in this table just to make easier the diagnosis. So in thymic carcinomas, the immunohistochemistry we are going to look for is CD117 and CD5. The first one, the first picture down in the left is a CD5 and the right one is a CD117. Next, please. So in 2021, there is a new review and of the not only the thymomas but also of all the tumors in the mediastinum. I am going to focus again in the thymic tumors. So they have highlighted that the TNM classification for thymomas should be used, and the modified Masaoka-Koga is optional. Thymomas and thymic carcinomas were the last cancer studies in the multiomic-based cancer genomic atlas, the result has shown that the thymomas has a very paucity of targetable mutations. They demonstrate also that B3 thymomas and thymic carcinomas, they saw a high expression on PD-L1, but they cannot use immunotherapy because of the severe immune-related complications are really our main challenges. They have described other types of thymoma, like micronodular thymoma with lymphoma stroma. It has been described, but they have kept these entities. Metaplastic thymoma, they have a very specific type of mutation, so they kept it. And the lipofibroadenoma. But other variants like microscopic thymomas or sclerosis thymomas, they have erased and are not included in the fifth edition. Next, please. So if we just talk about molecular biology, the summary is that there are no currently targetable mutations, but it has been very helpful just to support the histotype classification of thymomas. So we can see that thymomas A and AB, they show a mutation in the GTF2I mutation with an overexpression and fusion mutations in the chromosome 19. B thymomas, on the contrary, they saw, and C also, they saw a loss in the P53 gene. So this is also important and has reinforced the classification. Next one. So they have also included other entities within the thymic carcinoma classification. They have highlighted the presence of a micronodular thymic carcinoma with lymphoid stroma, which is very similar to the benign counterpart of micronodular thymic thymoma with lymphoid stroma. And they also saw positivity for CD117, the first picture, and the absence of TDT lymphocytes. Another entity is the hyalinized clear cell carcinoma, this type of tumor, which is very similar to its counterpart in the salivary glands. They show a specific mutation in translocation in the UN21 gene. They saw positivity also for P40, and the CK5 and 6, as you see, is kind of surrounding the nest of clear cells. And the last one is sebaceous carcinoma of the thymus, that is very similar to the skin one and shows positivity for androgen and adipophilin. Next one. They also saw that, and we all know that the expression in B3 and thymic carcinoma of PD-L1 is very important. It's diffuse, intense, and it's one of the most important expressions in all the tumors. The problem is the important immuno complications that the patients present, which precludes its use in these patients. However, in phase 2 clinical trials, they have revealed that there are some molecules like sunitinib, everolimus, and levantinib. They are quite efficient in recurrent thymic carcinoma. Next, please. So how do we report thymomas with a heterogeneous component? So we cannot use the term combined tumors, and what they say is we have to start with the more aggressive components. So we have a small cell carcinoma and a thymoma or a thymic carcinoma. The most aggressive component should be at the first, and then the second component. And if we have different components in a thymoma or in a thymic carcinoma, we should state the components in 10% of increments. Next, please. So the 2021 classification or update, they also very briefly talk about thymic carcinomas. They consider that the classification remains the same, so we have to divide in low intermediate grade of tumors, including typical carcinoid, atypical carcinoid, and high-grade large cell neuroendocrine carcinomas and small cell carcinomas. But they have also included a new entity that has been described in the pancreatic neuroendocrine tumors, the NETG3, which shows a morphology similar to the carcinoid, but they show a high Ki67. They also demonstrate different type of immunophenotype, so they are positive for chromogranin, while the high-grade neuroendocrine carcinoma, that maybe you have the problem with these two, is negative, and we have another immunohistochemistry that can help. So the H2, they are negative, while in the large cell they are positive. And also this P53, RB, they are wild type in this innate low grade, while the other, they are positive. Next one, please. So the most important is the histological classification for thymomas has been always very criticized, but it is important to know if there is correlation to the histotype with the prognosis of the patient. So the prognosis of the thymomas and thymic carcinoma depends mainly on tumor stage and the resection status. And so it is important to know if this histotype is important also for this prognosis. So the group decided in 2012 to launch an international retrospective database. So they collected thymomas from 1983 to up to 2012. And they focus in these questions: if there were demographic differences, if the WHO histological classification was consistently applied, which variables affect survival, histotype, stage, resection status, and if the histotype, the histological classification had an impact on prognosis. Next, please. So they realized around 3,000 thymomas they collected, and they realized that the type A, they appear in the higher age groups, so 64 against the others. And the stage distribution, as we can see, the type A and AB and B1, they are the most important thymomas in a stage 1 or 2, while B2 and B3, they have more tumors in a stage 4R and 4B. Next, please. So also the demographics, we can see that in Asia, there are less amount of type A, which are the yellows, while they have more than B3. While in Europe and in America, there are more frequently diagnosed B2. They have also divided the hospitals that they receive this specimen in high volume and low volume, and they could see that there is no much difference. So in a multivariate analysis for survival and recurrence, they could see that there was an independent correlation with survival, with age, stage, and resection status. And next, please. And what they saw in this multivariate analysis, that the histotype was not independent prognostic impact, but they was correlated with the recurrence. Next. So the conclusions is the average age is higher in type 8. So this was not clear if the prognosis was worse because they were older or because effectively, they appear in higher age. Myasthenia gravis, I didn't talk about that, but it's more commonly seen in type B. Why? Because there is is the tumor with a higher amount of TDT positive cells. There is a clear higher proportion of higher state moving from A to BC, so there is a clear importance of this classification. And there is a lower frequency in type A in Asia and more B2 in Europe. The histotype is an independent prognostic factor and in recurrence, but not in survival. And the age, state, and resection study had the greatest independent prognostic impact. So that's it. Thank you very much. And I just hand over to the next presenter. Thank you very much.
Hello, good afternoon, everybody. My name is Mohammed Ashrari. I'm my Senior Clinical Research Fellow at Oxford, and joining on this meeting for the discussion afterwards is Dr. Late, who's my supervisor and the Associate Professor and Consultant Neurologist. Neither of us have anything to declare for the purposes of this talk. So really, I was asked to give a talk about how we manage all these additional conditions that can be associated with thymoma. And really, that is a vast, vast subject and something which we could have in days and days of sessions on alone. So this is a bit of a quick tour through just to raise certain points that should be thought of at all cases, and with a little bit of an extra focus on myasthenia gravis, given that my background is in neurology. So we'll be looking at some of the common conditions and how they can be identified, and then going from there. So as an overview, thymic malignancies are unique in so much as they are associated with an enormous number of paraneoplastic syndromes, more than other malignancies typically see. Up to date, as many as 123 different paraneoplastic syndromes have been identified. But what actually makes this the most challenging is not actually the management of the syndromes themselves so much as the identification in the first place. This is partly because it's important to remember that all of these conditions pretty much can exist without a malignancy. For example, you can have myasthenia gravis with no thymoma at all, or in the presence of a thymoma. In some cases, these conditions behave differently when associated with a malignancy, but in many cases, it can be really difficult to tell them apart. Similarly, many of them can have signs and symptoms which can be attributable to far more benign and common diseases. So, for example, anemia that you would get with pure red cell aplasia, it could just as easily be due to menorrhagia in a woman who's having who's got heavy periods and has become anemic as a result of that. Fatigue in association with a malignancy in the treatment could easily cause all of the symptoms that you're seeing. So it's really, really easy to overlook things. That said, it's also important not to over-investigate, and finding that balance really comes with experience and is really helped by an MDT approach, and then it's the opportunity to discuss things. So neurological diseases and thymoma, we'll focus on those first because I think that's important. So myasthenia gravis can occur in around 63% of patients with thymoma. That number, an estimate, varies depending on different populations, but that is about the number that most people accept. But actually, there are many other conditions. Autoimmune encephalitis is frequently seen, Isaac's syndrome and acquired neuromyotonia, peripheral neuropathies, and Morvan syndrome. And I'll just talk a little bit more about some of these. I should emphasize that this list is by no means exhaustive. This is very much just the tip of the iceberg. So myasthenia gravis. So thymomas are present in about 15% of patients with MG and up to about 50% of patients with thymoma. But again, that number is estimated at higher in some cases, hence the 63% number in that table. It's important to note that this is only in association with myasthenia gravis when patients have the acetylcholine receptor antibodies. Anti-MuSK antibodies and seronegative myasthenia are not associated with thymomas. And there are odd case reports which suggest that they might be, but the general consensus is that there is no connection there. It can be, and basically what happens with myasthenia gravis, for those of you who may not know, is it's fatiguing it's fatiguing weakness of any of the skeletal muscles. So they're the muscles that you have some voluntary control over usually. Now, the symptoms are hugely broad because you have muscles in every part of your body and any can be affected. Ptosis and diplopia are by far the most common and often the first symptom, but dysarthria, so slurring of the speech, dysphonia, or effectively losing your voice, dysphagia, shortness of breath, weakness of the limbs, both proximally, which is the more commonly seen, but also distally, and also neck weakness. These are all symptoms that you will frequently see. Now, I will come back to myasthenia gravis in more detail a little bit later. The next one, looking at autoimmune encephalitis. So autoimmune encephalitis is a general term for inflammation of the brain due to autoimmunity. Now, while often it's isolated to the brain, sometimes these symptoms can also involve the spine and the peripheral nerves, and the terminology there is slightly different, but what we'll be focusing on at the moment is autoimmune encephalitis specifically. There are lots of antibodies associated with autoimmune encephalitis. Not all are necessarily pathological, but they often mark the presence of the disease. And there are huge numbers of antibodies. The ones that are most commonly seen with thymoma are the LGI1 and Caspar-2, but the others have all been previously noted with thymoma as well. So the diagnostic process of this is really challenging, even for neurologists. The symptoms are broad. Cognitive impairment is one of the more commonly seen ones. Drowsiness, seizures, myoclonus, so that's twitching of the limbs, focal neurological deficits, so weakness of a single arm or leg, movement disorders, and psychiatric symptoms, to name but a few. But really, the list can be really, really very long and often quite subtle and difficult to pick up. The thing I think to take home with autoimmune encephalitis from this talk is, if a patient is behaving oddly, if anything doesn't seem quite right, and you think it could be attributable to the brain, it's really important to refer early to neurology. These conditions can be fatal if left untreated. They can result in status epilepticus. They can result in permanent brain damage as a result of insufficient treatment. And even with treatment, the outcomes can be very challenging at times. The therapeutic approach really involves a combination of steroids, plasma exchange, other immune therapies sometimes as well. But really, it can be quite broad, and the diagnostic process can be so hard that really, the earlier you start, the better. Now, acquired neuromyotonia is a slightly unusual condition for non-neurologists, and even amongst neurologists, it's not something we see often. It's considered a peripheral nerve hyperexcitability disorder, but effectively what it means is that your muscles become overactive for no clear reason. About 20% of patients who have an acquired neuromyotonia have an associated thymoma as well, so there is a strong link there, but it is still relatively very rare. It can be associated with the Caspr2 and LGI1 antibodies, which can also cause encephalitis, and I'll talk about when they come together in Morvan syndrome a bit later. The symptoms are varied. They can be extremely subtle, such as cramps or the odd fasciculation or twitching of the muscle, to the more unusual things such as myokymia or rippling of the muscles. And it's I was going to put a video in here, but I couldn't find a particularly good example of it on YouTube, but certainly the videos do exist on the internet. But it's a very unusual phenomenon. And when patients come to you and with a background of a thymoma and mention these unusual muscle symptoms, it's important to think about a possible underlying neuromyotonia or hyperexcitability disorder. Once it's suspected, again, it's a referral to a neurologist, because they can be tricky to diagnose, and it's easy to overtreat these because often they can be benign. The approach to management often involves an MRI, either of the muscles and sometimes of the brain, to look if there's anything associated, and predominantly nerve conduction studies, and in particular EMGs. Treatments vary. In people who are having really severe symptoms, immune therapy such as steroids, plasma exchange, IVIG, and other immunosuppressants may be needed. But in a lot of cases, something simple like carbamazepine, which is an anti-epileptic, can be enough to just settle down the symptoms, and the patient may not need any more. And in some cases, it's not bothering them and they don't need any treatment, but it's something that needs to be identified and monitored. When this can become more of a problem is in Morvan syndrome, and this is where you have the peripheral nerve hyperexcitability, but you get a whole host of other associated symptoms. You can get dysautonomia, so dysfunction of the autonomic system, excessive sweating, constipation, high blood pressure, things like that, and encephalopathy, which is one of the real hallmarks. It's hallucinations, insomnia, confusion, delirium. More often seen with Caspr2 antibodies, but can occur with either. And in the absence of a peripheral nerve hyperexcitability disorder, it just looks like an autoimmune encephalitis, and in many cases it is. However, in any case, much like with the previous mentioned ones, just refer to neurology early with these patients, because it can be life-threatening if it's not treated. And just as a short point, peripheral neuropathies. These are in some ways more challenging, because there is a huge selection of things that can cause peripheral neuropathies, many of them benign. A lot of the patients with thymoma are older and maybe diabetic and have a neuropathy from that. But if someone develops a neuropathy which seems to be moving quicker or in an unusual pattern, or you're just unsure, again, it's worth seeking a neurology opinion. There are some antibodies which can be treated, which can be identified and treated. Things like CIDP can respond very well to IVIG and plasma exchange. And again, there are things you can do to stop the disability that can come with a progressive peripheral neuropathy. So, hematological diseases. Now, this is far less my comfort zone, but I think it's really important for anyone who looks after a patient with thymoma to be aware, because it's unrealistic with so many different paraneoplastic syndromes to expect one specialty to identify them all. So anyone who's involved in the care should always have these at the back of their mind. Pure red cell aplasia occurs in about 7 to 10% of patients with a thymoma. Broadly speaking, it can be classified into congenital, acquired, or secondary, and secondary is the one that comes with a thymoma. It's an autoimmune disease, and it's characterized by normocytic, normochromic anemia, reticulocytopenia, and a marked reduction in or absence of erythroid precursors from the bone marrow. The symptoms are anemia, and because the decline can be quite slow, actually patients adapt really well, and they may not feel the fatigue as much. They may not look as pale as you would expect early on. They may not complain of the typical symptoms, particularly in our older patients who often, for want of a better, would expect to feel a bit tired. Younger patients will often notice it more when they're doing things. And in this case, again, referral to hematology is essential. The challenge is that, as I said before, anemia can be caused by lots of different things. But if you're seeing a really unusual pattern that's progressing quicker than you would expect and more than you would expect, a HB of 110 wouldn't worry you all that much. But if they're suddenly falling to 80 and you don't have a good reason, it's important to think of this. Symptomatically, transfusion is used early on, and resection of a thymoma can cause a remission in about a third of patients, but relapse is common. And then in those cases, adjuvant therapy with immunosuppression is needed, and you need to be careful. And really, you need to manage this with a hematologist. It's important. Now, one which is really challenging is Good syndrome. Now, the reason Good syndrome is difficult is, to say what it is, it's an immunodeficiency associated with thymomas. The thymoma usually precedes the development of the immunodeficiency, but not always. And that rule holds true for all paraneoplastic syndromes. They can all come before, during, or after the diagnosis of the malignancy. And that's where things can become quite challenging. And there are a lot of confounding factors often involved with something like Good syndrome. And the impact can be very broad, affecting most aspects of the immune system. And what you tend to see is a hypogammaglobulinemia, a marked decrease in B cells, a lymphopenia, and an inversion of the CD4 and CD8 T cell ratio. But the most common thing that people will see and test for is the hypogammaglobulinemia, and that's usually what starts the investigative process. Now, the typical symptoms are as you would expect with someone with low immunoglobulins, and that's persistent infections or atypical infections. Most commonly, as we'll see in a moment in the next slide, we see respiratory tract infections, upper or lower respiratory tract infections, and things like bronchiectasis often develop as a result. But what's really quite challenging with this is that a lot of the treatments we use for the other conditions, particularly myasthenia gravis, are immunosuppressants. And a reduction in your immunoglobulins as a result of rituximab therapy, mycophenolate therapy, even others like cyclosporin or azathioprine can occur. And therefore, there are often confounding factors, and the isolated presence of a hypogammaglobulinemia in itself does not guarantee a diagnosis of Good syndrome. Now, clearly, if the patient's not on anything else and has a thymoma, that would really raise alarm bells. But it is a difficult and not as straightforward diagnosis to make as one would hope. But it is treatable in a lot of cases, such as with subcutaneous immunoglobulin infusions and aggressive treatment of infections and prophylactic treatment. Therefore, if you do suspect an underlying Good syndrome, refer early to hematology and immunology, because they are the people who will be able to guide you with regards to confirming a diagnosis. And often then it becomes a bit of an MDT discussion. How long have they been on other immunosuppressions? Could they be contributing? Are there any other confounding factors? So it's really important to remember that. Now, this is just a little bit of an example of some of the infections you see with Good syndrome. Candida infections are common, bacteremias. There are some viral things such as CMV disease, but by far the most common are respiratory tract infections. Now, lymphocytosis can occur. This is often relatively benign and not problematic, and is usually asymptomatic. It can precede the diagnosis of a thymoma. It can be paraneoplastic, but it may not be. And again, this is one of those things you would want to refer to hematology for them to investigate appropriately if you saw a raised lymphocyte count, particularly a persistently or very raised one. And then we move on to aplastic anemia. So aplastic anemia is one of those which you will know relatively quickly, because it's a quite catastrophic bone marrow failure where the patients will rapidly lose red cells, white cells, and platelets, and they will have symptoms associated with that. Fatigue, bleeding, bruising, menorrhagia in women, and infections. So really the things that would normally set your alarm bells ringing with hematological malignancies, it's very much the same here. So if you do notice somebody's counts are dropping, even if they're not symptomatic on routine blood testing, it's really quite important that you have a low threshold for referring to hematology for that. And I think really the takeaway thing from what we've discussed so far really. And sorry, just before I move on, there are a few other conditions here just listed. This list is by no means exhaustive, and as I said, you could do an entire week on these paraneoplastic conditions if you wanted to. But really, the take-home message is there are certain monitoring of your patients with thymoma is important. It's worth checking immunoglobulins regularly, as we've already spoken about before. It's worth doing regular full blood counts. And actually, when you do these counts, really look at the results. It's very easy to look at a very slightly low platelet count and dismiss it, or a minor anemia and dismiss it and think, well, this is not too problematic. But actually, if there is a trend of things reducing and everything's reducing, then that should set alarm bells ringing that maybe something is developing, but it's not become symptomatic yet. So now we move on to something I'm a bit more familiar with, and that's myasthenia gravis and thymoma. So the development of MG can occur at any time during, before, or after a thymoma. And more importantly as well, or equally importantly, MG can occur years before or years after. And in some cases, their later development can sometimes signify a recurrence of a thymoma as well. So if somebody has been treated in the past and suddenly develops myasthenia gravis, have a really low threshold for imaging them carefully to look for a recurrence, because it's certainly possible. So, and ultimately, when it comes to treating patients with myasthenia gravis, be it with thymoma or without, our aim of our treatment is to have the patient symptom-free and in remission. Now, that can be pharmacological or complete remission. This can sometimes be done with symptomatic therapies like acetylcholine esterase inhibitors or pyridostigmine, or in some cases, further immunosuppression with steroids and various other agents is required. But our aim is always to have them symptom-free. It's not always achievable, but we always try for that. So, patients with MG and thymoma can vary hugely from the very mild to the life-threatening, and there is no hard and fast rule for telling them apart from patients who don't have a thymoma, other than the fact that if they don't have the acetylcholine receptor antibodies. So with thymoma, there are some MG features which are more frequently seen. So the more concerning symptoms, effectively, because the disease can be more severe in thymomas typically. So dysphagia is more common, shortness of breath is more common, neck weakness is more common. And actually, one which is probably not always appreciated enough is poor treatment response. So many patients will have could have normal symptoms, for want of a better word, milder symptoms, but just not respond to treatment no matter what you do. And in those cases, you should again just consider, have I missed a thymoma? Is it worth re-imaging or imaging for the first time if they haven't had it already? So in terms of the assessment, early on when you're suspecting myasthenia gravis or making the diagnosis, referral and assessment by a neurologist is important. This is partly because to confirm the diagnosis and start treatment, but also because there are certain indicators that someone's myasthenia may be brittle and may be at risk. And certainly when you're looking at treating an underlying thymoma with surgery, with radiotherapy or chemotherapy, identifying these early is important. And for example, we know that neck weakness can indicate imminent or existing respiratory problems and bulbar problems. And therefore, if we notice that on examination, and that can be quite subtle for someone who's not used to looking for it, then we can be a bit more careful and a bit more cautious. Early spirometry is very, very important. Generally speaking, speak with your anaesthetist if you're looking for you're planning for an operation. But what we tend to say is over 40 mils per kilogram, we're not too concerned. Over 60 mils per kilogram is normal, and kind of under 40 and certainly under 20, we really begin to panic. If you want to be a bit more comfortable with things, over a litre, you've got some time. Under a litre, you'll be referring to intensive care. But as it is, that's something which is discussed with the anaesthetist. The other thing I think that's really important to point out is even in a patient with a diagnosis of a thymoma, even if they're asymptomatic, it's really important to check the AChR antibodies at least once. And that's because they can often be positive in asymptomatic patients, and that can indicate the possibility that myasthenia will develop later. Also, in a lot of cases, the symptoms may be quite subtle and not be identified yet, but a careful neurologist and investigation might still pick something up, and therefore you can plan appropriately for when it comes to treating the thymoma as well. So the treatment aim, short term, we want the patient fit for surgery, chemotherapy, radiotherapy, or whatever else they may need. It's really important to consider the anesthetic risk, as in myasthenia, in patients with neuromuscular disorders, and certain anesthetics need to be avoided or used very, very carefully. And unless the anaesthetist knows that risk exists, they can't plan appropriately. So you need to give them that information so that they can look after the patient as best possible. And ideally, the less symptomatic the patient is preoperatively, the better their chances and the less risk of problems developing intra and postoperatively. How this is achieved depends on how urgently the operation is needed, the other comorbidities, and how unwell the patient is. And as I said, long term, we're looking for remission. So there are some guidelines which were published a few years back by the ABN, the Association of British Neurologists, and these are not necessarily specifically focused on thymoma, but they do give you a guide of how you manage myasthenia broadly. And there is a lot of variation amongst different neurologists, largely based on what the patient wants, what the patient's like, and kind of what the individual circumstances are. Generally speaking, the first step is acetylcholine receptor inhibitors. In patients with thymoma, that's often not enough, but sometimes it is. Second step is steroids. Now, whereas most inflammatory and immune conditions, steroids are typically started at a high dose and then reduced, in myasthenia you have to be careful. Starting steroids can make the disease worse in the short term. So we often start slowly at low doses, sometimes even alternating days, and then work up. If, however, a patient is an inpatient for other reasons and you're monitoring them closely, you can be more aggressive with that. But that's something that you've got to be careful of. And the third step, and what most patients will end up needing, is a steroid-sparing agent so that you can reduce the steroids in the long term and mitigate some of the side effects that come with it. And then what's really quite important, actually, is the treatment for crisis. So a crisis is, strictly speaking, considered severe respiratory or bulbar symptoms causing respiratory failure or inability to swallow or speak. However, often if someone's got really severe limb weakness, we'd still treat that as a crisis effectively because it's still very disabling. So from the practical aspects, pyridostigmine, very safe and effective. Other than a bit of stomach upset and diarrhea, actually most patients tolerate it extremely well, and even that is usually not so problematic. Therefore, it's one of those which actually we're quite happy for a non-neurologist to start if they're fairly confident of the diagnosis and the patient is awaiting review. What we tend to do is start it at 30 milligrams a couple of times a day and then work up from there. Steroids are more complicated. They're usually needed in thymoma, but if there are minimal symptoms, they're not essential. And often once you start steroids, you're kind of committed to them and it's quite difficult to get patients off it. And therefore, ideally, these should be started by a neurologist, because if you can get away without them, then you want someone there who can make that decision. And if they are needed, you need someone who can monitor them really carefully. And as I said before, we start at a low dose and increase slowly. In terms of steroid-sparing agents, this should always be done by a neurologist who's going to be managing it going forward. It needs careful planning with the GP for monitoring of bloods and adverse effects. This takes months to work, these steroid-sparing agents, usually a minimum of 6 months, often up to 2 years to see the full effect. And actually, as a result, delaying the start of this before or after operation doesn't really matter. If you start your mycophenolate a month before the operation, it's not going to have it taken effect by then anyway. So you would get on with treating the thymoma in most cases and start the steroid-sparing agent whenever the time is right. In terms of preparation for the thymectomy, as I said, an experienced surgeon and anaesthetist are so important with this, and that's why having the specialist centres who do a lot of these is really helpful. And at Oxford, we're very lucky in that respect. We have a huge myasthenia gravis population, and as a result, our surgeons and our anaesthetists are extremely experienced and are able to give really good care to the patients. Unless, however, there is a reason to operate really urgently, it's often better to take a bit of time ensuring the patient is optimised and therefore minimising the risk. Therefore, if there is a very minor, small thymoma that you don't desperately need to get on and operate on straight away, taking a month or two sometimes is the right thing to do if it means you can get the patient really stable and safe. However, that is a decision that needs to be made with the surgeon, the oncologist, the neurologist, the anaesthetist, and actually I should have said here the radiologist, as they will often be informing a lot of your decisions. Really, that's a discussion to be had amongst the team. So when you need a rapid improvement, what do we do? And that can be quite challenging. So if they've got bulbar symptoms or respiratory symptoms and neck weakness, severe limb weakness, and you're really worried about the intraoperative risk and them getting even worse, you want to give them a boost. The benefit of this boost is evidence has shown it reduces intubation period postoperatively, it reduces ITU admissions and the length of ITU stays, and overall reduces the hospital admissions. These risks are less now that we're doing far more keyhole rather than kind of open surgery, but the risks are still improved with if you optimize these patients. So the question then, when to do it, that is often a very challenging question, and there are a lot of things you need to consider. The first thing is that not all patients respond to IVIG or plasma exchange. Some respond to neither. Most will respond to one or the other or both. but you don't know which one, and we have no real way of predicting. Therefore, what you don't want to be doing is relying on giving these treatments shortly before the operation, then they don't respond, and then you're a bit stuck and with a patient who's not really been optimized. Therefore, giving it a bit early, 2 or 3 weeks, sometimes more, gives you some time to assess their response. In our general practice, what we try to do is give the plasma exchange first, where possible. The reason for that being that if they don't respond, you can then give the IVIG afterwards. However, if you give the IVIG first and then do the plasma exchange, you're removing a lot of the immunoglobulins you've given, which seems a bit counterintuitive. But not all places have plasma exchange readily available, and it's not always appropriate for patients. And when that's the case, you work with what you can. Apologies. Yeah. Okay. So effectively, other things to bear in mind very quickly: IVIG and plasma exchanges, they can cause other adverse effects such as increased thrombosis risk and bleeding risk, and therefore you need to be quite careful doing these too soon to the operation. Which one to give doesn't make any difference. They are both equally effective in all evidence. And the other thing to bear in mind is that post-operatively, there's a risk of crisis in patients. Around 2% of myasthenia patients will have a crisis post-operatively, and of those 2%, about 80% happen in the first 6 months. There are lots of risk factors, which I've listed here, and you can look at later, since given the time is a bit tight. And these are things to just consider when wondering whether or not the patient is at risk of crisis. The other thing to bear in mind is that sometimes patients post-operatively can develop new MG, particularly if they've had receptor antibodies beforehand. Often this happens in the first couple of years post-operatively, so it's important to keep them under observation for the post-thymectomy period. So in summary, lots of paraneoplastic syndromes, hence this talk being difficult to condense into 20 minutes. It's not reasonable to memorize them all, but it is important to identify, to know what exists so that you can identify them and treat them early. Thank you.
So we'll go straight to the panel discussion and some questions. We're running tight for time, so some questions, we had a lot of questions actually. Some questions will probably be more appropriate for the treatment section that will happen after lunch. Maybe Shalini, shall I start with a few questions that came through during your session regarding benign hyperplasia, thymic hyperplasias? Is it a risk factor for later development of thymomas or thymic carcinomas? Even someone had asked, or do they transform, or is there any evidence for that transformation?
I think the truthful answer is I don't know for sure. It's not something I've come across in the literature. And, I think we're only picking these things off late. So what we tend to do is we tend to follow these patients up. And if they show absolutely no other associated condition, I mean, if there is an associated condition, then there is a reason to explain why we see what we see. But there are no guidelines as such that, for how long should we follow these patients up for, but I haven't come across since I have been doing any transformation, let's put it that way. But we do discuss all of these patients, and we definitely, I suggest, especially in the younger patients, that definitely we need to follow them up. But exactly what is the length of the follow-up, I don't know.
And in terms of that kind of modality of follow-up, particularly as you mentioned, young patients, I assume MRI is probably just as appropriate given the less radiation with that.
Yeah, I mean, I think in centers who are comfortable to do MRI, that would be the preferred option. I do realize that, so lots of people have asked me, share your protocol, which I openly do. And it's available, if you read papers, it's widely available. But I think the expertise lies with the radiographers, because it's difficult to character, it can be a very small area. And, unless you're doing lots of these, you will not be able to confidently measure for a dropout in signal intensity. So I think if imaging is done, definitely MRI is preferable. But I think with people who are experienced and know what they're looking for. Okay,
thank you. And then Rebecca, we had a question about PET scans and the role of PET. How does that help with your decision making? I guess something on versus benign thymomas versus more malignant cases, and when do you decide to use PET over just a standard CT imaging?
I think you have to think about it as an adjunct. So if you've got somebody who's got clearly stage 4 disease, as with any malignancy, PET is there predominantly to help you to look for metastatic disease that would stop you performing radical treatment. So if you've got somebody who is elderly and not fit for surgery and you wouldn't be offering radical treatment, PET would be inappropriate. I think, again, similarly, it's a very large dose of radiation. So if you've got someone that has what looks like a benign disease, you wouldn't advocate PET because that's a large dose of radiation, particularly for a young patient. Just to add on to Shalini's point, I think my concern about radiation dose is obviously less problematic in an elderly population. And the majority of these lesions are in the elderly population. I think chronicity changes over time do really help us see whether or not we're suspicious something is malignant or benign. So you need to add together all of the imaging data that you've got, not just something between mortalities, but also chronologically. And I think PET is not as used as it is, for example, in lung cancer or lymphoma, but we do tend to scan most people who would have either resectable or treatable disease to look for malignancy and also to check for malignancy elsewhere, because you may have a relatively benign small thymoma, and their symptoms actually relate to malignancy elsewhere. One of my cases, I didn't actually show it, but they had a cecal carcinoma, and that was the cause of their lethargy. It wasn't myasthenia gravis. So PET's useful to look for METs, and it's useful to look for other disease that patients may also have, as well as a thymic lesion. With the exception, obviously, of the carcinoid and neuroendocrine tumours, in which case, as I showed, specialist PET like Dototec PET is extremely useful because it's more sensitive for metastases in that particular group.
Okay, thank you, Rebecca. I'm being asked to kind of wrap up quickly. So maybe just a question from Mohammed there. Thank you for your presentation, Mohammed. So we had to kind of run through the latter slides of it. How often do you see resolution of myasthenia gravis after the resection of the thymoma? Do you, I guess it's variable. Any comment on that?
I think I'd probably better deferring that to Dr. Late, as she's if she had speech, she's better placed to answer that question, I think. Dr. Late, are you able to unmute? Can she hear me? Can anyone hear me? So, in all honesty, not that often. We often patients will get a bit of an improvement. How much of that is an element of, for want of a better word, a psychological improvement because they feel something's been done and there's been an intervention? How much of it is a true improvement in their myasthenia? I don't think we often see it that much. What we in terms of resolution, what we do see more often is, for example, if a patient were to need, say they would need 20 milligrams of steroids to sustain them being relatively symptom-free, with a thymectomy, they may need 10 or no steroids, but a steroid-sparing agent instead. So rather than complete resolution, what we often see is a significant reduction in how much immunosuppression they actually need. And actually, that's really quite valuable, particularly with regards to the steroids, as we know that the side effects are dose-dependent. So if we can have the patients on less, that's better for them. But there are some patients who get complete remission, but it's a small percentage.
Okay, great. Thank you, Mohammed. And Angeles, we did have a few questions on the PD-L1 markers that you commented on in your presentation, but I think we'll probably hold those questions back for the next section after lunch, where we discuss the treatments, because as mentioned, the immunosuppression complicates the treatment of our patients with PD-L1 markers there. So we'll wrap up, and I think we're going to have a break now for lunch, and then come back at 1:15 to hear the next section, which will be on treatments in early stage treatments for thymic malignancies. Thanks everyone for listening, and I say thank you very much to all our speakers and those who are listening and submitted in questions today.
Hello, welcome back everybody. I'm very pleased to welcome you to the first of this afternoon's sessions where we'll be discussing treatments for early stage thymic malignancies. My name is Marie Eaton. I'm a clinical nurse specialist caring for patients with both lung and thymic malignancies, and I'm based at the Christie Hospital in Manchester. I'm very pleased to be joined this afternoon by 4 speakers. The first is Mr. Alan Kirk, who's at the West Scotland Regional Heart and Lung Centre, and he'll be discussing the robotic surgical approach in managing early stage thymic malignancies. Alan will be followed by Dr. Maggie Harris, who's a clinical oncologist based here at the Christie Hospital in Manchester, and she'll be speaking to us about indications for radiotherapy in this group of patients. And finally, I'm delighted to be joined by Sister Claire Haslop from the Royal Papworth in Cambridge, and also Sister Marika Colvin from Guy's and St Thomas's in London. Claire and Marika are also both clinical nurse specialists with a keen interest in caring for patients with thymic malignancies, and they're going to be explaining how the role of the nurse is key in supporting patients and their families, navigating them through treatment and beyond. There will be an opportunity for questions at the end, so please do submit the questions. I'm sure the speakers will be very happy to answer any questions that you may have. And in the interest of time, I'll hand over to Mr. Alan Kirk. Thank you very much.
Okay, Marie, thank you very much. And thank you very much, everyone, for joining us either contemporaneously or at a later stage. I've had a long-term interest in thymic malignancies and thymic diseases, and I'm absolutely delighted after nearly 25 years of working almost single-handed that BTOG, Sanjay and David have catalysed the development of this BTOG special interest group in thymus, and I think it's a really excellent way forward. Surgery, as many of you are aware, will be the mainstay of treatment for the majority of these rare diseases. However, we have decided to split it up. I'm going to deal with the early stage thymomas, and I will try not to stray out too much onto Mr. Andrea Bile from Guy's, his talk on more advanced disease. So surgical approaches, I've interpreted this in 2 different ways. Thank you very much, Steve. I would like to talk about the surgical incisions, how to get into the chest in the first place, and then perhaps more a philosophical thing on surgical approaches, how we deal with them, how we deal with the pathology interaction, and most importantly, how we deal with these really difficult patients where we don't manage to get all of the thymus resected. Next slide, thanks. So in terms of surgical incisions, the kind of thing we're looking about here is more and more of you from the thoracic oncology world will be seeing more, whether it's from screening or early stage lung cancer or CTPAs. We're seeing a lot, I believe, more than we used to 20 years ago, of small, undiagnosed, difficult to biopsy anterior mediastinal tumours, of which thymomas will be the most important part of these. CT, probably our most common modality, and you've heard from Dr. Shalini Datta before. Next slide, thanks. But more and more we're relying on trying to, in inverted commas, avoid the unnecessary thymectomy, use MR and sometimes PET technology to establish what needs to come out, what needs biopsied, what can be satisfactorily surveyed over a period of time. Next slide, thanks. Surgeons of varying hues have been operating the thymus for generations. Cervical, in my part of the world, in the west of Scotland, was often the province of the thyroid surgeons and endocrine surgeons, where because it was connected to the thymus, they had the expertise to do so. And a lot of the surgeons of the generation above me in the west of Scotland dealt with both myasthenia and thymoma through cervical incisions. And bizarrely, from a thoracic surgical point of view, one of the doyens of thoracic surgery from Toronto General, Joel Cooper, the father of single lung transplantation, published widely on cervical approaches for thymectomy. Next slide, thanks. Median sternotomy, when I grew up as a registrar and a newly appointed consultant, was the best way to expose the thymus, with or without an additional cervical incision. Get great view of the phrenics, great view of the diaphragm, great view of the gland itself and all the beating structures underneath, which can be a bit of an anxiety at times. And there was at one stage a dichotomy amongst surgeons, both endocrine and thoracic, which was the best way to deal with these things. Next slide, thanks. This debate perhaps ended once and for all with Alfred Jaretsky III's seminal work on extrathymic tissue and trying to get all this black thymic tissue that may or may not be malignant or myasthenic out through a cervical incision was thought, come the 70s and 80s, not to be possible. And therefore, for both treatment of myasthenia gravis through the MGTX trial and for the treatment of malignancy, thymoma and thymic carcinoma, a radical thymectomy is what is required. And this is a really important piece of work. Next slide, thanks. So in common, again, along the same lines as every surgical specialty has got its own minimal access, whether it's meniscectomy for cartilages, whether it's lap chole for gallbladder disease, and most recently was the publication or early publication of the Violet study showing that minimal access video-assisted thoracic lobectomy is superior to thoracotomy lobectomy. The thymic surgeons started doing video-assisted surgery as well. My own view is that when I started off doing this about 6 years ago, it was through a 3-port technique. Next slide, thanks. But there are exponents of subxiphoid approaches. When I was over in Shanghai for a time, we did them with a telescope through the subxiphoid space, but with the arms going through the pleural cavities, actually giving a very natural approach similar to most surgeons who did these open. However, it is a closed space, and this technique is reliant on having some quite complex and sometimes painful sternal retractors to pull the sternum away from the mediastinum. Next slide, thanks. There are also, as Eric Lim from Brompton is a great exponent of, uniportal subxiphoid approach, where everything is done through a small incision below the xiphoid. Next slide, thanks. And like most things in life, as robotic technology and other enhanced technology has taken over, my personal view, and you see my surgical team here, with registrar, first assistant, scrub nurse, I do the majority of these over the past 4 years by robotic surgery. Next slide, thanks. The magnification, the articulation, the degrees of freedom you can get to dissect things out of the mediastinum and preserve the phrenic nerve is absolutely superb. Next slide, thanks. Doing it with a surgeon sitting in the console in the corner, so the magnification, you can see the right hand forcep pointing at the phrenic nerve, which is a really, really important structure in the chest and in the context of myasthenia, with or without thymoma. Next slide, thanks. And I know the robotic surgery is an expensive commodity, but certainly my first 50 cases of robotic thymectomy here show a significantly reduced length of stay compared with open and VAT surgery. On the whole, fewer complications and no conversions from a robotic approach to thoracotomy. And the detail is not important in the bottom there, but by avoiding complications, reducing hospital stay, reducing conversions and readmissions, you can actually make the procedure not only very excellent outcomes for patients, but you can make it cost effective for your program. Next slide, thanks. So moving away from, I suggest to you, an arrogant statement for those who have access to robotics. I think for early stage thymoma, I think that, well, I don't think, I maintain that robotic approach is the way forward. We do a lot of lung resections, as Andrea does down in Guy's and others elsewhere in the country. But I do feel that if someone took my robot away for lung resections, I would mutter quite a long time, but just get on with it and do just as good a job at VATS. However, if you took away my robot for mediastinal and thymic work, I really would have a fit. And the general principles of thymectomy is, whether it's open, RATs, VATs, or whatever method you use, the principles should be total resection of the thymoma and the anatomical thymus, including the neck horns and mediastinal fat, clearing from left to right, from phrenic to phrenic, and from neck down to diaphragm. And again, another important point, I truly believe there is no place for thymomaectomy or partial thymectomy in the management of patients with thymic malignancies, and we should be doing this principle of any minimal access surgery is do the same job at minimal access as you would done at conventional open operation. And again, it doesn't matter whether you're doing it VATS, RATs, or open. You want to dissect, skeletonize, visualize the innominate vein, and identify and preserve the phrenic nerves. Next slide, thanks. Extending from open surgery at median sternotomy, with or without neck extension, to minimal access, minimal invasive surgery, thymectomy. In red are the overriding principles of minimal access surgery. There should be no rib spreading. There's no point. The sore bit in chest surgery is sternal or rib retraction. There should be no place for rib resection in minimal access surgery, and no division of the sternum. In the early days of VATS, which I think we're way beyond now, a lot of early pioneering surgeons would make a reasonably small incision and use the telescope as a light source for him to stick his fingers in. Here, nowadays, it should be completely thoracoscopic visualization of the inside of the chest, not manual eyeball. We really need safe retrieval of the specimen. I do not want to compromise anything. We take out a small, important thymoma. If you don't deal with it properly and it bursts and spews thymoma cells all over the pleura, you've done a major, major disservice to that patient. And although most of us will remove the specimen through an endoscopic retrieval bag, from a pathologist point of view, it's really key that we do get safe retrieval of the specimen. There's no point in taking out a 2.5 centimetre thymoma with an intact capsule and surrounding thymus through a 12 millimetre hole and then find out you disrupt the capsule, and then the pathologist cannot tell you whether it was disrupted already or whether it's something you did at the time of retrieval. So we do have to be thoughtful about the size of our extraction ports for these specimens, which, as long as you don't distract the ribs or break the ribs, it is a safe and comfortable thing to do. And at any stage, the mantra for minimal access surgery is conversion is a feature for patient safety. It is not a complication, and we should feel that conversion is absolutely mandatory if oncological principles are in any way threatened. Next slide, thanks. I do like in the old days, whenever they were, I used to take out the thymus by open or VATS, stick it in a plastic bag with or without formalin. It just was an amorphous mess, which made pathology reporting incredibly difficult. So I do like to pin this out. I don't have a pointer to show you, but really important to get the horns out of the neck. In this case, where there's a thymoma in the lower pole of the right side there, with all the fat around about it as well. I now pin it out on a board. Next slide, thanks. And using the surgical toolkit from the ITMIG Surgical Standards website, if you blow up on waterproof paper an A4 size of the mediastinum, you can very reliably pin out the thymus, which is really important for interpretation, as we'll hear for adjuvant therapies later on, where the at-risk areas are. So I would pin that out, and using other sutures or clips, identify to my pathology colleague exactly where I'm worried about. Am I worried about invasion of the innominate? Am I worried about invasion of the pericardium? Now, I did say that I was looking at this anatomical position here. I did say my talk was largely revolving around early stage with apparently intact capsules, good fat planes round about the thymus, separating from underlying structures. But the robotic platform has really allowed us to take minimal access surgery to a different level And over the course of the past year, 18 months, we've resected innominate veins robotically, en bloc with the thymic malignancy, partial SVC resection, pericardial resection, and indeed lung, where lung has been involved. Next slide, thanks. So unity in multiplicity, I have to say we've all been working in our own little cocoons with rare diseases. At the beginning of this, I'm grateful to Sanjay and BTOG and David for allowing us to get together, not just today for this education group, but to have a demonstrably UK national thymic interest group for to optimise the cross-fertilisation for the communication and delivering what we all want for our patients, which is to get the best treatment at the best time in the right environment. And outside of BTOG, which I've said on a number of platforms is the best multi-professional thoracic oncology meeting in the world, bar none. Second close runner-up is the International Thymic Malignancy Interest Group, which is a fantastic organisation, and I would commend to you the ability. Unfortunately, it is once again virtual later this year, but abstract call is out, and I really would commend all or some of you, given that it's virtual, we should all be able to attend this in due course. So with that, I will stop and thank you very much for your attention. I look forward to your questions later on. So passing on to the next, almost as a link, as I've already alluded to, the fact if a surgeon can take out a lesion, so be it. And if it's completely excised, R0, no transcrapulous transgression, in early stage disease, perhaps we don't need adjuvant therapies, but there are those that will. I'm delighted to introduce Dr. Maggie Harris, a Clin Onc from Christie in Manchester. Thank you very much, Maggie.
Hello, thank you, Alan. That was really, really interesting and actually does kind of dovetail on quite well to my talk. I work at Manchester at the Christie Hospital. I'm a clinical oncologist, and for the last about 15 years, I've worked closely with my medical oncologist colleague, Dr. Yvonne Summers, and with our thoracic surgeons to try and join up our management of our thymic malignancies. And with that in mind, I've seen all our patients who were considered for postoperative radiotherapy for the last 15 years. So my talk today, I've been asked to talk about the indications for adjuvant radiotherapy post-surgery, and also to discuss some suggested follow-up guidelines. So my talk's going to include about where radiotherapy might fit in thymic disease, and I will mention not only in the adjuvant setting, but some other areas, how we decide who might benefit from postoperative radiotherapy. I will briefly mention the radiotherapy technique, a suggested follow-up regimen, and then just summarise what I've said. So I think it's been really interesting today listening to everybody, but this is a challenge to work out who gets radiotherapy. Thymomas and thymic carcinomas, rare tumours. So the evidence that we have as such is retrospective, it's multi-institutional databases or small studies. So there isn't any grade 1 evidence for radiotherapy. And there is selection bias. There is a great variation in radiotherapy techniques as it's across many centres. And we know that these relapses can occur late and they're infrequent, so you need a long follow-up. There is also no toxicity data if you look at all the information that's out there. So this is a bit of a challenge to work out who actually will benefit from radiotherapy. So where does radiotherapy fit with thymomas and thymic carcinomas? I'm going to concentrate on this first bit, which is the post-surgical resection. And the aim of the radiation there is to reduce local recurrence in the mediastinum. However, radiation is also used as a definitive therapy in inoperable patients with or without chemotherapy, and that will be addressed a little bit in the next sort of session. We also use it in the treatment of recurrent thymic disease, and that can be in the mediastinum if they've not had previous treatment there, or even we've treated pleural mets where surgery was not possible. We also obviously manage, give radiation palliatively to manage or prevent symptoms caused by the tumour. And these patients can do very well and can last quite a long while, live good lives, even with some palliative radiotherapy. So when I was sort of researching this talk, I looked at large numbers of databases, guidelines. There are a lot out there. They are contradictory. They are very they said very little grade 1 evidence. We've based more of what we do kind of at Manchester, and what I've based a lot of this talk on is the ESMO guidelines in 2015. And I think that is what a lot of the UK would use, but they're not perfect. And I wanted to sort of bring perhaps a more pragmatic view of if you see a patient, how you're going to decide whether to give them radiotherapy or not. You have to bear in mind that most, even the bigger centres, as per the Notch guidelines, probably are only going to see 10, maybe 15 new patients a year, and there'll be a very broad spectrum. But a lot of centres and a lot of oncologists may only see one of these patients each year. So how do we decide who gets adjuvant radiotherapy post-surgery? So putting it simply, it's basically due to it's 4 things we look at. We look at the stage, and I will mention a bit about that because even that isn't easy. The histology, which again we've had an excellent talk on, the completeness of resection, and this esoteric patient-specific factors. I'm an oncologist. I spend a lot of time looking at kind of what is the benefits and the toxicity for this particular patient. So I'm actually going to spend a little bit of time on that as well, because that isn't mentioned in a lot of the guidelines. So talking about stage, it's actually quite challenging. We've had some talks on this, and the Masoka-Koga staging, which on the early stage basis on the capsule, and this is what kind of I was taught when I was training. However, we've now kind of, certainly in Manchester, we've moved over to the new TNM IPMIG staging, which is more what we're used to. It's a TNM staging. It translates to a stage 1 to 4. It relates to operability. It's based on the depth of invasion into surrounding tissues. However, it's different to the Masoka-Koga stage. And all the guidelines that you read, all the retrospective databases, they all use Masoka-Koga. And this I saw in a very recent publication from IPMIG in the J2O, just sort of illustrates what kind of, I think, who was mentioning earlier on, the differences. And what you'll find is that the TNM stage 1 actually is the old Masoka-Koga stage 1 and 2, and even a little bit of stage 3. The stage sort of 3s and 4s are more similar, but actually it's concertining those early stages into a much earlier stage. And certainly what I've been getting back quite a few of is quite a lot of T1As. And as best as I can sort of say, is a T1A, which is encapsulated or unencapsulated, with or without extension into the mediastinal fat. It's the best I can say to equate as close as we can to the Masoka-Koga stage 1. But, and the caveats are out there, we don't know yet how that TNM will relate to the previous management. So there is more information to be found. So with that in mind, most of the retrospective studies, and I agree with Alan on this, show no benefit for post-operative radiotherapy in completely resected stage 1, and that's Masoka stage 1, for all histologies. And I think we pretty much agree with that. For stage 2, this is controversial. My thought is there's probably likely little benefit if it's completely resected, unless you've got a thymic carcinoma. But that is controversial, and some of the guidelines in certain centres around the world would recommend radiotherapy for completely resected stage 2s. For stage 3 and stage 4, where you've got a lot more local involvement, we would certainly consider radiotherapy. What about histology? For thymic carcinoma, as I've said, we consider for the stage 2s. They are more likely, they're more aggressive, more likely to get some local recurrence. And for the more aggressive of the thymomas, there is varying opinions on this. Possibly with the B2s, B3s, they may have more likely localized recurrence, but there's no consensus. And again, I think our pathologist mentioned, if you look at the survivals, the patients who've got an A, an AB often don't do as well, but that's because they're older. So difficult area and not a definite consensus in that. What about the completeness of resection? So I think pretty much universal recommendations are that we would consider adjuvant, well, we recommend adjuvant radiotherapy for all histologies where they've had an incomplete resection. And obviously you are more likely to get an incomplete resection and a higher stage for more aggressive histology. And so often they tend to go together. And so what about the patient-specific factors? Not mentioned in most of the guidelines, but something that as an oncologist, I see all the time. And more and more, I'm sort of using this to make my decisions. You have to see, these are not lung cancer patients. These are thymic carcinoma. The survivals are 10 years. And they may range for a stage 1 to stage 3 of 50 to 80%, with local recurrence rates of less than 10%. Obviously, these are people who may well have had post-operative radiotherapy, but you've got to say these people do very well and live a long time. And these are large radiotherapy fields, and toxicity can be quite marked. So you need to weigh up the benefit versus the toxicity in your particular patient. We know that thymoma patients are at increased risk of second cancers. So in our very young patients, we've got to think about what might be happening 20, 30, 40 years down the line. We also have to think about the comorbidities, the performance status, the age. In an elderly patient, the toxicity from the radiotherapy may not be maybe more than the risk of their thymoma coming back. What size of field are you going to be having? And what other immunological conditions do they have? We have a patient with Goodpasture's syndrome who had already quite poor lung function, and we elected to survey that patient. And then on the other hand, we've got the myasthenia gravis, patients with myasthenia gravis. And I was interested listening to a neurology colleague. I've certainly had a patient who had myasthenia gravis, had a thymectomy, things improved, was delayed, referred to us. So by the time they came to us, they were 9 months down the line. And they did have an R1 resection, and when we scanned them, they'd got some abnormality come back in the mediastinum. Their myasthenia gravis symptoms had come back. We irradiated the patient and her symptoms improved. So somebody with a myasthenia gravis, I may be more likely, if they are an uncertain benefit, to push for radiotherapy. And what does the patient want? During COVID, some of my older patients didn't want to come for 25 visits when we talked about the pros and cons in those patients. And you've also got to think about the follow-up compliance. If you are going to survey a patient who maybe has borderline benefit, you have to have a good surveillance, robust surveillance policy and follow-up for that patient. Otherwise, it isn't going to be safe. So I'll talk a little bit about that as well. So the radiotherapy technique, what do we need? Well, you need really good pre and post-op imaging. You need the operation notes, and you need the histological, a full histological report, and you need good interaction with your thoracic surgeons. I've had a number of patients who've come recently who've had an uncertain margin where the pathologist couldn't fully comment on that completeness of excision. These were borderline cases with perhaps more toxicity would be from the radiation. And with there, having a discussion with your surgeon, are they pretty sure they've got it all out? Has it been a VATS where they might have, where again, I've seen Alan talking about how you can remove it all. Were they sure they got it all? Was there actually some disruption in once it had been removed or through the port? And I've had patients where actually the surgeon said, I'm really pretty sure. And actually I was happy to survey that patient. Again, if you're working closely with your surgeons, they will mark with surgical clips areas of likely residual disease, which means you can make your field smaller and more accurate. We would usually recommend radiation within 3 months of surgical resection, and the best radiotherapy you've got available, IMRT, VMAT, 4D. And what is the CTV? We would usually treat the whole thymic space, the tuminous extensions, i.e. the tumour bed with a margin, because these often aren't necessarily exactly where you might expect. There is no evidence for prophylactic nodal radiation. They don't often spread to the nodes, and so actually no benefit for that. You just get extra toxicity. And when I was looking at this, I heard, when I was researching this talk, there was some data a little bit about imprint, which is radiation for the pleura, which is given in mesotheliomas. However, with these patients, the thymoma patients have such good prognosis that the toxicity of this is likely to be too great, so that it's not recommended currently. I will say, however, that protons may become more used in this group, particularly in some of our younger patients. What about the dose? And again, looking at the notch information, there's obviously quite a variable doses that we give in this country. We tend to use the doses from the ESMO guideline, which I think are relatively sensible. Standard fractionation. And so adjuvant after complete resection, if you do give that, I said I give very little of that, 45 to 50 gray. Usually for our R1s, I would give 50 gray in 25 fractions using the surgical clips. For an R2, I would boost just that R2 area to another 10 gray. And if you are giving it this outside the scope of this bit of the talk, definitive radiotherapy with or without chemotherapy, you would take that up to 60 gray. And thymic carcinoma, you may take it higher again. And for palliative, standard palliative doses, and they do respond very nicely. So what about the follow-up guidelines? So we've based these on the ESMO guidelines, and I think they are sensible, and they are essential particularly if you're going to survey some patients. So what we would recommend is that all thymoma and thymic carcinoma patients should see a specialist oncologist, an oncologist with some sort of interest, hopefully relatively early on in their diagnosis, in their sort of at that meeting, they can have explanation about what thymoma is, because I said certainly 10 years ago patients didn't know. Often they were told it was a benign lump that had been removed. They didn't know that there was malignant potential, so they can find out what it is. They can have lifestyle advice. We know that they have an increased risk of second malignancies, so smoking cessation, sun management. We would also screen them for the immunological conditions. So we would do their anticholinergic antibodies. We do an immunoglobulin screen, serum protein electrophoresis, their routine bloods, and we would explain the follow-up plan. So the patient knows from the beginning what they should expect. We would always do a baseline CT scan 3 to 4 months post whatever your definitive treatment might be. So you've got now a scan. This can be actually quite helpful if you're not sure about radiation, to get one post-surgery, because it can tell if you are going to survey somebody, you can see if there's any changes. And our follow-up protocol would be for our completely resected early stage thymomas. We'd recommend an annual CT scan. These are the low risk group, an annual CT scan of the thorax for the first 5 years, and then consider 2 yearly CT scans up to 10 to 15 years, and then an open follow-up. Now, it will depend what your local setup is, whether you can do that in your oncology setup or whether you would use your respiratory team. It also would very much depend on the performance status, comorbidities of that patient. For our more advanced patients, thymic carcinoma, an incomplete resection, or if they've received radiotherapy or chemotherapy, so anybody who's slightly higher risk, we would keep them under our care. They would have 6 monthly CT scans for 2 years, and then annually. And again, needs follow-up for 10 to 15 years. And this is because if something does come back, you can treat them. We've certainly referred patients for resection of pleural mets, who've done really well, obviously having chemotherapy. So there is a lot that you can offer these patients, but I think you need to have a robust follow-up plan that you and the patient have agreed to for the future. So my take-home message, I'd recommend adjuvant radiotherapy if an incomplete resection. We would also consider it if it's a more aggressive histology, thymic carcinoma, or with advanced stage. And that's controversial for stage 2. You need to consider the toxicity versus the benefit in individual cases. They do require long follow-up, so you need to make sure you've got a robust follow-up plan for each patient. And please remember, these are rare diseases, and there is a lack of strong evidence. So there is a case for super-regional MDTs or just buddying up to centres who maybe have more experience to help us all learn. And we would also encourage contribution to the large prospective databases so that we can learn more about this rare condition and optimise the management for our patients. So thank you very much for your attention, and I'll be able to answer questions at the end of the talk.
Good afternoon. Our talk is entitled Nursing Support for Thymic Patients. It was prepared from collaboration with my 2 CNS colleagues, Marika and Marie. The 3 of us have experience in caring for thymic patients and a special interest in this rare tumour group. We declare no conflict of interest. You have heard how rare thymic tumours are, and CNSs with any expertise are even rarer. As referred to in Stephen's talk this morning, 90% of the centres they surveyed didn't have a CNS with thymic interest. There is nationally Marika Colvin at Guy's at St Thomas's Hospital in London, Marie Eaton at the Christie Hospital, Manchester, and myself, Claire Haslop at Royal Papworth in Cambridge. There may be others with an interest. Please let us know who you are and where you're based. We'd love to have you on board. As of May 22, our approximate current patient caseloads with whom we are interacting on treatment and on follow-up are as follows. In London, it's 60. In Manchester, 100 to 200. And in Cambridge, around 65. Around 12% of my current caseload I have been involved with and caring for over 8 years. I try to maintain a thymic patient database populated from the MDT meetings and surgical clinics. There is more data that could be collected, undoubtedly. My first contact in the pathway with suspected or diagnosed thymic tumour patient is any of the following. Accompanying the patient and carers within a surgical consultation, direct with the thoracic surgeon. At the investigation, i.e. needle biopsy of an anterior mediastinal mass when thymic malignancies in the differential. And as we've heard this morning, these are chosen more carefully to be done these days. I see them directly with the oncologist if thymic carcinoma or advanced thymoma or adjuvant therapy consultation. With a second opinion from the oncologist or for the surgeon from elsewhere, and by telephone contact to introduce myself and arrange further imaging as requested by the MDT, for example, an MRI scan, before they are seen in clinic. Marie's first contact is in the oncology setting, not the surgical. This slide demonstrates our CNS input to coordinate and facilitate care is being involved at each point in the pathway, starting with investigations through to MDT, to diagnosis and possible surgery or chemotherapy and radiotherapy, and into surveillance. In the advanced setting, it is making relevant community referrals and best supportive palliative care. But providing specialist information is the overarching principle which underpins these interactions. This can involve care and support over many years, guiding our patients through second and third line treatments. But also it is a pleasure seeing some young patients have and raise children despite the trajectory of their thymoma disease. Surgical support at Royal Papworth is a big part of my role. It can be a more sustained and intense contact during inpatient care. Preoperatively, I provide clarification of surgical information and risks given, answering questions and concerns, preparing for subxiphoid or sternotomy approaches using diagrams to help the patient, and provision of a surgical booklet or pack. It's a general thoracic surgical booklet. I'm starting a process of developing a specific thymectomy booklet with one of the surgeons, which I think will be helpful. Prehabilitation before surgery, or enhanced recovery as we call it, is well established in thoracic surgery. The 4 elements to concentrate on are good fitness before surgery and encouraging early mobilization post-op. Nutrition, the patient needs to be well nourished before they're facing surgery. Quit smoking and addressing any psychological needs. I liaise with other teams, immunologists, neurologists, anaesthetists, re any medication. And I regularly let the anaesthetist know if a patient has myasthenia gravis, and indeed the physiotherapists, or liaise with them with regard to these complex cases. Whilst an inpatient, I do ward visits. I explain the thoracic telephone link line, which we do in the first week of discharge. This is done by a CNS, going through the elements of recovery, such as pain, cough, wound, and bowels. The pathology takes around 3 weeks, and I explain this to the patient, and that it will go to the MDT, and then they will see the surgeon for a follow-up in the clinic. It can be an unsettling and worrying time for them waiting that 3 weeks. But I try to ensure that their concentration is on their recovery during that time. One example more recently is a young 30-year-old patient with myasthenia gravis who relied on TDS pyridostigmine for the hands and the muscle to function. And in fact, if a dose was missed, she wasn't able to shower easily. So I ensured the anaesthetist, the physiotherapist, and the ward team were aware of her coming in to have surgery. Anecdotally, in consultations with our patients, they've shared some of the following concerns at the time of their diagnosis, which they were worried about. For example, was it going to be benign or malignant? Closing that box off. The spread of it, how bad it is and how did it get there? How will I recover from the operation? Despite being told it's slow, it was worrying at first. Immediate thought was to get this thing out, and the rates of survival. We would like to undertake a more formal piece of research around this aspect of patient concerns and patients' needs around the diagnosis. Between the 3 centres, I'm hoping, of Manchester, Guy's and Papworth, and hope to get this developed soon. Rare cancers present a number of challenges. Much of this was actually covered this morning by Karen Ruddock in her excellent session. So I'll just go through it very briefly. The patient's isolation and anxiety and feeling scared. They're not aware of where to get information from, and sometimes that's very challenging to find. Patients get questions from their family members and want to know if he or she is seeing an expert. They are shocked by it being an incidental finding and a part of the body they've never heard of. They can be disadvantaged because there's little research or trials to consider. And it is being aware of the management of the conditions that go alongside thymomas, the immune system related disorders and myasthenia gravis, and the complexity that this gives. Macmillan Cancer Relief and Cancer Research UK have a good section for patients on rare cancers and how to deal with it. And we've heard this morning how excellent the support and advice from Thymic UK and information that they give. I will now hand over to Marika, who will expand more on the detail of the CNS role and oncology side of the pathway and her role as trustee of Thymic UK. Thank you for listening.
So for my part of the presentation, I'm going to look a bit more closely at how we support patients with a thymic malignancy from the oncology side of the pathway, as this is often when I am most involved and have more close contact with patients and their carers. But to start with, when I'm asked about the cancer clinical nurse specialist role, I think we often as nurses struggle to define and explain our role, although we know the importance and how we make a difference to patients. I've outlined on my first slide how the National Cancer Action Team report in 2010 on the contribution of the clinical nurse specialist highlighted what they felt were the main high-level activities of the CNS in the context of cancer care. And these came into 5 functions. I think these resonated with me, and I felt these go a long way to explain how and what we do every day. The first point was using and applying our technical knowledge of cancer and treatment to oversee and coordinate services, personalising the cancer pathway for individual patients, and to meet the complex information and support needs of patients and their families. We're also acting as a key accessible professional for the multidisciplinary team, undertaking proactive case management and using clinical acumen to reduce the risk to patients from disease or treatments, using empathy, knowledge, experience to assess and alleviate the psychosocial suffering of cancer, including referring to other agencies or disciplines as appropriate, using technical knowledge and insight from the patient experience to lead service redesign and implement improvements and make service responsive to patient need. Since working as a lung cancer clinical nurse specialist at Guy's and St Thomas's over the last 12 years, I've developed a keen interest in thymic malignancies, and more so in the last 5 years, I've managed a caseload of patients that I meet through our clinics. A more recent development in the last year is that we now have a designated thymic malignancy clinic, which is held on Monday afternoons. And we use this as an opportunity to bring new patients with thymic cancer. So we have a group of clinicians who are more familiar with thymic cancers and can make a smaller, specialised MDT. Our oncologist, our medical oncologist, a clinical oncologist and a thoracic surgeon can be present, along with discussions with the pathologist, and cases can be discussed. This creates and brings a more collective approach and draws on experience and knowledge together. We're also lucky that we have allied health professionals that specialise within lung cancer, including our dietitian, physio, OT, and speech and language therapist. And although we have 3 other busy clinics where patients may still be seen, especially those on annual surveillance potentially after a thymoma surgery, but we're still keen to develop this designated clinic on Mondays and feel it's a really exciting step forward for our patients. Often we're meeting patients at various points in the pathway. These can either be pre or post-surgery, either chemotherapy, which obviously can be given prior to surgery or after, the need for adjuvant radiotherapy, or in some cases, second opinion, which is often when patients come to a more specialist centre to gauge our advice and to see what management we can offer them. I'm going to look a bit more in detail at that next. So in terms of the specialist nursing support within oncology, and looking at when we meet new patients, often the CNS is key at this time because often overwhelming for the patient and their family. There's a lot of information to take on board, and there's a lot of, we need to give a lot of time to them to go over things, and often the CNS is pivotal to that. We make sure that we tell the patients we're there for them through this cancer journey. And it's often a comfort for them to know that they can come to us with whatever query or concern they have. It can never be too small. So our role is obviously as a key worker for these patient groups. We're giving information relating to their initial diagnosis, resources that are maybe available to them, and directing them to support through often Thymic UK. We're explaining the treatment plan, which obviously can be quite complicated, and they need time to go through potential side effects, implications which may arise because of the treatment. For example, obviously chemotherapy, we have to be mindful of fertility and hair loss and make referrals as necessary for those patients. We're alleviating their concerns, especially when it comes to potentially financial, social and family roles. And we complete a healthcare needs assessment when we first meet our new patients so that we can look at making referrals to services that may benefit them. And clearly there's a clear psychological support aspect which we're doing daily for our patients, either through phone contact or emails. While patients are on treatment, be that standard chemotherapy treatment or radiotherapy, we're looking at managing their toxicities and the burden of treatment on them. Signposting, supporting and liaising with our clinical teams. And often we have to understand the patient's associated conditions and how these are affected by treatment, and liaise with other specialists that they may be linked into. Our patients often then go on to surveillance, which again is a worrying time, and we're managing those patients with their fear of recurrence. And obviously, when they're having annual scans, this scanxiety is a real problem or a worry for them, which we obviously want to help. In terms of the importance of the CNS for thymic patients, I found that there are some key factors due to it being such a rare cancer group. We're always looking to manage each patient as an individual, but it can be multifaceted due to other associated conditions, and there's often complex and often challenges of the diagnosis, which we need to understand and listen to and be aware of, because this affects the patient and the families going forward, and often how they're managing and coping. Patients are keen that we understand the impact of the rare cancer and provide them with specialist advice. We need to ensure we know and follow the national guidance and have the most up-to-date information for them. And as it often can be a younger age group, it's keen that we have the right information and we give them transparency. As I talked about before, we're coordinating care within the multidisciplinary team, being a point of contact and stability for the patients, being an advocate and helping them make decisions, and obviously looking at awareness and developments in this area of thymic cancer and looking at research, and they often ask, what is there next? We're linking in with other patients. Obviously, if I'm aware of other patients that we link them through Thymic UK. And obviously, as we have patients on surveillance for a number of years or due to the nature of the thymic cancers, we may see patients for a long time. We form a close relationship with them, so we get to know them really well. And obviously this can be difficult if they come to the end of treatment options. We've already had a presentation from Karen, the founder and chair of Thymic UK, but I want to discuss a little bit more about my involvement in the group as a CNS and where we've got to up to the last 4 years. As Karen mentioned, our first meeting was held with 6 patients and their carers in June 2018 at Survivors' Day in the New Cancer Centre at Guy's Hospital. This is very much a patient-led initiative, and I remember how it felt really important bringing patients together with the same rare cancer. It's actually quite a breakthrough moment, and I could tell that bringing them together as a group, they were determined to come together and make a difference. This led to us looking at how we would work as a group and our aims and objectives. And obviously one of the key things is for research and access to treatments, as this is something that often patients struggle with receiving, so they want to know that things are going to move forward and there might be options for them in the future. We've looked at developing a website as a resource for patients, and I think it's really important that we have clinicians involved so that we can direct patients to these specialist areas. We had an educational patient day, which was very well attended at the Christie, which Marie helped us organise in December 2019. And we've also been to BTOG, which obviously the last meeting in person was in January 2020. And that's where we had our first Thymic interest group meeting. We worked hard to make the Thymic UK registered charity in January 2021. And I'm proud to be a trustee and work closely with the group to move things forward. As we have recently looked at our patient numbers, we found that we have currently 237 patients and carers on the Facebook page, but more have registered through our Thymic UK page. So it may not be a complete accurate total number, so we're just looking to look at our numbers. We're doing a lot of awareness, especially with obviously May being Thymic Cancer Awareness Month. And I'm obviously looking at how I can implement change things within my role. And LCN UK asked me to do a webinar last year, so that's something that was really starting moving things forward with awareness. As a group, we have virtual meetings currently, quarterly. And Marie and I are looking to be more involved with those meetings and set them up more frequently. So looking to the future. So coming together as part of the BTOG Special Interest Group, Claire, Marie and I are looking to see what we can do for the future within our roles in interest in thymic cancers. We've provisionally had some discussion about a potential CNS-led project where we can maybe do an audit to elicit concerns and patient requirements around and after diagnosis, and what their initial thoughts and needs may be. Claire's initially had some thoughts about developing at her hospital, the Royal Papworth, a specific thymectomy patient information booklet. And I've been involved in reviewing information about thymic cancer, so I hope to continue that. And then going forward, we're obviously trying to find if we can link in with other nurses nationally who have an interest in thymic cancers and can also be linked CNSs as well. That's something that's really important to us. And being involved in the BTOG Thymic steering group and also the IPMIG annual conferences that are held. Maintaining our thymic tumour local database, which we're all trying to do, I guess, in terms of trying to collate our data on patients, and looking to develop our role within Thymic UK. And obviously, that's a big part of that is awareness for primary and secondary care. So I've come to the end of my presentation. Thank you for listening. I'm going to head back to Marie and happy to answer any questions.
Welcome back, everybody. There were some excellent talks there from the members of our panel. Claire, unfortunately, wasn't able to present her slides, but she will record them for us and they will be available online alongside everybody else's presentations. Quite a few questions, actually, for our panel members. Alan, there's one or two questions for you, if you don't mind. some of our colleagues have asked, how many UK thoracic surgery centres have and use rats? And what about the resection of lymph nodes during surgery?
Aha. Can you just confirm, Marie, that you can hear me?
I can, loud and clear, Alan.
Right, thank you very much. Right, in terms of, this is the beginning of a journey. The robotic technology has been around with the urology and the prostate since about 2003. In UK, it's been about 2014 with Middlesbrough, Newcastle, and Guy's. But as I was just checking, 60% of thoracic centres have access to robots at the moment, according to my figures from Intuitive, and more are coming on stream all the time. My home patch of Scotland, our unit, all 5 or 6 surgeons operate Monday to Friday every day in one theatre. We get an additional theatre on Friday. We have been very lucky that because of our volumes, which is very similar to many other centres around the country, we can justify having a robot for thoracic surgical use alone. Other places have got to compete is perhaps the wrong word, but compete is the right word, with gynae-oncology, colorectal and other specialties. But I think the landscape of robotics in thoracic surgery will be completely changed over the next 2 years. I mean, in Scotland, Aberdeen are doing it. Edinburgh have got a robot. The thoracic surgeons are starting training soon. Newcastle up and running. Hull, Liverpool, Manchester aren't far away with their business case in. So I think the next couple of years will be great. I am not an apologist for robotics, and I realise for every enthusiastic robotic thoracic surgeon, there will be detractors for a number of reasons, that there is no level 1 evidence. It took us 25 years to get level 1 evidence that VATS lobectomy was better than thoracotomy lobectomy, so I'm not sure that we're going to get the level 1 evidence, and it is expensive. If surgeons elsewhere in UK do as good or better a job than I do in the robot by VATS, then so be it. But I think if we have this meeting in 2 years' time, you will find much better access. Now, I know I'm hogging this, the operation itself is fairly straightforward if you stick with my guiding principles of complete thymectomy. There's no reason why it has to be centralised. I think Andrea may say different with more complex resections and adjuvant therapies and more advanced disease, but any thoracic surgeon can do a thymectomy in early stage disease, and I'm sure that we'll ultimately get access to that for those that wish it, and also patient preference. As regards lymph nodes, I think lymph nodes, this is an anterior mediastinal structure. You should be taking the local N1 lymph nodes within the fatty pad from the thymectomy that you're already doing. When it becomes more paratracheal lymph nodes, which I think Andrea is going to talk about, it becomes more complex because you then are doing open operations through right or left chest. But I think we are not nearly as far advanced as the lung oncologists in terms of proper assessment, identification of local thymus lymph nodes. I hope that answers the question. Thank you.
That's great, thanks, Alan. Can I just ask as well, out of interest, so in some circumstances when our oncology colleagues, for one reason or another, get their hands on the patients before the surgeons, and we treat them with chemotherapy and radiotherapy, would robotic surgery be an option for debulking surgery in the future?
The vision that you get, the meticulous dissection, so if you've got a situation, and I would like to think, and I know you've said it tongue-in-cheek about getting your hands on the patients first. I think that should have been done through prior multi-professional discussion anyway. But in that situation where there is prior chemoradiotherapy for whatever reason, I think robotic, we know, and some of the guys in the States and Europe that have been doing this for much longer than we have in the UK will, in fact, be able to resect a nominate, do an en bloc lobectomy, take away the pericardium. So, yes, I think that is an option. The robotic platform has opened up the ability to get minimal access surgery with all its potential benefits to a wider population.
Excellent. And you mentioned earlier that patients obviously recover more quickly after robotic surgery. Do you find that psychologically patients cope better in the long term after robotic surgery rather than an open operation, if that's possible?
Right, I can answer that in several roundabout ways. We've now been going 4 years. We've done 120 thymectomies, and we've got not level 1 randomized evidence, but our patients go home median day 1 after thymectomy for early stage disease. Psychologically, they are sold this. We advertised our robotic program as an extension of our successful minimal access program anyway. So patients just want what's best for them, and sometimes they're asking for it, even when it's not appropriate. The psychology, I think, happens. Adults, on the whole, probably don't mind. They will just take everything in their stride. I'm involved with 3 young children under the age of 10 at the moment, admittedly for myasthenia, non-thymomatous myasthenia, but they are requesting / demanding thymectomy robotically by their parents and their neurologists. So psychologically, absolutely. Although median sternotomy is done day in, day out for cardiac surgery, I think we as a group underestimate the psychological impact of a median sternotomy in a developing young woman.
Absolutely. Thank you, Alan. Maggie, there's 1 or 2 questions for you as well, please, if that's okay. A question regarding clinical trials. What would your thoughts be for a clinical trial with radiotherapy versus no radiotherapy for our patients? And do you think that this would have to be an international trial?
It would be lovely to have some data, and I think probably the most controversial bit at the moment would be sort of the stage 2s. That's where most of the controversy is. I think the trouble is the rarity of them, and if you are going to have it international, you'd have to make sure that you agreed that we all had the same staging system, and that you agreed the follow-up and the radiotherapy technique. So it would be great. However, it would have to be international. The numbers are so small. As I said, we're quite a big centre. We get 10 a year. And that is across the whole gamut. And as I said, my thoughts, I am giving less and less radiotherapy. And I think probably also because we've got a good surveillance program in place now. But I think for me, it would probably be some of the more tenuous kind of indications for radiotherapy. And so yes, but I think it would have to be something that we would look at probably from the IPMIG platform.
Thank you. And I think you touched on it in your talk as well, but we've had a question regarding occurrence of other malignancies, particularly in the chest area, and future treatment of radiotherapy. So if there was invasive breast cancer, other cancers within the chest, is that a concern unique when obviously because you can only give so much radiotherapy?
Adds one of the factors that you'd put into your decision making. We've seen, certainly I can remember a couple of patients whose thymoma was diagnosed on their radiotherapy planning scan for their breast cancer. So breast cancer being one of the commonest malignancies, that is something that does coexist. And I've surveyed a patient who I might have given, who was on sort of borderline for giving radiation because they'd already had quite extensive radiation. It also can make it difficult to follow up because obviously patients with breast cancer can also get mediastinal nodes, and we've had a patient who was thought to have intramammary nodes from their breast cancer, difficult to biopsy because of comorbidities, and then finally was biopsied as they weren't perhaps responding as they might have done, and it was found out that they actually had a coincidental thymoma. So it's a kind of a complex area, but I think if somebody has already had radiation to the thorax, I would be more likely to survey that patient. if they were for somebody who'd had perhaps an R1 resection, and I would survey that patient and hold more radiotherapy if it was likely to progress. And as I said, at the moment we don't put any, there's no screening, but we would again have a low threshold for investigating somebody with new symptoms who had thymoma.
Right. Thanks, Maggie. And hopefully our patients, our thymic patients, have got quite a good prognosis. If there was a period of time, what would your period of time be before you'd consider reirradiation to the same area, or is it completely a no-go, irrespective of the time that's lapsed?
It very much depends on that patient, on the prognosis, and what radiation dose they had previously. So again, I've got a patient who's had a number of different cancers, and thymoma was one of those. And we elected, and he'd had previous radiotherapy, and we elected to survey him. But obviously, if he had got obvious progressive disease, then you would look at it at that point and the area. And if there wasn't a surgical option for him, which obviously you would try and go down, then usually you can start to anything over a year you can consider reirradiation, but the longer the better. And you have to look at the age of the patient, you look at the area that's going to be overlapped, and you look at the prognosis, and also any toxicity from the previous radiation. So it's a very individualized kind of decision, but it's not a complete no-no of reirradiation.
Thanks, Maggie. We've also had a question about proton therapy. Is this available for all thymic cancer patients? Or if not, would there be any trials that you're aware of in development?
No trials currently that I'm aware of. We certainly, I think it would only be in the young population. And I only know because we did have a patient a 19-year-old, who we were going to explore it. I don't know whether it is commissioned yet, but I think it would be in that young oncology group where you might put forward a case if you felt that that patient wasn't suitable for more surgery, which would be your treatment of choice. So if they, and I said the patient we elected to survey, but certainly if we had gone for radiation in that very young age group, we would I think we would have taken advice and seen if protons might be available. But it's very rare. I haven't got very many of that young patients, but I think it would only be, as far as I'm aware, in the young oncology group that you might be able to access protons, and that would be on an individual. You'd send it to the proton panel.
Fab, thank you. And during your talk, you mentioned about your rationale for radiotherapy after a complete resection. Do you mind just explaining a little bit more about what would make you choose or not choose to give radiotherapy to particular patients?
So it would mainly be in a more advanced stage. So if you had a stage 3 or a stage 4 the surgeon had managed to get a complete resection, or somebody who had a stage 2, or who had thymic carcinoma, perhaps a B2 or B3, so more aggressive histology. But in the main, a complete resection, I would tend to survey those patients. And I said the only other area I have seen sometimes is patients with myasthenia gravis, but in the main, a complete resection, I would, an early stage 1 or stage 2, I wouldn't recommend adjuvant radiotherapy. I just think they do so well, and the increased toxicity from radiation.
Thanks, Maggie. There's another question that's popped up just for yourself again. Is there a role for SABR to isolated pleural mets?
Again, ideally, you'd remove them by surgery. And when you have said currently, I think the last isolated pleural met we did with conventional fractionation. It would depend on the commissioning within your area, but certainly technically, if you've got a small area, I could see no reason why not, but it would depend on the commissioning and the availability. But yeah, you give the best radiation you can, and these patients do really well. Certainly you can get these isolated pleural mets, but actually, to be honest, I mean, Alan will probably comment on this, but kind of we've certainly some of them that they don't require a huge operation to remove an isolated small pleural met, and so in the last sort of couple that we've had have gone for surgery. But as I said, if surgery wasn't appropriate, we would discuss and find what they were eligible for radiotherapy, and SABR might be one of those.
Thank you, Maggie. Alan, could we come back to you, please? There's been another question regarding surgery. How would you manage a T1B surgically cleanly removed, non-adherent to the lungs, but reported as an R1/2 as tumour extends to the resection margin? Apologies if I've not made sense when I've read that question back.
Right, I don't quite know where that came from, but from what you say, completely resect. First of all, as I thought I'd try to go over to you, it's really important to know where that at-risk margin is. Your scenario that you describe should be completely resected. I think you said there was a bit of adherent lung, was that correct?
Yes, let me just cleanly removed, not adherent to the lung, but reported as an R1 or 2 as tumour extends to the resection margin.
Right, that is a real, and excuse my attempt to talk oncology language, but I've had this, the whole point about R1 resections, I'm teaching to suck eggs, is that there is a risk of local recurrence. And Nick Reed, one of my colleagues in oncology, tried to get this over to me in terms of analogy of if you've got endometrial cancer that is present on the serosal surface, there is a risk of pelvic recurrence. If you've got our tumour at the present in the intravaginal cervix in someone with cervical cancer, the margin is in free, in fresh air, if you like, and therefore he would irradiate an endometrial cancer in the pelvis, but not where there was tumour present on the cervix. And I sometimes feel that that's exactly the same as the thymus. Once you've got the lung collapsed out of the way, the surface of the anterior mediastinal aspect, the margin is fresh air. So I would survey that patient, having been absolutely clear that's where the at-risk margin was. Did that help?
I think so. Thanks, Alan. Thank you very much. There are one or two other questions that I... Sorry, Maggie, carry on.
No, I was only saying, I think that's the really important bit is the dialogue between the oncologist and the surgeon. It's essential because they've been in there, and unless you can actually watch that operation, which would be great, but if you can't, they've been in there and they actually know how that pathology, whatever, equates, and also for you where that radiation is going to go. So I think the dialogue between your oncologist and your surgeon is paramount, basically. Sorry.
Yeah, absolutely. Absolutely. Thanks, Maggie. There's one or two questions come through that may be more appropriate for the next session, talking about advanced disease. Just one or two questions from me, really, from Marika. It's really interesting to see a different nursing perspective, because we do tend to work in silos. There aren't that many of us, and we're dotted about across the country. And I'd just be really interested to ask your opinion about support for patients. I sometimes find it difficult to signpost my patients to places other than Thymic UK and to Maggie's centres, really, and Macmillan. Have you any tricks up your sleeve, or where patients can go for additional support and advice?
Yeah, no, I think it is difficult, and each patient is individual, really, aren't they? Because sometimes you can give them, the information about Thymic UK or ITMIG if they want to kind of, explore. But often, some of them aren't very keen to even, go down that route. But others are really keen to have everything they can. So it's kind of like gauging what their, what their importance, what important information they want. And often, sometimes even just linking with a patient as an individual rather than in a group. So I don't think I've got any particular other tricks apart from just kind of working out what that individual and family might need. And we're obviously quite lucky at Guy's, we have like an information centre, so we link them into Dimbleby and often the other information routes that way. But Thymic UK has been a big, a massive thing really for patients to have that nationally, bringing patients together, and even with Facebook and social media, I think things are changing.
Absolutely. Absolutely. I mean, do you provide any support packs or anything for your patients? It's a shame Claire can't be on the call as well. I, with my colleagues here at the Christie, we wrote a Thymic information booklet that we give to all our new patients and make a little information pack up for them. And I was just wondering if that's something that's done at other centres, or if we could collaborate on something to make sure our patients are getting equitable support.
I mean, with the Awareness Month, Thymic UK and ITMIG put together like the patient information. There's a new leaflet that they put together. So I'm currently going to disseminate that to patients, which I think we're all going to start using. So that's definitely important to put that in part of the pack. But with all new patients, there's often different things they might need. So that's something we're looking generally within lung cancer as well. So trying to tailor those kind of information packs and finding out what else might be appropriate to add to that. But no, I think it's a good idea. We have had information, but again, it's reviewing it and making sure it's current. So I think the new leaflet that we've got that we can send out to different centres as well, so they can give it out. So we're all giving out the same information. That'd be really good.
I found as well in my practice, I'm not sure if you and Claire will have done as well. Our younger patients tend to have a very high psychological need. And how do you manage that, making sure that everybody's given an equitable service, with the demands and the other part of your role in your lung cancer specialist nurse post as well?
No, it's difficult because there's a lot of information needs, and they require a lot of support. So it is quite intense, the relationship you build with these patients.
Absolutely.
So we can refer them on to psychological support that we have, but the waiting lists for things like that are quite extensive at the moment. So I think we find that we're doing a lot of that over the phone. You'll probably find the same, that constantly getting calls and emails and wanting updates and have we thought about this and can we do this? Can we access different treatments, for example, going forward? There's a lot of questions that patients have that is directed to offer the CNS. So that can be something quite challenging. So I think it's it's important that we recognise what we're doing, but hopefully try and access more support for us and more links with the psychology team. So maybe we can provide a bit more tailored care.
Absolutely. I think the three of us could talk about this all day. But in the interest of time, we need to bring the session to a close. It's now time for a refreshment break. Thank you ever so much for all our speakers. Apologies again that Claire wasn't able to join us, and look forward to the next session. Thank you, everybody.
Hi, welcome back. I hope you've had a good break and are raring to go for our last session, which is very interesting, focusing on advanced disease. I'm Pooja Jain, I'm one of the oncologists at Leeds, and I've got three speakers I'd like to introduce. Andrea Bele, who's a surgeon at Guy's, talking about surgery in advanced disease, followed by Yvonne Summers, who's a consultant medical oncologist at the Christie, talking about chemotherapy, followed by Professor Poppert talking about biological options and data. We all know Professor Poppert, and I'll hand over to the talks now so that there's no delay in them.
Thank you very much for the introduction and good afternoon, everyone. Thanks a lot for the opportunity to do this talk. I'm going to focus about surgery and advanced disease and the multimodality option from a surgical perspective. As you discussed before, surgery for early stage thymoma now is mainly done minimally invasive. For advanced stage thymoma, surgery is most of the time part of a multimodality approach when a discussions with radiotherapists and oncologists is crucial to decide what is the best treatment options for the patients. But despite or in difference from other cancer, surgery can still be indicated in recurrent thymoma. So, of course, for advanced stage thymoma, we normally require a multimodality approach. with multi-chemotherapy agents, you can appreciate and observe an excellent response to chemotherapy on the surgical specimen. And of course, for thymic carcinoma, most of the time, the multimodality approach is the preferred approach. For surgery, what is really, really, really important is achieve a complete resection, or aim to achieve a complete resection. In order to do that, it's important to work together and to have facilities where you can sometimes do joint procedure with vascular surgeon, cardiac surgeon, have the opportunity to use a bypass machine in order to be able to do whatever is needed, of course, if the patient is fit for that, to obtain a complete resection. As we know, the resectability is about 85% for stage 3, but goes down to about 40% for stage 4. And when you approach patient with stage 3 and 4, you need to be prepared that you may do complex vascular resection, you may have to do an extrapleural pneumonectomy or an extended pleurectomy decortication. As you have discussed this morning, patients with even stage 4, they can have a long survival just with chemotherapy. And thymoma is a completely different disease from lung cancer. You never offer such an extensive surgery for stage 4 lung cancer patients. But for thymoma, because you can clearly improve the outcome, even in advanced stage, you need to be aggressive if you can achieve a complete resection. Of course, in the highly selected patient, they're fit enough to go through such an extensive treatment. But if you choose the right patients and you can achieve a complete resection, you can have a survival of 35% at 10 years, even for a stage 4 thymoma. For stage 3 thymoma, only 50% of the lesion can be completely resected, but there's a lot of variability in the literature. I think that we should aim to get a 90% patients with an R0 resection, and this involves a lot of technical skills and experience, and as I said before, a big team of colleagues to work together. Of course, you know, personally, I've been lucky to train in New York and in Italy in referral center for locally advanced thymoma, and I've been used to work in this kind of environment. The postoperative mortality is low, and you may have a very good 10-year survival, but about 1 in 2, they may recur within the first 5 years. This is a case of a young patient, 51, who I did a right hemi clamshell, which is a combination of a sternotomy and anterior thoracotomy. She required a bilobectomy in order to achieve an R0 resection, and she had then chemo and radiotherapy. This operation was done over 3 years ago, and the patient is still free of disease. This is another patient presented, and at the time of presentation, there was involvement of the SVC. And every time I see an involvement of one of the major vessels, and of course, the venous vessels are more frequently involved compared to the aorta and the pulmonary artery, I normally prefer to start with chemotherapy, followed by resection. As you can see here, the resection was complicated by the fact that I had to isolate all the venous drainage of both upper limbs and the main SVC. And when I resected the tumor, I had to reconstruct the SVC. And again, we managed to achieve a complete resection, and the patient is still free of disease over a year after the operation. Regarding stage 4 is even more complicated because most of the time the pleura is involved. Sometimes a pleurectomy is enough, but if the visceral pleura is involved, or the diaphragm is involved, or the visceral pleura around the hilar structures are involved, then you need to consider even to go further and perform an extrapleural pneumonectomy. Of course, there's a wide range of survival rates has been reported, but even if you look at the lower one, at 40% at 5 years is still, to me, an excellent survival for a patient with stage 4 disease compared to other cancer we are normally dealing with. And I said before, you need to be ready to perform even an extrapleural pneumonectomy. You need to be very flexible in terms of approach. It could be a thoracotomy, it could be a clamshell, it could be a combination. Some patients have a sternotomy plus a thoracotomy at the same time. The mortality varies. Of course, it's higher in patients that have paraneoplastic syndrome or MG. And in thymic carcinoma with stage 4, I think that you need to be extremely, extremely cautious because the risk of recurrence is much higher. I think for thymoma, you can be more extensive or you can offer surgery in a lot of patients. With thymic carcinoma, you need to be extremely selective. This is a case of a young patient, performance status 0, presented with stiff neck. She had an MRI. The MRI picked up this lesion, which has been upgraded to a CT scan. Was judged unresectable. She came to see me, and I thought again it was unresectable at the beginning. And she had neoadjuvant treatment. Unfortunately, she only had 3 cycles because she got COVID. So we have to wait until the COVID pneumonitis was resolved. And then we proceed with the operation. So in this case, the operations involve a right extrapleural pneumonectomy and a reconstruction of the innominate vein and the SVC. Again, here, this case shows you the complexity of this surgery and how it's difficult to plan this surgery, because there are very few series that have done this kind of reconstruction. There are different ways of doing this reconstruction. As you can see here from the imaging, we have reconstructed both vessels, the innominate and the SVC, separately on the atrium. Why we have done that? Because when you reconstruct, as it is the usual anatomy, so the innominate vein to the SVC, the 2 meshes may increase the risk of blockage and clotting, first of all. But second, if you have to clamp all the upper limbs venous drainage, you need to put the patient on bypass machine. And of course, these increase the risk of postoperative complication. If you do this in stage, of course, you can avoid to use the bypass machine, and you can reduce also the risk of complication. Of course, I did this case with my colleague, Mr. Lucchese, is the cardiac surgeon. We do all these cases together in order to improve the outcome and increase the chances of being able to perform a complete resection. This is an imaging of the tumor. It was nearly 24 centimeter and with about 85% of necrosis and infarction, just to show that chemotherapy works. As you can see, there have been like few series published in the literature with small number, but you can see that you can achieve even in stage 4 thymoma a complete resection in over 80% of the patients, but you need to be confident and be ready to perform extensive vascular reconstruction. And you can see here the difference in terms of overall survival and disease-free survival. And as I was saying before, you need to expect that about 50% of your patients may recur within the first 5 years from your operation, even if you have achieved a complete resection. As you can see here, there are very small series. The biggest one was published by Cardillo. Most of the patients were thymomas. And you can see that the 5-year survival was pretty impressive in all the series, with a big of variability about a complete resection. But I think that in experience center, you should aim for at least 80% of complete resection, even in the advanced cases. This is another series published in the European Journal of Cardiothoracic Surgery. This was a multi-center series, and Guy's and St. Thomas was part of it through the European Registry of Thymoma within the European Society of Thoracic Surgery. And they look at pleurectomy, decortication, and EPP, and they showed a similar survival of both. And of course, the 2 negative prognostic factors were the thymic carcinoma and incomplete resection. I think why here there's no difference between PD and extrapleural pneumonectomy, because again, here what is really important is achieving a complete resection, and it's different from mesothelioma, which is more aggressive, and you know that you leave disease behind. Here you can achieve a higher, or you have higher chances to achieve a complete resection, and if you have to proceed and do an extrapleural pneumonectomy, you can. And the survival is not different because normally patients with thymoma are fitter and they are younger, and they may tolerate better an extrapleural pneumonectomy compared to patients with mesothelioma. This is another series done by Memorial and Sloan Kettering with a review of the literature, and you can see the numbers are small, and this is why, as was discussed this morning, I think that having a network like they have in France, when you have centers doing thymoma all around the country and discussing those cases, but having 2 or 3 centers highly specialized with a team trained and ready to take care or take on board those cases, I think is crucial to increase and to improve the outcomes of our patients. And again, this was, again, the survival to show that even in this American series, the overall and disease-free survival were pretty good considering a stage 4 disease. And the last part of my topic will be about the recurrent disease. So when you look at recurrent disease, of course, when you have a recurrent lung cancer, very, very, very unlikely you offer surgery. But you need to keep in mind the recurrence rate of thymoma, even after complete resection, may vary between 10 to 30%. In stage 1, if you do a full thymectomy, is about 1%. But it goes up with stage 3 and 4. And the most common site of recurrence is the pleural cavity, followed by the mediastinum. And if the average time between the primary surgery and the recurrence is about 5 years, but some patients may recover after 10 and 11. This is why I think it's quite important for this patient to be followed up for at least 10 years. Mainly if they're fit, because most of our patients are young and you can still offer further surgery to them. And surgery is an option because, as you can see from the data published in the literature in the late 90s, even a few years ago, if you add surgery, you can significantly improve survival. Of course, redo surgery is challenging again and has a higher risk of postoperative morbidities and mortalities. And I think a proper discussion in the MDT, proper inclusion criteria are quite important to offer the best treatment to our patients. This is an example of a patient that was operated in 2013, 68 male patients, stage 4A B3 thymoma, where induction chemotherapy had a thymectomy and upper bilobectomy with partial pleurectomy. And patients recurred in 2015 with a lung nodule and a chest wall deposit. So he had a wedge and I would say a completion pleurectomy to remove that nodule. It was fine, and then 4 years down the line, he developed a further recurrence on the left-hand side. Of course, from here, it's difficult to understand, was in the basal segment of the left lower lobe, very close to the diaphragm, to the stomach. There was a lot of discussion about chemotherapy or surgery, radiotherapy or surgery. Of course, radiotherapy may have some risk when the lesion is so low and close to the stomach. The radiation field is close to the stomach. So we decided to offer surgery. He had a VATS wedge resection, and he did well after the procedure. This is another example of a patient, 77 years old. Now she's 81. So I saw her my first year as a consultant, was 2015. She had her first surgery in 2005, followed by radiotherapy. I decided to continue a follow-up. And in 2016, we picked up this new nodule in the diaphragm. She had a thoracotomy and a partial diaphragmatic resection and pleurectomy. The histology showed, again, a B2 thymoma, R0 completely excised. And she is still under follow-up with us with no any evidence of recurrence. Of course, when the patient is over 80, you may argue if you still need to continue to follow them up. But I think that age is a number. If the patient is fit, you should continue to follow them up, because even if surgery is not an option, you may consider maybe a radiotherapy if the patient recurs in only one side outside the chest or within the chest. So in conclusion, surgery should be the treatment of choice for early stage thymoma. I do believe that minimally invasive surgery should be the best approach. And in the recent years, I think there's more and more evidence that robotic surgery can be better compared to VATS. But again, these are just technical difference. I think every surgeon should offer whatever thinks more confident. I think that is not the technique to use. What is really important is achieving a complete resection. Surgery should be considered as part of a multimodality approach in advanced stage thymoma or recurrent thymoma. Surgery alone unlikely works. or can work, but in order to maximize the results, surgery is always a part of a bigger picture of a multimodality approach. For me, long-term follow-up is crucial and recommended. High-volume centers, a tertiary referral center, should be considered for advanced thymoma, for recurrent thymoma, or sometimes even to discuss complex cases that can be done locally. But it's always nice to discuss those cases and have a network in order to, again, avoid to preclude or to exclude any patient for any possible treatment. As I said before, I truly believe that a national network may contribute to improve the outcome to our patient with thymoma. And I would like to thank you for your attention. And I will also take a moment to thank Sarah Bennett, who is one of the relatives of one of our patients with thymoma, who is helping us as a fundraising to raise money to do research in thymoma, and she's very supportive with us. And also some of our patients, like Karen, involved in the Thymic UK, and for all the help and the support they're giving us. Thank you very much.
Thank you very much. So I'd just like to thank the organisers for this opportunity today to talk about chemotherapy in thymic tumours. It's been a fantastic day so far, and it's been great to see so many people contributing to education in a rare disease. So I'm Yvonne Summers, I'm a medical oncologist in Manchester, and I've been looking after patients with thymic disease in a specialist clinic, specifically for patients with thymic disease, for about the past 10 years. And I work very carefully and closely with Maggie Harris and Marie, that you've met already this afternoon, and of course the broader multidisciplinary team. Those are my disclosures. So my talk this afternoon is going to be rather atypical for a medical oncologist. So you're not going to be inundated with lots and lots of Kaplan-Meier curves. It's going to be a little bit more basic than that. We're going to talk about which drugs, what is the trial data, what is the evidence that we have to guide our treatments, what real life data do we have, what does ESMO say about what we should be doing with patients with thymic disease? And then I'm going to look at just a couple of clinical cases that will bring home some of the points that we've discussed, and I'll leave you with some take-home messages. So this slide demonstrates some of the pathways for thymic tumours, and we're going to be focusing mainly on the right-hand side. So that's patients with locally advanced disease and patients with unresectable disease. And the reason that I'm focusing on those two areas is because you've already heard from previous speakers that that's where chemotherapy is most important. For patients with earlier stage, very clearly resectable disease, those patients will have an operation, and for the vast majority of those patients, they won't need any input from medical oncology. You've already heard some information about adjuvant therapy, and although we're going to talk about data for chemotherapy, there's even less data for adjuvant chemotherapy in those earlier stage disease patients, so I'm not going to focus very much on that, except to say it really is a very individual discussion. So the first thing to say that you've heard already, that there is limited evidence. It's mainly retrospective studies, phase 2 trials, and it's all pretty old now because most of the interest in research and trials in the systemic side is going to be more looking at immunotherapy and biological therapies these days. So these studies are all really quite old now. And the platinum drugs and the anthracyclines are the most important agents. And you can see in this table a variety of the chemotherapy regimens that are mostly used. And you can see most of these are multi-drug regimens. So CAP or PAC, the combination of cisplatin, doxorubicin, and cyclophosphamide is one of the most commonly used agents, combinations. And then platinum etoposide, of course, and carboplatin paclitaxel is used perhaps in the UK more in recurrent disease, but also has some role in thymic carcinoma. And then you can see some other agents, pemetrexed as a single agent, often for recurrent disease at subsequent lines, and gemcitabine, capecitabine, and oral etoposide. So what is the evidence that we have for primary chemotherapy? So primary chemotherapy is patients who have locally advanced disease, and we're entering into chemotherapy with the aim of a definitive treatment of surgery, hopefully, or possibly radiotherapy at the end of that chemotherapy. And you can see from this table, which brings together the evidence that we have for primary chemotherapy, that most of these regimens are combination regimens, including both platinum and an anthracycline. You can see that the studies are mainly phase 2 with some retrospective data in there. You can see that the numbers of patients involved in these studies are small, and of course that reflects the rare nature of thymic cancer. So in Manchester, we have a population of over 3 million, and we see about 10 new patients a year. So this really is a rare disease, and so conducting clinical trials is very challenging. And you can see that most of these studies had both patients with thymic carcinoma and thymoma, and all stage 3 and stage 4. What I'd like to point out is that in the primary chemotherapy setting, you can see those response rates. They're all pretty high, mostly above the 70%. And in these series, most of the patients then went on to have surgery. And the complete resection rates, as you've heard already, were a bit variable. So for some of the patients, perhaps with more advanced disease, with stage 4 disease, the complete resection rate's a bit lower. But most of these patients did go on to have surgery, with some of the patients going on to have chemoradiotherapy if surgery wasn't possible. And what evidence do we have for palliative chemotherapy? So again, we have a small numbers of patients in phase 2 and retrospective studies, and again using a variety of agents, predominantly platinum and anthracycline based, but also some data, as you can see on the study that's third from the top on pemetrexed. And again, you can see that response rates are reasonable. So response rates up to the 90% for the combination agents, the combination regimens, including platinum and anthracyclines. The study looking at pemetrexed with a lower response rate there was in patients that had previous lines of therapy. So there's a bit of a hodgepodge of studies here, quite heterogeneous, but those that are having chemotherapy at an earlier stage in their pathway with multi-drug agents with response rates that are higher. Earlier on this morning, David spoke about the Rhythmic group in France. So France have been really very proactive in managing thymic disease as a rare disease, and there is a great consensus, and you heard David describe this morning that there are 14 centres and 2 regional centres which offer advice on patients with thymic disease. And the Rhythmic group presented some data on chemotherapy about 3 or 4 years ago now in over 200 patients. And what you can see in this data is, for a start, the type of regimens that patients were having. So let me just explain. The pie chart's on the left-hand side, starting on the top left-hand corner. So A is patients having primary chemotherapy. So we would call that induction chemotherapy often. So chemotherapy as initial treatment with the aim of them having radical surgery or radiotherapy afterwards. And you can see that the majority of patients in France were having a combination of platinum and anthracycline, the PAC regimen, in 70%, with a little more, fewer patients having carboplatin paclitaxel, some platinum etoposide, and a small number of others. Then in the second pie chart B, this is patients who are having primary chemotherapy as their main treatment. So they are not going to go on to have surgery or radiotherapy because it's deemed at the outset that these patients are not going to be operable. So they're perhaps mainly stage 4B disease, but perhaps some stage 4A that are not deemed to be resectable. And again, you can see the same sort of selection of chemotherapy regimens. But then when you go down to look at the pie charts on the bottom, these are patients that have had recurrent disease, so first recurrence in C and second recurrence in D. And you can see there a broader range of chemotherapy regimens coming in, and obviously some biological agents too. And I guess that reflects that many of our patients with thymic tumours do respond to treatment obviously some of them do have recurrences, and subsequent treatment is possible. So again, as we've been talking about earlier today, thymic disease, very different disease to lung cancer. Many patients do well from systemic therapy and have multiple lines of treatment. And if you go on to look on the right-hand side of this slide, this gives you some indication of the response rates to the various types of chemotherapy. And the bar charts show in green those patients that have had response, in the orangey colour those that have had stable disease, and then the red colour at the bottom is those that have had disease progression. So you see for primary chemotherapy, those that are having chemotherapy up front with the intention of then going on to have a radical treatment, response rates are high both in the thymoma and in the thymic carcinoma groups. And as you go on to primary chemotherapy, so those patients where the disease is sufficiently advanced that we know we're not going to be able to treat with radical intent, response rates are a bit lower, about 30%, but similar response rates for both thymic carcinoma and thymoma. And then as you go across the various lines of therapy for recurrent disease, the response, not surprisingly, dropping off a bit, but we're still seeing response at second, third, fourth line treatment in patients with thymic tumours. So how does all that relate to ESMO guidance? Well, ESMO guidance does indeed suggest that we should be carrying out primary chemotherapy, induction chemotherapy for those who have initially unresectable disease with a platinum-based regimen in 2 to 4 cycles. Post-operatively, if there's an R2 resection, then further chemotherapy can be considered. And they also suggest that with primary chemotherapy, we should be offering CAP as the preferable regimen because of the combination of drugs probably having a slightly higher response rate. And the French data actually did show us slightly better outcomes with CAP compared to PE. They say that carbotaxol is an option for thymic carcinoma, and there's certainly some evidence for that and use, probably more in Europe than in the UK. In terms of adjuvant chemotherapy, they specifically say that adjuvant chemotherapy is not indicated for completely resected thymomas and also for R1 resected thymomas, and that it can be considered in patients with thymic carcinoma and higher stage disease, but the evidence for that is very poor and it is a case-by-case discussion. In terms of ESMO guidance, again, as we've heard from the surgeons earlier on, this is something that we should be treating aggressively. We should be treating as for primary disease, so surgery if possible. If surgery is not possible, considering radiotherapy for local recurrence. And as we've outlined, you can retreat patients. And actually, although we've talked about a number of different regimens, it's certainly established that if a patient has had a good response to treatment and then has a good disease-free interval, it's entirely reasonable to retreat with the same regimens again, which of course in patients who are going to live potentially for 5-10 years and sometimes obviously more than that, it's important that we try and get the most out of all of the treatments that we have because they may be having 4, 5, 6 lines of treatment in the long term. So how do I build all of that into my treatment considerations? How do I make decisions about the patients when we see them in clinic? It's important to remember that the evidence that we have is not as robust as it is for other diseases. We don't have any head-to-head randomized phase 3 trials, and so to some degree, there's not a clear right and wrong answer. So there is a lot of grey and there is a lot of nuance. We must remember that patients, as I've said, often respond to treatment, have a good prognosis, and that can influence how we manage patients. And we need to think about what the likely treatment plan is. And for me, making chemotherapy decisions, it's the nuances between where I go for a 3-drug combination using the anthracycline and the platinum upfront and CAP, or where I go for platinum etoposide. And the things that will sway me one way or the other tend to be things like, are we going for a primary medical treatment where we're really looking to try and improve the clinical situation so that surgery can be possible, and I really want to get a high response rate, and in that situation clearly would like to go with CAP. Is it thymic carcinoma where actually response rates are a bit lower and outcomes are a bit worse? So yes, in those sorts of situations I want to go for CAP rather than platinum etoposide. If this is, as we said, if the surgery is something that's likely, then I'm likely to go for CAP if we're expecting surgery and clear resection margins, partly because of if we are anticipating that perhaps we might not have a clear resection margin and there may be a big radiotherapy field, I may be a bit mindful about an anthracycline and potential long-term toxicity with anthracyclines in patients who may live a long time. And also, of course, there's then concerns about whether there's any pre-existing cardiac disease if we're thinking about an anthracycline and radiotherapy. So there's a number of fairly soft things that come into the decision making about whether we go with CAP or whether we go with platinum etoposide. But I think it's important to remember that there's not a clearly demonstrated substantial benefit from one or the other. So those decisions it's quite grey and quite nuanced. So having said all of that, I thought I'd just give us a couple of case studies to demonstrate some of the things that we've been talking about. So the first patient I'd like to think about is a 42-year-old lady who came to me in 2017. She'd presented to her GP with a chesty cough which hadn't responded to a couple of lots of antibiotics. She had a chest x-ray which was abnormal, and she was then referred for further investigations. She had nothing particularly significant in her past medical history. Like many of her patients and most of her patients with thymic disease, the majority of them haven't got a significant smoking history, and many of them are very fit. She then went on to have some further investigation, including a CT scan and a CT PET scan. And although she didn't report it, on direct questioning, she did admit that she'd had some fatigue and she'd noticed some intermittent drooping of her right eyelid, but hadn't spontaneously mentioned any of that. And when we checked her acetylcholine receptor antibodies, as we do routinely in all of our patients, in addition to immunoglobulins, we found that her acetylcholine receptor antibodies were elevated. She was referred to neurology at that time, but no intervention was deemed necessary because she was asymptomatic. So she went on to have, as we said, the scans, and you can see from what's written on the screen there that she had some disease in the right apex and also an anterior mediastinal mass, but she also had some unusual anatomy, and she had a right-sided aorta. The PET scan confirmed what was seen on the CT scan, and the lesions were of intermediate FDG activity. And she went on to have a CT-guided biopsy prior to treatment of the right apical lesion, which showed some sclerotic stroma, lymphocytic areas which were CD3 positive, with a high Ki67 of 80 to 90%. And on the original biopsy, she was thought to have a thymic carcinoma. So you can see on the images of the PET scan there, the apical mass and the anterior mediastinal mass with intermediate activity. And then on the CT images, again, you can see the apical mass. Then you can see a further pleural lesion on that middle CT scan, and then the anterior thymic mass on the lower CT images. So at that time, we decided to go ahead with primary chemotherapy with cisplatin etoposide, with the aim that we would hopefully get her to surgery at the end of chemotherapy. She had 4 cycles of treatment, which she tolerated fairly well and was still performance status 1 at the end of treatment. But the CT scan disappointingly only showed stable disease. So we discussed her again at the MDT at that point, and the biopsy had been reviewed. And actually at that point, the pathology review felt that it wasn't a thymic carcinoma, it was actually a thymoma. And so we went ahead with the plan for debulking surgery. But she did have fairly extensive disease. She had pericardial invasion at the time of surgery requiring a patch. She also required a right upper lobectomy, pleurectomy, a diaphragmatic metastectomy and a patch, although the phrenic nerve was intact. So she had really quite substantial surgery. And not only that, but she had some complications post-operatively. So you'll remember that I said that she was positive in terms of acetylcholine receptor antibodies and had some vague symptoms prior to surgery. But post-operatively, she had to be reintubated and actually had a myasthenic crisis, which was treated with intravenous immunoglobulins and actually subsequent pyridostigmine and then subsequently steroids. So she did recover, but she had a very lengthy post-op recovery and also had a chylothorax. So she had quite complex time post-op. And it was really important because although it made us review our guidelines, so although we routinely refer patients to neurology who have acetylcholine receptor antibodies at the time of diagnosis, we've subsequently written into our surgical guidelines that if there are any acetylcholine receptor antibodies, even if the neurologist has initially said that they don't need to have any treatment, they need to be reviewed preoperatively so that we have a plan in place. So this lady, having had very extensive surgery, the pathology from the surgery was that of a B2 thymoma. So we started off with thymic carcinoma, then we thought it was a B1 thymoma, but post-operatively decided it was a B2 thymoma. It was T3N0 M1A, and there was an R1, possible R1 margin in the thymic bed, and the surgeon had actually left some clips, importantly, in the area of concern. So she went on to have post-operative radiotherapy, 50 gray in 25 fractions, and I'm delighted to say that 5 years down the line, her myasthenia has completely resolved. So one of those cases where it has completely resolved. She's not on any medication for it anymore. She's back to performance status 0, and you can see from her imaging there from this year that she doesn't have any significant signs of recurrence at this time. So the second case that I wanted to just talk about is a slightly different situation. So it's a case of pleural recurrence. So this gentleman is a surgeon, and when he originally presented, he presented to another hospital with chest pain and was found to have a thymic tumour. Only past medical history was that of fairly well-controlled diabetes with no complications. So he went on to have surgery at another centre, and at the time of the surgery was noted to have pericardial and aortic invasion, and had not only his surgery but also post-operative radiotherapy back in 2009. He then had 6 years disease-free, but developed symptoms again back in 2015. And at the time, the initial scan didn't show any clear recurrence, but the symptoms persisted, and he had a further scan, which eventually did show this pleural recurrence on the diaphragmatic surface that you can see in that CT scan on the right-hand side. So he had further surgery, had the metastasis resected and some clips left in place, which you can see on the second scan on the right-hand side. And he was referred to me for consideration of adjuvant therapy at that time. So we had an interesting meeting. So he came along very much with the view that he was going to have adjuvant chemotherapy. That's what he'd been referred for. And I was a little bit more reticent about it because, of course, we are in a relatively evidence-free zone. And I was mindful of the fact he was working full-time as a consultant surgeon. He had a background of diabetes, and we were potentially talking about giving him platinum-based chemotherapy with obviously a risk of neuropathy. On the background of him having had a very good disease-free interval between his initial surgery and then the recurrence resection. So we had quite a lot of discussion about it, and actually I think this is a gentleman that I spoke to David about, so we had a lot of discussion with colleagues around the country. And eventually we decided that we wouldn't go ahead with adjuvant chemotherapy and we would simply monitor. And I'm pleased to say 7 years on, he's still disease-free, still working with no problems with neuropathy. So he had a good outcome. And the reason that I wanted to talk about him as a case is because making decisions about treatment is difficult, but it's actually probably relatively easier to make treatment decisions where the decision is to treat. And sometimes, particularly with thymic tumours where outcomes can be very good, actually the option to not treat is a very good one, but it can be difficult to explain that to patients as to why maybe it's not the right thing to go ahead with treatment. So difficult decisions both in terms of treatment and not treatment. So what are my take-home messages? Thymic epithelial tumours are rare, but they have much better patient outcomes than other thoracic malignancies, as we've heard repeatedly today. The diagnosis can be difficult, often requiring specialist pathology review and MDT review. The overall response rates to chemotherapy, to primary chemotherapy, are high, 60% or more. They tend to be a bit higher in thymoma rather than thymic carcinoma, and patients often respond to multiple lines of chemotherapy. The outcomes, of course, are very good. The 10-year survival for stage 4 is still about 40 to 50%, which is phenomenally good compared to most of the other cancers that we treat in thoracic oncology. It's a little bit less than that for thymic carcinoma, and the outcomes are obviously less good there, but still the outcomes are good. The evidence base is clearly limited, but combination treatments including platinum and/or anthracyclines are the most important drugs. You should also consider other associated conditions which may or may not respond to treatment, such as Good syndrome and red cell aplasia that we've heard about earlier on today, and also considerations such as myasthenia gravis, and all of the MDT need to be aware of some of these other paraneoplastic syndromes that can occur with thymic patients. As we've heard, aggressive combination treatment, often trimodality, is used, including in stage 4A disease. And recurrences can be late, often 5 to 10 years, and they should be considered in a similar way to the primary cancer. So local therapy may be used in addition to chemotherapy for recurrence. Thank you. So I'd like to hand over now to Professor Popat, who's going to talk to us about biological therapy.
Thanks, Yvonne. Thanks for that wonderful presentation and setting me up so well to talk about biological and targeted therapies. So this is clearly a very hot area, and as everywhere we've talked about this whole morning, we have limited data on which to go on. So let's dive in and talk about where we're heading in this field. So these are my disclosures. So we've heard this morning and throughout the day about the ESMO guidelines, but I think there are two major sets of guidelines for therapies that we need to know about. The first of these are the clinical practice guidelines for thymic epithelial tumours, and in terms of systemic therapies, we also see neuroendocrine tumours of the thymus as well, and we shouldn't forget about these tumours. We all come across them from time to time, and ESMO have published a set of guidelines for neuroendocrine tumours of the lung and thymus, and we should all read these. So if you want to go to sleep now, that's absolutely fine. I've got a few more bits of wisdom to say otherwise, but the essence of the talk is covered in these two guidelines. So I would suggest that to understand biological options, we need to understand the biology of thymic malignancies, and to understand that, we have to understand pathology. So I would suggest having a good grounding in the pathological basis of the tumor that you're treating is actually fundamental to understanding any of the biological targeted treatment options that we have. And we have two fantastic publications that have summarized this. So the first is the latest 2021 update of the classification of thoracic malignancies by the WHO. And even as an oncologist, I would urge, if you get access to this blue book, have a read about it, because it really does help define how we classify our thymic malignancies from a pathological viewpoint. And in the right-hand side, we have this very nice update, which is the summary of that blue book, which is published in the JTO last year, which actually includes two UK pathology authors, Dr. Nanaka and Dr. Nicholson. And it's great to see this UK leadership in this international field of thymic pathology summarization. So what about biological agents? Well, our history for biological agents goes back some time ago. In fact, back in 2004, Dr. Laura published the ECOG phase 2 trial in patients with thymic malignancies that had relapsed or were metastatic, that were undergoing treatment with octreotide. Now, these patients were predominantly low-grade tumors that went into the trial, mainly thymomas, one thymic carcinoma and a handful of one thymic neuroendocrine tumor, a handful of thymic carcinomas. And these patients were allowed to have octreotide, and some of them were allowed to have the addition of octreotide together with steroids. Now you can see in my summary in the bottom of the slide that the response rate was 30%. That's not far from what we're seeing for some forms of chemotherapy in the relapse metastatic setting. And the addition in the top right-hand side of the Kaplan-Meier graph of steroids together with the octreotide seemed to have a slightly higher progression-free survival than just the octreotide alone. So that is something that should be considered. We often forget about octreotide, and personally I would generally consider this for the lower grade, much more indolent tumours and tumours where we haven't really seen a benefit from chemotherapy because the proliferation index, for example, may not be very high. So taking this further, the next logical step is, should we be considering peptide receptor radiotherapy for these patients? Well, we don't really have data to suggest that, but certainly the most recent data from colleagues at the Mayo Clinic and others have demonstrated that these tumors do express somatostatin receptors, but this is very histologically different across different subtypes. So for example, the higher grade neuroendocrine small cell carcinomas have higher expression, as you'd expect. The more lower grade thymomas, much lower expression, 15%, in your typical squamous cell carcinomas, about 70%. And there are individual case reports talking about PRRT for patients with thymic malignancies. Of course, this is not commissioned and we don't really have much data, but this is one option that I think will develop over the course of the next few years. But really, much of the data that we've been looking at have been looking at what is classified as either targeting angiogenesis or the growth of vascular structures within tumors, or dirty kinase inhibitors, where we don't really know what the target of these kinase inhibitors, but we see some activity. And the classic example of this is sunitinib. Sunitinib was one of the great hopes for kinase inhibitors many, many years ago, and in some tumor types such as renal tumors, it really was standard for many a year. And in thymomas, we definitely, or rather I should say thymic epithelial tumors, we definitely see some activity. So this is the NCI phase 2 trial in which 2 cohorts were evaluated. We had a thymoma cohort and a thymic carcinoma cohort. You can see in the waterfall plots on the top right-hand side of the slide that there seems to be much more activity in thymic carcinomas than we can see in thymomas, and that does translate to a higher rate of response in the thymic carcinomas than we're seeing with the thymomas. It's very hard to talk about progression-free survival because by definition thymomas will have a better progression-free survival than thymic carcinomas, just on the prognostic impact of the tumor itself. But the median PFS is documented in the slide over there. So sunitinib definitely is an option for our patients, and very much so for our patients with thymic carcinoma. Now, within thymic carcinomas, there is heterogeneity of these types of tumors. We tend to see some thymic carcinomas which are fast growing, some thymic carcinomas very slow growing, low proliferation index. Personally, these TKIs are more beneficial in the lower end of the carcinoma activity spectrum than the widespread, rapidly turning over carcinomas, which I think are probably better suited to chemotherapy. The other important thing is that sunitinib is now generic. It's no longer a high-cost drug, and so this should be accessible for your cancer center, as it's no longer classified as an extremely expensive drug with generic versions available. The other study which has looked at this is the Remora trials, and here my Japanese colleagues used another dirty kinase inhibitor called lenvatinib. It's very similar in terms of its function to sunitinib. It hits many different kinases, some involved with angiogenesis. Now, this was a single-arm phase 2 trial run in Japan. All patients had thymic carcinoma and received lenvatinib. The predominant histology was squamous cell carcinoma, and you can see really a relatively modest but impressive response rate, with nearly every single patient having some evidence of shrinkage on the waterfall plot on the right-hand side. And if you look at the spider plots, you can see that even those who didn't achieve the criteria for response still had durable, stable disease during the lifetime of this study. Now, those of you that have used lenvatinib will know that it's a tough drug. It is not a straightforward drug to give at all. It has a lot of toxicities, and in this study, every single patient needed a dose reduction, and I think that's reflective of the adverse events that are seen with this type of drug. Now, the drug is not licensed, and we don't have NHS funding for use in thymic malignancies. But if you don't ask industry, you don't get. And I would suggest that because thymoma is such a rare disease, it's not unreasonable to ask the manufacturer to see if there's access for this agent. Well, what about other targeted drugs? The other target that we've used is everolimus. This is another relatively old now kinase inhibitors, which switches off mTOR, central hub of cell signaling. And this is an Italian phase 2 looking at 2 cohorts, thymomas and thymic carcinomas. Very small study given the rarity of the disease. But again, you can see, there are some patients that do benefit on the waterfall plot. We're seeing a little bit more benefit in terms of response rates with thymic carcinomas than thymomas. Again, difficult to read too much into the time to treatment failure or median progression-free survival because of the prognostic impact of thymomas. But again, this is a potential option, I would suggest. And again, everolimus is no longer generic on patent. It is now generic, and you may wish to consider access to this in your particular site. But you have to be careful. Again, everolimus can be a tough drug, and in this particular series, nearly half of the patients with thymoma did develop some form of drug-induced pneumonitis, which is, challenging. And certainly we know that everolimus is associated with pulmonary sepsis. So there are challenges with both everolimus, lenvatinib, and sunitinib in delivering it. Every single patient that walks in through the doors, at least I see, wants to know why they can't have an immune checkpoint inhibitor. And I would always say think twice before considering this is an area fraught with danger. Now, we do have some data to support immune checkpoint inhibitors. There have been 2 trials of pembrolizumab, 1 trial of avelumab, and 1 trial of nivolumab. And there is another trial ongoing, which I'll come to later in this presentation. What you can see here is I've highlighted the response rates. And what we can see is that only about a quarter of patients, thymic carcinoma or thymoma, are benefiting. So this is rather modest response rates. Nevertheless, these aren't the response rates we're seeing with what we would suggest as high activity, such as PD-L1 high non-small cell lung cancer, but some patients do derive durable, stable disease. However, in a disease where there is high levels of autoimmunity, generating more autoimmunity is potentially problematic. And this is the problem that we've seen. Indeed, the trials that have evaluated thymoma, this is a trial of avelumab and a trial of pembrolizumab, identified very high rates of myocarditis, nearly 50% of patients having myocarditis. And in the trials of pembrolizumab in thymoma, there were several toxic death from autoimmunity. Clearly, this is not the right way forward, and I would suggest that immune checkpoint inhibitors in thymoma is a complete contraindication unless you're at the higher end of the spectrum, the B3 thymomas, where you clearly have documented no evidence of autoimmune disease. And even then, this is an area where we're trying to generate some data. It may be something that you might want to consider in thymic carcinoma, but unfortunately, it's not licensed and it's not routinely available. What does the data show? This is Bepi Giacconi's phase 2 trial of pembrolizumab run from the NCI, and you can clearly see that in many patients who respond, the benefit in the spider plot here is really durable. And even in patients that don't respond, we see many patients with durable, stable disease. And in the right-hand panel, we can see that the amount of PD-L1 expression tends to be associated with the probability of deriving a meaningful response. Now, as ever, PD-L1 is a really poor biomarker. We don't really know how to interpret PD-L1 in thymic malignancies. We don't really have a very good scoring system. So the whole area of immune checkpoint inhibitors with thymic malignancies, I would suggest, is one where we still need to do lots of evaluation and research. Speaking of which, we have a trial ongoing, which is the EORTC ETOP Nivo Thyme trial. This has closed cohort 1, which I'll talk about in a minute, and cohort 2 is still open and recruiting for suitable patients with relapsed thymic carcinoma or B3 thymoma without any autoimmune conditions and are negative for autoantibodies against acetylcholinesterase. In cohort 2, patients will be given Nivo-IPI combination in a single-arm phase 2 study. In cohort 1, patients were recruited and received nivolumab, 49 patients across Europe, and Nicolas Girard presented the data at the ESMO meeting in the fall last year. Now, the activity was rather modest, I would suggest. As investigators, we were hoping to see response rates in excess of 40%. The response rate achieved was less than that, so the trial didn't meet the planned endpoint, but nevertheless there was activity, and you can see in the Kaplan-Meier plot on the right, there are some patients with durable progression-free survival. So activity here, it has been, as we've seen in previous studies, but not dramatic with nivolumab. Undoubtedly, there are some patients who do benefit. The Nivo-IPI arm is ongoing. Then finally, there are what I call jackpot malignancies. It's a bit of an anachronism to call this jackpot malignancies, but these do occur, and these are patients with KIT mutations and thymic carcinomas. So if you have a patient with thymic carcinoma, you must always try to look for KIT mutations. They occur in about 15% of patients with thymic carcinomas, tend to be KIT IHC positive, tend not to be expressing neuroendocrine tumors, and in the handful of patients that you can identify and have been presented in the published literature, they do benefit from KIT inhibitors like imatinib or sunitinib, and do behave like gastrointestinal stromal tumors. We should always look for NTRK fusions. Thymic malignancies aren't a classical malignancy when we are expecting to see NTRK fusions, unlike rare types of pediatric tumors, sarcomas, or salivary tumors, but the occasional case has been identified. This is one case presented with a NTRK3 EIF4B fusion responding to entrectinib, and as all of us know, NTRK testing is funded by the NHS, so I don't think we've got anything to lose with our patients being tested for NTRK. Finally, we have a number of genomic studies of thymic malignancies, and these have really evaluated all our thymic epithelial tumors. We know that type A's have this GTF2I mutation, which is classical and is associated with a good prognosis. We have some tumors associated with HRAS and NRAS mutations. I would suggest these patients should be evaluated in trials of MAP kinase inhibitors. We see CDK with chromosome 16 loss in patients with thymic carcinoma. We're not quite sure what that is associated with. Finally, some patients are associated with microsatellite instability, so do take a family history. Maybe the patient belongs to an extended Lynch family syndrome, and you can identify this from NGS, where you'd find a much higher mutational burden than you would expect, and it's not unreasonable to look for mismatch repair deficiency by IHC on your diagnostic specimen as well. A couple of rare histological subtypes just to finish up on, but we do come across patients with thymic neuroendocrine tumors from time to time. These are thymic, either high-grade neuroendocrine tumors or low-grade neuroendocrine tumors. We know from pathology that Ki67 is not a good classifier. We still need to use mitoses per high-powered fields. We know that nets in thymic tumors are really much poorer prognosis, and the survival tracks to that of thymic carcinomas. That's excellent work from the ESTS dataset. We have data that suggests that the low-grade thymic tumors should be managed like a pulmonary carcinoid. and we don't really have a good data set for how we should manage our high-grade neuroendocrine tumours. We also come across nut carcinomas. These are not really thymic malignancies, but can sometimes be central and arising from thymic structures. These are classified, as we've heard previously, by nut BRD fusions. These are highly aggressive, poor prognosis tumours which result in expression and overexpression of the nut oncogene product. We've been looking at trials of BET inhibitors. These really haven't taken off really, are not really being developed further, so that we have an urgent need to develop our therapeutics for these patients. Future trials, a couple of things just to bear in mind, the last couple of slides, is that you should remember that mesothelin is expressed on thymic tumours, particularly thymic carcinoma, and there are a number of drugs being developed looking at mesothelin expression. So always touch base with your mesothelioma colleagues and phase 1 colleagues if there's anything targeting mesothelin ongoing. And finally, this trial is ongoing looking at combination of pembrolizumab with lenvatinib, the Pecati trial run by colleagues across Spain, France and Italy, and very much look forward to this data in due course. And with that, thank you very much for your attention and look forward to discussions.
Thank you so much for the interesting talks. I'd like to thank all the speakers. Some questions, Professor Papa, to you, because you were just speaking last, is you talked about looking at molecular markers. Now, these are guided by the Genomic Health England programme. So how do we go about getting these? Because there is no guidance, is there?
Well, NTRK testing is funded in the UK.
Yeah.
So, get your tumor NTRK tested. Now, your lab may have different ways of doing this, but some labs will give you your DNA profile at the same time as your RNA profile. So if you don't ask, you don't get. I always make a point of asking. Some people might want to classify their tumors as a lung cancer, and you know what you're going to get with those. Sometimes it'd be difficult to know whether it's a lung tumor that's invaded into the thymus or vice versa. So people do get DNA outputs through different mechanisms. Colleagues have suggested KIT mutation for the next round of the GLH implementation of the test directory. So we're hoping that that will be officially funded sooner rather than later. And we should always remember the NHS has funded whole genome sequencing for patients for whom there are no therapeutic options left. Now, where do you class there are no therapeutic options left? That's the eye of the beholder, but your GLH may or may not have whole genome sequencing set up. You've got to ask your GLH, where are they in the whole genome sequencing pathway? This is a standard NHS funded pathway. Some GLHs are set up for whole genome sequencing, others are not. It will be coming online, I think, within the course of the next few months.
That's good to know, thank you. Yvonne, there's actually a question similar to a case that you presented about that patient with the pleural diseases, and the question's actually saying, what are the panel's view on the timing of observation versus any type treatment for stage 4A disease with recurrent multiple pleural metastasis, given the long-term survival we see in these patients?
Thanks, Pooja. So, I think if you've got if you've had a period of disease-free, essentially after primary treatment, I think that was the nature of the question, then I would favour in a fit patient, if we've got localized disease, treating aggressively and not observing, because I guess what we want to do is we want to give them a further opportunity to be free of disease. If they're fit and they're suitable for a surgical resection of that would be my route, unless they were not fit. So if they weren't fit and you were thinking that they weren't suitable for another operation and perhaps had struggled with their initial therapy or had renal impairment or something, then you may want to watch and wait. And of course, the other thing is that although a lot of these patients are young and fit, I certainly have quite a lot of patients that are in their late 80s. And for some of those patients, another operation wouldn't be something that they would relish. So it's individualized, but usually I would want to try and treat as aggressively as possible. There's then a question about what is that time interval between their original treatment and recurrence. And it's actually, these are very different patients. So the sort of thymic carcinomas, we often haven't treated those in that aggressive way of debulking because of the nature of the disease. If it's a thymic carcinoma that's recurred very quickly, that's a very different situation, and we'd be talking about palliative treatments for those. But if it's a patient that's had a thymic epithelial tumor, a thymoma rather than a thymic carcinoma, and they've had a reasonable period of time, as they almost always do, I would want to treat aggressively again.
Thank you. Just picking on that time interval that you said, and going back to re-challenging, it is very different, the thymic cancers from our lung cancers. What would be a good time interval for you to consider re-challenging with the same chemotherapy agents that you've used in the past?
So for me, it's not just the time interval, it's also about the benefit that they've had in the front line. So you'll see that obviously not all patients respond, but if a patient has had a good response, and perhaps not just a good radiological response, but a symptomatic response. And for example, I've got a lady who responds very well with her myasthenia every time we treat her. So if there's a reason symptomatically, or in terms of the response that they've had, then my sort of threshold for retreating is probably lower. If you've got a patient who's had only stable disease and perhaps has then recurred within a short time frame of 1 to 2 years, I'd probably want to think about a different agent. So it's not like some of the other more aggressive malignancies when we would normally be saying, well, we'd be happy to retreat with a platinum agent after 6 or 12 months. For me, it's a little bit more nuanced than that, and actually the timescales are probably a bit longer than that given the nature of the disease.
Thank you for that. Andrea, a question for you. We've had a case that Yvonne presented where the surgeons had removed the pleural met and decided against adjuvant therapy because sort of pseudo-adjuvant and no evidence. So would there be any situations, or what situations would there be where you would like upfront systemic therapy before operating on somebody in current or advanced setting?
I think it all depends on the extension of the disease. So if you have a very bulky pleural disease and you are really worried that you may not achieve a complete resection, you're going to leave a lot of disease behind, I think that is a situation where probably I agree to start with some or rechallenging or any adjuvant or chemotherapy and then reconsider surgery. If it's more like a limited, isolated disease or minimal volume of pleural disease, I think that surgery should definitely be considered. And I think again, there's is a kind of discussions you need to have with your team and the oncologist and the radiologist, and look carefully at the scan and see what can be achieved with surgery, how extensive could be the resection, of course, in the context of the fitness and the age of your patient.
Thank you for that. Just picking up on the long-term survivors that we see with this disease, if we are using our, say, PAC up front and then operating and then unfortunately resection margin positive and needing radiotherapy, do you think we need to focus on the cardiac toxicities of all our treatments and building that in follow-up, regular monitoring, cardiac monitoring of some sort? These patients are going to live long. How can we keep them well? Question for anybody, really.
You probably need a radiation oncologist for that, but you're not often. Well, it depends on where the radiation field is. I mean, the concern is obviously around the coronary arteries, and you may not be going down that inferiorly. Often when you are giving radiation, it's a much more superior field in using IMRT, etc. So that it's a slightly different concern than it would be, for example, with a more proximal lung cancer where your field may be more extensive, but there may be patients where we are a bit more concerned about this. And of course, the whole area about cardiac safety is one that's evolving in the field of thoracic malignancies.
I guess, would that ever change the choice of your systemic therapy that you use up front?
For me, I don't think so, because a bird in the hand is worth two in the bush, right? So you don't know what's going to happen 10 years down the line, whether you've got a good actor or a bad actor in terms of the disease. So, I always say give the best treatment up front, then you've got control, then you can start worrying about the future, because you may not have a future if you're not maximizing the opportunity that you've got with you. I mean, that's my personal approach. I don't know whether Yvonne's got any other thoughts.
I think we've just been more mindful of it because we've had a lot of work with the lymphoma team, particularly looking at their long-term survivors, and obviously they have much bigger doses of anthracycline usually. And I mean, I guess the other thing that we've been mindful of is the additional toxicity from radiotherapy, from radiation, because of course we're scanning these patients, and we've been having some conversations about what sort of scans we should be doing because of the radiation dose from that. So I think we've been, as lung cancer oncologists and as thoracic oncologists, we're not used to thinking about long-term toxicities. And I think there's something that we do need to learn from our colleagues in other areas about what we should be doing and how we can be minimising the risks. I guess that there are probably some situations where if we've got very, very bulky disease and I'm going in with and it's a thymoma rather than a thymic carcinoma. I mean, these are the difficult ones, Sanjay, and I think those are the ones that we often sit in the clinic and say, mostly we're giving CAP these days, but sometimes we leave the anthracycline out if we have a particular concern with someone with a cardiac history that we are slightly more worried.
Thank you for that. I think that's it for this last session. I would like to take this opportunity to thank the entire panel and also David Gilligan for organising this meeting, and hand over to David for closing remarks.
Thank you very much, Pooja. So we've come to the end of our essential update, and I think that anyone who's dipped into either part of all of this will have gained some greater knowledge or understanding of thymic tumours. I know I've made many notes and learned lots of things, and I think the important thing that we can take from this meeting and move forward with in the specialist interest group is looking at some of the things that have come up today, like having gold standard pathways, like having specialist clinics, like having specialist information packs, looking at how we follow patients up and with what modality. There's lots and lots of things that we can do, and also looking to see how we can work with national and international bodies to put together some sort of network that will allow and sort of up the standard for how we look after patients with thymic malignancy in the UK. Just to update on a remark that I made earlier in my opening session, I've clarified with Dawn at BTOG that the presentations from this meeting will be available on the website, and there's no time limit, so they will be available long term, which is fantastic. And finally, I'd just like to thank everyone who made this meeting possible. I'd like to thank, of course, the speakers, the chairs, First Sight Media, BTOG Secretariat, other members of the Specialist Interest Group who helped put the programme together, and Dawn and Gina at BTOG for their fantastic support. And finally, those of you who took part and asked questions to make this a really, really stimulating discussion. So with that, I'm going to sign off and just note that there are further BTOG webinars as advertised on the slide there on screen, and hope to see you at them. Thank you very much. Bye.